check this. Check this. Hello. Mic check this. 1, 2.
Discussing about the soft markers of chromosomal abnormalities and first trimester screening. It's being presented by our own consultant, Dr. Neha Reddy. She is fetal medicine specialist at KIMS Cuddles, Kondapur. And to chair the session, I would request Dr. Madan Mohan. He's a consultant pediatricians at Hope Children's Hospital. And Dr. Amita Anderson, fetal medicine specialist, Yoda Diagnostics. And our Dr. Jayant Krishna, he is pediatric neurologist at KIMS Cuddles, Kondapur.
Hello, good morning, chairpersons and all the delegates here.
This is pointer, this button is pointer, this is slide changer. This is pointer.
This is pointer, that is slide changer. Okay. So without much delay, I would quickly start my session. I'm Dr. Neha Reddy, fetal medicine consultant at KIMS Cuddles, Kondapur. So I'm going to talk about soft markers in first trimester and how do we make sense of the first trimester screening. So first trimester screening, what is it? Just a brief overview. So this is a screening of the baby, of the fetus from 11 to 14 weeks. It starts with 3 main components. One is ultrasound for a fetal structural survey, biochemistry with a maternal blood sample to measure the free beta HCG and PAPE, and along with this maternal parameters, which are her history, her age, her BMI, and mean arterial pressures will be taken into consideration. So why are we doing all of this? What is the purpose of doing such an extended view? Why is the NT so important? So we all know the latest antenatal care routine follows an inverted pyramid, where the first trimester evaluations plays a major role in categorization of the patients or mothers as low risk and high risk. So it helps in screening of the fetus for chromosomal aneuploidies, also any fetal defects. As well, it screens the mother for the risk of preeclampsia, preterm labor, and fetal growth restriction in the later part of pregnancy. So ultimately, we are going to give a plan for further ultrasound surveillance, as well need for any invasive testing if required. So what are soft markers actually? So these are subtle non-structural findings which we see on the scan. They indicate an increased risk, but not an anomaly. So whenever they are present, we have to be alert and further plan has to be made. So there are 2 main components I'm going to discuss about. One is ultrasound and the other will be biochemical parameters and how to interpret combinedly. So first to start is ultrasound. So there are mainly 4 important markers which we are going to see during the NT scan. So one is nuchal translucency, second is nasal bone, third is ductus venosus Doppler, and fourth is tricuspid flow. So there are other minor markers as well, but we don't include them into first trimester screening. Rather, we put them as a alert and we just follow up them. So mainly I'm going to talk about the 4 important markers. So I am going to take you through a set of clinical scenarios so that we can better understand the interpretation of these markers, because theory will not be more helpful. So there are some few cases I have chosen for each of them. The first case is, she is a Mrs. B, 34 years old, primary consanguineous couple. NT scan, they came at around 12 weeks, 3 days. NT was 3.1 mm, but the CRL was 61 mm. So this was relatively very increased for that gestation. So we can compare in the So we can see here, the first picture is ultrasound picture of a normal NT where the nuchal translucency, we can can be seen here. This is normal. This is the basic picture which I got. This shows an increased NT, which was around 3.1 mm. So we have analyzed the other NB, DV, TR. They were all normal. There were no obvious structural defects. We have counseled the patient and we have explained there's a risk of chromosomal anomalies. We need to scan you again at early TIFA to rule out major structural surveys which may be evolving and can be seen by 16, 17 weeks as the earliest. So when we saw her at early TIFA, it was 16 weeks. There was unilateral CTEV, hypoplastic nasal bone. However, nuchal fold thickness was normal. But then because we know that there's a risk of Down syndrome and chromosomal anomalies, we went ahead with amniocentesis. We can see a FISH report which shows 3 copies of trisomy 21, and this has come as trisomy 21. So this was diagnostic. So here this case of increased NT had a cause which was chromosomal. Moving to the second one, this was 29 years old, gravida 3A2 with 2 early pregnancy losses. NT scan was done at 12 weeks, 3 days. We can see a huge increased nuchal translucency which was measuring up to 8.7 mm. And when we saw the other structures like CRL, grossly okay baby with increased NT. The second picture shows a proper nasal bone. The third, this one shows a dilated jugular sac, and this is a septated cystic hygroma. So with all this in the picture, we have explained her this is a increased NT. The prognosis cannot be said, mostly not going to be favorable. So they went ahead for termination, and the POCs were tested. We did for the basic QFPCR, for basic aneuploidy, 21, 13, 18. They were all normal. Whereas whole exome, they showed a genetic mutation on FOX2 gene. However, it was uncertain significant, but still this was correlating with the phenotype. So it was causing lymphedema distichiasis syndrome. So we have explained the report to them, advised preconceptional counseling before next pregnancy. So this case was a genetic etiology for increased NT. Moving to the third case. So this was a gravida for para 12 to 34 years old. NT scan was done outside at 12 weeks, 2 days. NT is seen to be around 2.2 for a CRL of 61. It was falling around 97 centile for gestation. Combined FTS was not done. She came for an early TIFA with us. So we could see EIF, nuchal fold was fine. There was no other anomalies. So we have explained again the increased NT, most chances of microduplication, genetic or chromosomal could be there. We can rule out by amniocentesis. So we did amniocentesis, a FISH was sent. Here we can see there are only 2 copies. And these 2 copies are normal. So this was concluded as a normal FISH. CME also, there was no clinically relevant copy number variation detected. So this was a normal, chromosomally normal fetus. Increased NT in this case could have been normal variant. There was DNA storage, but it was not very, there were no other evolving anomalies, so they didn't go for AWS. Now the baby is delivered, baby is doing well. So briefly about nuchal translucency, what is nuchal translucency? It is sonographic appearance of the collection of fluid behind the neck and under the skin, measured between 11 to 14 weeks of gestation, and a CRL of 45 to 84 mm. So we have to go for a proper mid-sagittal section before going for an NT. So how to measure NT? Briefly, I'm not going to very much detail. It has to be a proper magnified image including head and thorax and mid-sagittal view of the face. You have to see about nasal bone and palate separately. And then you can measure the nuchal translucency part behind the neck. And you have to measure always the widest part. So CRL is 2 types actually. Whenever we are talking about the increased NT, one is CRL dependent NT and the other is CRL independent NT. So CRL independent NT, we don't conclude what is a CRL or not. But whenever there is a CRL dependent NT, like we discussed the 2.7 mm for a CRL of 61. So there we have to correlate the NT and the CRL. So 2.7 mm would look normal for a 76 CRL. So we have to correlate the CRLs in CRL dependent NTs. Whereas whenever it is more than 3.5 mm, CRL doesn't matter. So why are we all worried about all of this? Because increased NT has seen to be associated with chromosomal anomalies, genetics, congenital cardiac defects, structural defects like congenital diaphragmatic hernia, skeletal abnormalities, lymphatic abnormalities. So we have to know that what is the amount of aneuploidies and defects that increased NT is associated with. So we can see that surprisingly, it is whenever it is less than 3.5 mm, only 3.5% are the aneuploidies. So we need not to worry when it is 3 mm, we need not to panic and advise them not a good prognosis. We cannot tell them. Still, we have to just work up and make sure that the fetus is doing healthy. Only when it is more than 3, the aneuploidy rate is increasing from 20 to 30 to 50, 60. And whenever we are seeing overall how many babies are alive and well after postnatal, we can say 93% of the fetuses with NT up to 3.5 mm are doing well. Only those 7% that we are scared for. So beyond 3.5, yes, you can counsel and insist for, but within 3.5, we have to be more careful about the counseling not to terminate. So ultimately, the majority of the cases of the NT resolves and the babies are born healthy after delivery. So briefly, what is the increased NT and how do we plan it? How do we plan the testing? Whenever it is less than 3.5, we can still give the combined FTS, give a patient-specific risk and follow up. When it is more than 3.5 mm, we have to go for an invasive testing. It can be a chorionic villus sampling in first trimester or amniocentesis during the second trimester. You have to follow up with the early TIFA and 20 weeks TIFA with echo. When it is persistent, the nuchal fold is still increased in the early TIFA also. Then you are looking at a more complex situation. There you have to also include molecular testing with whole exome sequencing and follow up the baby every 4 weeks. So in this category, 10% risk of perinatal death or live birth with anomalies can still be there even after doing whole exome sequencing also. So that thing we have to explain the patients. So this was about NT. Nasal bone cases, then case 4, Mrs. D, 32 years old, primary, low-risk patient, came for an NT scan. We can see this is the normal NT picture where we are able to see 3 lines. The second one is the echogenic nasal bone. When we compare this with this picture of this patient, we can see there are only 2 proper echogenic lines. There is no equal to sign which is properly formed. So we were suspecting an unossified nasal bone. FTS was run, which was low risk. And then option of NIPT versus amnio was given. However, we were more inclined towards the early TIFA, and then accordingly we can plan. But then early TIFA was, but they were very anxious. They went for NIPT. NIPT showed a aneuploidy risk of T21. So when they came with that report for early TIFA, we were able to see around EIF was there, multiple markers were there, hypoplastic nasal bone and ventriculomegaly. Then these all indicated an invasive testing for confirmation. When we did, we can see a gain at 21 chromosome around 33,000 kilobase pairs, which says that it is a trisomy 21 that is characteristic of Down syndrome. So this, they had to go for a termination, advise preconceptional counseling. So whenever hypoplastic nasal bone, always advise early TIFA for evolving anomalies. Invasive testing is indicated. NIPT is little dicey because it can be offered, but you have to explain all the limitations of NIPT because isolated nasal bone still in 3 to 4% of the patients can still be associated with the molecular micro deletion duplication. So always amniocentesis is the indicated one. The next case, this is 26 years old Mrs. E, low risk patient again. So here we can see this picture of this baby fetus. We are able to see again 2 lines are properly. There is no underlying echogenic line which is seen. And also RNT view also shows one is defect at this point where only one nasal bone is seen, the other nasal bone is not able to be seen. Then we did a FTS, combined FTS including the unossified nasal bone, but still she was falling under low risk only. Then we have advised early TIFA and accordingly we'll plan further plan. So she came for early TIFA. This is the early TIFA finding at 17 weeks, 2 days. Still the nasal bone not look very confident, very bright. It's very small and tiny. So it was a hypoplastic nasal bone. It was as it is an isolated nasal bone. We have explored everything, but the patient, as it was IVF conception, they were keen on NIPT. So NIPT is done. It came low risk. But still we kept following up the baby fetus throughout till 38 weeks, and recently 1 week back she delivered, and she delivered an absolutely normal baby. So it can be still a normal variant also. So briefly to assess, this is the FMF protocol of assessing. So what we have to know is it has to be mid-sagittal view of the face properly, as NT head and thorax has to be magnified. We have to be looking for 3 echogenic lines. One is skin, the upper one, the bottom one is the echogenic than skin, which is nasal bone, and this The tip of the front echogenic part is the tip of the nose. So we have to make sure that nasal bone and palate are seen separately. There should be no maxilla intervening in between. That's the exactly ideal way of looking at it, and the assessment will also be more perfect. So when do we say it is present? Whenever it is echogenic, then we can say it is present. But whenever it is not seen, or less echogenic, or similar echogenic as skin, still we quote it as indeterminate or absent. The same picture. So whenever there is an absent nasal bone, it is associated with 60% of the trisomies. That's why we are more worried about. But still, 1 to 3% of the euploid fetuses can also have absent nasal bone. So we have to just follow up and then conclude. So next, moving to the rest of the markers, DV and TR. This is a case 6, Mrs. E, gravida 2, paravan L1, previous healthy live baby, non-consanguineous couple. This was a regular NT scan where NT, NB, DV were normal. 4 chamber of heart were normal, but still we were able to see a regurgitation. What is regurgitation? It is a regurgitation across the tricuspid valve, which is sustaining more than half of the systole and crossing more than 60 centimeters per second. We can compare with the upper normal TR, where it is, we can see the velocity of the regurg is only up to 330 centimeters per second. Whenever it extends beyond 60, we conclude it as tricuspid regurgitation. So FTS was still done because it was only TR, the rest of the soft markers was fine. It was around 1 in 790, we make it as, conclude it as intermediate risk. I have advised early TIFA. Early TIFA we were able to see still the TR was present. Heart normal, but there were no other anomalies. So we have discussed the implications and NIPT was given. NIPT showed low risk for aneuploidies. Then again the follow-up, so we have followed up for 22 weeks TIFA with echo. Heart was normal, the TR was resolved, and now the baby is doing healthy. So that isolated TR, in absence of any anomalies, it is going to be a normal transient event. So case 7, this is 33 years old, gravity 2, history of diabetes mellitus and cervical incompetence and pregnancy loss in the past pregnancy. They were very anxious couple. Came for an NT scan. NT was normal, NB was present, but we were able to see occasional TR. Whenever we are doing a TR, we have to put across at least 3 times across all the 3 valves of the tricuspid valve. So one of the valve was showing the leak. Then we went on and assessed DV. So DV, we were able to see a small reversal of A wave with a high PI. So these are all things we have included in the first trimester scanning, and we could see a adjusted risk of trisomy 21, which was 1 in 227. So that is a intermediate risk for trisomy 21. So then we have advised early TIFA, but before that, as I already said, she had lost 1 pregnancy and she's a diabetic also. They were very anxious. They wanted to rule out before that if any information can be done. If it is low risk, they can relax. So went for NIPT, but unfortunately that was a high risk for trisomy 21. Then it had to be followed up for TIFA, where in TIFA we did amniocentesis. QFPCR also showed a aneuploidy for trisomy 21, and in CME there was a gain in 21, 3 copies of 21 chromosome, which is suggestive of trisomy 21. So inclusion of this subtle DV and TR refines the risk and gives a better calculation so that we can proceed in a better way. This is the last case. This Mrs. S, 34 years old, gravida 2, paravan L1, RH negative pregnancy. NT scan, NT was normal. NB was not so loud enough, uncertain. DV here you can see it is characteristically reversal of the A wave. But the 4th chamber, the most important the other soft markers were seen. Heart was also seen in particular. This seemed okay, like all the 4 chambers were seen, the cusp was seen, the valves are seen. Then FTS scan based only done because there was reversal. We have advised for a second look at early TIFA. So this is early TIFA at 17 weeks. So when DV reversal still was present, the heart looked like this. So we can see the 4 chambers of heart, right atrium, left atrium, RV and left ventricle. We can see RV is more echogenic and small. The color Doppler also shows a little bit of less flow across it. And the valve is also thickened. So we were suspecting query tricuspid valve dysplasia or hypoplastic right heart syndrome. The other features were also there. So we had to go for an amniocentesis, and amniocentesis showed pathogenic variant. 1P microdeletion syndrome and 22Q1111 0.2 microdeletion syndrome. Both were pathogenic and they had to go for a terminal. So whenever DAV and TR are there, always include in the risk calculation. They are markers for fetal cardiac defects also, always keep in mind. And in presence of two soft markers, always counsel, discuss option of NIPT or amniocentesis. So in view of shortage of time, I'm just skipping those. So DV is a small vein that connects the UV umbilical vein to the heart. So it's a marker for cardiac defects. So this is the waveform where there is a A wave positive. This is the A wave reversal. So whenever A wave reversal is there, you have to be more careful because 65% are aneuploidy detected. Rest of the may have cardiac anomaly, but still 3% could be a euploid fetus. So in about 80% of the cases, wherever reversal AV was seen, the pregnancy outcome was normal. So this we have to keep in mind and go ahead for the counseling. The next part is biochemical markers. So these are biochemical. There's a pattern. There's beta HCG and PAPA follow. So we have to, whenever we see a beta HCG which is high and PAPA which is low, we have to go. The risk calculation is going to be altered more towards risk of trisomy 21. Whenever both of them are going to be decreased, it is more of trisomy 13 and 18. So how is the interpretation done? Whenever we come to a fetal medicine unit, we take all into consideration. This all will give a final risk. This is starting from the history of the mother, mean arterial pressures, the ultrasound including NT, NB, DV, TR and the biochemical. Combinedly they gave a risk which we quoted as a trisomy 21 background risk, and after including all the factors it is adjusted. So one should concentrate on this adjusted risk. As I told earlier, preeclampsia, FGR and delivery risk is also there here. So this is the final report one has to be concentrating on. So integration will improve the detection rate up to 95%, which is close to very much good amount, with a false positive of 2.5%. So first trimester screening can still have false positives. So we have to follow up and then test and then only confirm. So whenever you do categorization, these numbers matter. Whenever it is more than 1 in 100, it is a low risk, we can follow them with a ultrasound. When it is more than 1 in 100, it is CVS or amniocentesis because high risk needs invasive testing for confirmation. Whenever there is an intermediate risk, one has to go for assessment of all these soft markers and then these matter, NB, DV, TR. And accordingly, you reassess them into high risk or low risk. If it is high risk, amnio. If it is low risk, ultrasound. So to summarize, presence of soft markers is not always diagnostic. It can be suspicious. NT-NB play a more role, but DV, TR also refine the risk. And in order to make sense, T or DV or tricuspid regurgitation, so both of these two will be taken into consideration, and also the high-risk pregnancies like twin pregnancies and advanced maternal age pregnancies, IVF conceptions, these all needs to be seen specially focused at fetal echo. However, it is better to have a fetal echo rather than missing a TAPVC and PAPVC after delivery. So we usually recommend in all of them, but absolute indications are those with positive family history or scan findings. Thank you.
Excellent talk.
Thank you so much.
That was a nice talk, Doctor. Just a question was that, as Dr. Amita said, that NIPT is also a screening method and you're doing this NT scan with double marker or EFTS now. Who are the cases you will choose to advise NIPT or go for amnio directly? Because now that she says there can be false positive in NIPT also, should we even do it? Or should we just go for amnio wherever you think that there's a high risk on screening? Just a discussion point.
Yeah, yes, I got it. So, NIPT versus amniocentesis. So, whenever a scan is done and the scan is clean, there are no soft markers, there are no anatomical defects, then we go for an obstetric history. Is it advanced maternal age, more than 35 years of age, or is it IVF conception, or is she having any previous pregnancy losses? All of this we have to take in consideration. Then if it is everything, no other positive history, and if she is advanced maternal age, we can go for a non-invasive prenatal testing because advanced maternal age also will unnecessarily give false positive on FTS. So those cases we can go for NIPT without any doubt. Or if you suppose you have a certain markers, so we have to again classify, is it a soft marker or is it a structural defect? Structural defects, always invasive testing, because we don't want to miss those microdeletions. Soft markers, we have to categorize them again. If it is NT and NB, always amniocentesis, yeah. NIPT can also rule out, but that small proportion, that 3 to 4% of the babies with just isolated NB, are they going to fall in that 3 to 4% or 96% of the normal babies? We don't know. So that's all going to be after delivery. So if the patient is affordable and going to come for the follow-ups, and it is a high-risk pregnancy with advanced mental age and IVF conception, we can still consider NIPT after explaining all the limitations. These limitations always have to be explained now. Because I have come across one case where NIPT was low risk, but the baby had Down syndrome after delivery. Unfortunately, that was a doctor couple. So these things we have to tell. And whenever there is increased NT or cardiac anomalies or any structural anomalies or previous history of Down syndrome, it is always better to incline towards invasive testing. I know we have the risk of miscarriage, but still in good hands and experienced, skillful specialist, they can go well. I think Amita ma'am can add if anything is missed.
Yeah, one more thing I think I would like to mention is that upfront fetal sequencing is nowadays very commonly done. Upfront fetal sequencing. So none of the bodies, none of the organizations actually give a guideline to do direct upfront fetal sequencing, because whole exome sequencing without a clear fetal phenotype,
Yes.
again you'll have, it's a double-edged sword. You'll have variant of uncertain significance you don't know what to do with. Even if you see ACMG and ACSG, both of them do not recommend upfront whole exome sequencing. Only when karyotyping and CME is negative, when you have a clear phenotype of the fetus, then only go for whole exome sequencing. I think that is very commonly done now. We have variant of uncertain significance and going for termination up front.
Yes, I agree with that. It is always a sequential. It should be basic followed by advanced. Because if we are caught at basic, there's no sense that we're doing an advanced test. So it has to be KT or CMA, depending on the findings, followed by whole exome only indicated. Because just a random whole exome, patients do ask, can we just do a whole exome? It will be reading all my genes. But that doesn't how it works, because at times most of the times we get uncertain significance where we are not able to tell them will it affect or will not affect. Unnecessarily they'll be in a dilemma.
Instead, I think we should offer them expanded carrier screening, well in before.
Yes, first trimester would be the best time to offer preconceptional or first. Thank you so much.
Thank you, Dr. Neha. I hope we are clear about the soft markers and the first trimester screening. I think the take-home points would be the soft markers needs a proper follow-up and termination. They can be, a normal variant. Okay, so it needs a proper follow-up, and we should not go ahead with. Should not be an option for termination. So thank you, Dr. Neha. I would request Dr. Madan to present memento to Dr. Neha. I request Dr. Amita and Dr. Madan and Dr. Jayant to please continue chairing the session for the next talk. So next we have the recent advances in fetal structural cardiac defects. Because such tiny hearts and big decision to make, let us see what are the recent advances. To deliver the talk, I request Dr. Sudeep Verma, who is consultant pediatric cardiologist at KIMS Cuddles. He is with Kondapur and Secunderabad branch. Over to you, sir.
So good morning, everyone. Thanks a lot for giving me opportunity to talk. See, as Dr. M.M. Rao sir told, fetal echo is an important and integral part. Even after TIFA, sometimes some of the disease may be missed by initial days and even missed by the experienced cardiologist also. So how to suspect and all, and how to that, what is the impact of that? So I'll explain some 7-8 cases how the impact of the prenatal diagnosis guided us to do the therapy and having the good outcome. So see, these are the common scenarios which come to us. Diagnosed to a muscular VSD is small, they want to terminate. after TAPVC, coronary abnormality, AP window, couples got you were not diagnosing it before, because these are the common things even which was missed by the all even experienced people also. ASD PDA persisted. Even we tell the PDA, they will come and fight with you. Ki, why you not told PDA? In spite of explaining that ductal cytosis is the normal part of the fetal shunt, in spite of that, they tell why it not diagnosed before. So initially normal, but now over the period developed arch hypoplasia, semilunar, because there is a ongoing, because these are the evolving lesion, and the rhythm abnormality, cardiomyopathy, they can develop even the third trimester later also. And if the diagnosis of TGA, coag tape is what to do, whether to deliver in the proper center in the periphery or they have to in the tertiary center. So it's a very common question as a cardiologist will get repeated. We have to answer all these things. So these are the various factors which prompt the fetal echo. I won't go into that. So even when we come to the fetal echo 10 years back, we all used to follow this because they are all the very famous with all the flashbacks started. So because when we come to know the neonate, we have to ask the history, what is the history before. So now recently we remembered 1 year back, then patient developed with the severe RVH and severe RV dysfunction, pericardial tamponade. When we found out the mother took the high dose of paracetamol 3 or 4, just 1.5 months, it called the ductus restriction, and that causing the severe RVH and the failure. So many of the information of the fetus will develop of the neonate, you have to inquire about the fetus in between. So that's why how the fetal echo evolved. So now we have to do more with the fetal echo so that we can guide our therapy in the neonatal age. So these are the lesions which evolve, because this is very important for the counseling. Semilunar wall, arch narrowing, cardiomyopathy, which will evolve over the period, which may be normal, but once they come to the third trimester, which lost the time period of the abortion if they want, but it evolves over the 28-32 weeks. Second thing, rhabdomyoma also, they may develop only in the third trimester sometime. Evolve, which was diagnosed, but evolve over the period like TOF, which was not severe TOF, but till the time baby developed into pulmonary atresia, aortic stenosis, which was mild, which developed to the severe. So now these are the various situations we come across our routine practice. So this is the crux of that for the everyone who are doing the fetal echos and how to counsel. Blue is the one which has got the very good outcome. So if you found out VSD, large SD, common atrium, PABC, you can easily tell you can continue. If no other genetic syndrome, you can continue. This got the almost curable. In present era with the present surgical and intervention techniques, it's almost a curable 99% surety we can tell the baby will have a near normal life. Second is the TGA, TAPVC, these all depend on the promptness and outcome. If you diagnose before, deliver in the center where the surgical outcome is there, that is the yellow. So it's a depend on the promptness and the presentation. If very late presentation, that will be difficult. But if you diagnose this, still you can give a good prognosis considering considering socio every status. And then third is the very dismal prognosis even during the multiple. So if you found out HLHS, heterotaxy, pulmonary atresia, PA intacti, sinusoid, so these you can even, because they come directly and ask you whether we'll abort or not. So the first answer, my job is to give the option. Rest you have to decide. But if the third category is there, you can tell okay, it's better to avoid because the journey for that baby is very dismal. There is multiple intervention. Even after that, the prognosis is very bad. So if you diagnose your whatever lesion you are diagnosed, if you divide into 3, blue, yellow, red, then your counseling will be much better and you can decide the outcome much better. So fetal echocardiogram. See, there is an impact. What is the impact? So, these are the common referral: echogenic focus, chamber asymmetry, mild TIA, LSVC, usually drop out, and URSA. So, these are the common outcome, and even half of them are the normal variant. We don't have to worry about that. But URSA, they are coming nowadays. So, we are telling it may be associated. They come with the whether will deliver or not. So URSA even in the adult only 5 to 10% develop with the obstruction to the trachea and esophagus. So 80% of the URSA will not have any problem. So you have to give that exact figure. Even if the URSA is there, they may develop as a vascular ring later, but it developed only in 10 to 15%, 80% it will not cause any problem. Okay, so lesion with robust data, these are the 4 lesions which shows the robust data, how the prenatal diagnosis impact the outcome. So HLHS, mortality, if you diagnose prenatal, you have to deliver in the center, you will start prostaglandin in the intervention. and you have to do surgery on the first day. But in India, only 1 or 2 centers are able to produce a good result for HLH. Still in India, if a HLHS comes to a hypoplastic left heart, we are telling it's better not to continue because the outcome, and even there are no better surgical center which can able to do the very good outcome in the HLHS. But the robust data shows if you diagnose before, it has got the better outcome in the postnatal life. Coarctation, it has got the very positive impact. If you know from the postgrad, we have 2-3 cases where we diagnose postnatal coarctation, prenatal coarctation, we deliver second day without starting prostaglandin, we operate on the third day, and now the child is doing good. So that unnecessarily reduce the burden of the risk and reduce the burden of the intervention, and directly we can go for the surgical or intervention. TGA, this is one of the main important topic where if you do the zero preoperative mortality in the prenatal group, the studies show, there is one Indian study from the Amrita Institute where they showed if you do in the good center, the mortality is almost 1% only, 1 to 2%. There is no difference. So almost 0% mortality if you diagnose before, and to do the in utero transfer and they try to deliver in a center which has got the better outcome. So that's how it impacts the. So this is the one, that same paper, you can see the prenatal diagnosis. If you do, there is the chance of 0.01. That means the outcome is much better. So in spite of that, they told prenatal postnatal no difference. But if you do in the specific center where the cardiac abnormality is getting treated, the outcome is very good. Even if you do in the center where the cardiac anomaly, where the cardiac surgery team is not there, the outcome is like a delayed. So that's why you have to diagnose such cases in a place where you can do the immediate surgery or the intervention. So place, and this is very common question, all obstetricians are asking where to place. So it's only these 3-4 lesions which are the duct dependent lesion, VSD, pulmonary atresia, HRHS, critical PS, or the TGA you have to deliver in a tertiary center, but otherwise most of the lesion you can deliver in the periphery, and then you can transfer and you can send us for the further evaluation. So there is now again the impact. Why this impact is important? Now the fetal intervention also coming in a big way. So even the aortic stenosis, pulmonary stenosis, evolving heart block, you can do the steroid, you can do the immunoglobulin, you can do the PBAV or PBPV, and that you can got the good result. So there are the various fetal interventions. So So these are some gray zone. Even I am very good to admit that these are the lesions which I miss in my practice. TAP-BC I missed twice, AP window I missed twice in my practice, muscular VSD so many times you miss. Even everyone has got the same experience. Vascular link, sometimes PS link. So once we are telling, so this is a disclaimer should be there, that these are the some lesions which can be missed. Even coronary abnormality like anomalous coronary L-kappa, sometimes you may not able to diagnose. So these are the lesions which has got the significant, got major impact, but you have to tell if they are coming, you have to diagnose, and this can be missed, but these are the treatable and the curable lesions. Okay. So why we need the prenatal? Because these are the various procedures which we are doing on the basis of our fetal diagnosis. PG infusion we have to start for the duct dependent lesion. PDA stenting, yesterday also we did in the night for a 1-day-old with a VSD pulmonary atresia. In the night we did PDA stenting. If we know it from the beginning, we can prepare better. And we started PG. And then transumbilical intervention, we can take the advantage of transumbilical access and do the intervention, surgical correction, and the arrhythmia. This is the one of the very important field, arrhythmia management. If you do with the hydrops, even with the severe hydrops, if you are able to diagnose arrhythmia, you can have a very good outcome. So these are the cyanosis, which is the most common problem, which can have a very bad outcome, but needs to be detected before and to be delivered in the tertiary center. So I won't go. So this is a 32-year-old, gestational age 28 weeks, referred in abnormal 4-chamber. You can see there is a coarctation. So what we'll do? So this, even after book, they come after delivery outside and they come to us. On that day, she was in shock. So what to do? So when we diagnose, we expect it's a good prognosis, but you have to deliver in a proper tertiary center, need for the process. But they come very late. So at what time? They came in the night in the very bad shape. So what we thought, we will do the intervention at that point rather sending for the surgery. So we took the advantage of the umbilical artery and we did the balloon dilatation. And you can see with the balloon dilatation, the coarctation, we were able to just relieve some coarctation so that the child sustained for 10-15 days, and after 2 months we were able to do the surgery for that. So this child with the balloon dilatation, the lumen improved, extubated on day 2 of procedure, discharged on day 7 and underwent surgical, because it's a very elastic, recoil is very high. So then again there is a high chance of recoarctation, but we tied over the crisis. After 2 months we did surgery and the child is doing fine. Same 28 weeks gestation, 28 years, 28 weeks referred for fetal echo. You can see what is there. The right side of the heart is very muscular. So this is like a evolving, you can see, this is like a very stenosed wall. So this is like you can see the right side is hypertrophic. What they also is the pulmonary atresia HRHS with intact septum. There is no VSD. So they present in a much worse way. So what we did, in utero transfer, we do duct dependent pulmonary circulation, but she delivered prematurely in some tertiary hospital. But they started prostaglandin and sent to us. So the birth weight was only 1.2, requiring PPB. You can see the oligema is there, and this you can see the heart right side is very small. And severe TR in the RVOT is also, if you see the diagram, it's like this. So what to do? So what we did at that time, we immediately took them for the intervention from the IJV. You see there is no pulmonary wall antegrade flow. So we did the perforation of the wall and then we did the balloon dilatation. So with that successfully, you can see the graded balloon dilatation, we can able to achieve very good result. And discharge, but he developed, because of the low birth weight, he developed infection and all, but he stayed with us for 1 month and discharged successfully. Now he's on follow-up, but because of the balloon dilate, developed severe PR. So now waiting for the next surgery after 2 to 3 years. So even you can see the timely intervention, in spite of that prenatal diagnosis, they delivered prematurely. The outcome may be dismal if you not referred on time. So 8 months follow-up. Third, 35-year-old, 26-week gestation, conceived a year after marriage. You can see this is the first case what we did for Dr. Nageshwara sir at that first time. This is a severe aortic stenosis, you can see, and it developing HLHS. It's a very hyper-echogenic LV and there is a severe LV dysfunction. You can see endocardial fibroelastosis already said. So what we did in now, the era of the fetal intervention also come into the picture. So we explained everything because it's a precious, maybe 8 years after infertility treatment, so they want to go ahead with the balloon dilatation. So we did with this, and see this is the detail into that, and after that this is the pictorial diagram how we'll do. We'll go directly, but the only thing is the good anesthetics and good ultrasound fetal medicine required, because when the child is only in the front, not the spine. First time we tried for so many times, but child is unable, the spine was anterior. So again we have to cancel it. We did after the next day when the child, the chest was anterior, and then we able to did the procedure. So this is the one thing, and you can see after that you can see the LV improves very much. Okay, the endoclastic fibrosis was there, but the dysfunction improved, and over the period she improved. And after delivery again, but what happened? These are the lesions which have got the tendency to recoil and again to do. So you need multiple dilatations over the years. So again, at the age of 3 to 4 months, we did the severe balloon. They developed like a granular appearance, dysfunction, and we did the balloon. And after that, now she is still having the moderate AR, but we have to follow AR. It's almost 8 to 9 years old now, but need to go for the aortic wall repair or replacement in the future. But in spite of that, you see, which has got the LV dysfunction, endocardial fibroelastosis, we developed it into the just and developed. Now the child is 10 years old, at least asymptomatic for that AR and AS. So these are how we have to develop, and this will see, if you see the balloon dilatation, the LV length, width and mitral annulus will improve. But this has to be done before 30 weeks. After 30 weeks, the recommendation, there is no point, you can just deliver, because the outcome in spite of neonatal is same like that the fetal. So before it develops the 30 weeks, you have to do that if the endocardial fibroelastosis LV dysfunction is there. So there are the various procedures, 28-week gestation. See, this is one of the very important case. You can see it's going, the confluence is not seen, the distance between aorta and the LA is very high. This is one of the twig sign. You just see the one of the twig is going, but there is no connection. One of the very important marker, once you see the comedone ridge, the ridge seen in the LA, between LA appendage, if you find out that, that means it ruled out TAPVC. Here we are unable to see that ridge, and there is an increased gap between the aorta and the LA. So this is, you can see, is going down into the portal vein. This is the descending vein. So if you see, this is like a descending vein going down to the portal vein. So this is the infradiaphragmatic TAPVC. We know, because this already diagnosed by fetal media referred to us. So what we thought, because this anyhow has to go, so we delivered, and immediately after birth, okay, we did the surgery. You can see, we took and just take after 1 hour into that, and the same placental blood we use as a bypass prime for blood we use for the bypass. So after that, the now child is around 10 years old doing fine. So even you see the impact of the diagnosis. If you do, you can able to plan and you can call the multi-departmental, multi-specialty approach to give a good outcome. Okay, so like this 4 hours old, surfactant, no improvement. In the same way, this was not diagnosed. This done fetal echo but turned out and referred as normal. But once they developed it, the white out chest lung, and we found out it is supracardiac obstructed TAPVC. So what we'll do? So again at that point, it come in a very bad shape, almost arrested condition. So what we did, we took the advantage of the umbilical vein and did the vertical vein stenting immediately. And after 20 days, we sent it for surgery. The child improved. So what comes as a arrested condition, we able to do. But here, even the diagnosis was missed in the fetal echo also, because that's what, because sometimes the area between the confluence and all is so thin, you're not able to see. Sometimes we did a coronary sinus, but that is the TAPVC to the coronary sinus. We thought it's a LSVC dilated. So these are the very percent. So SLE mother, you can see we diagnosed what to do. It developed percent. So SLE mother, you can see we diagnosed what to do. It developed, everything was done, but in spite of that we know. So we did the trans umbilical pacing here. And after that, we change it to the pacemaker, permanent pacemaker. This has got the very good outcome. Now child is coming 8 years and now waiting for the next PG replacement. So even if you know the child developed that, you can able to do that. Now the reports are coming even when the PR interval is prolonged without developing heart block. Even the LV dysfunction, that you can give the intra immunoglobulin in the ascites so that you can able to reverse that endocardial fibroelastosis. So this is the same way. You can see the tachycardia, flutter. Okay, this is again no maternal risk factor. They come to us with the reversal in the A wave, and that causing the heart rate of almost 350. So that is we give the sotalol, and we started with the fetal medication, and then the fetal tachycardia improved. So this is 240. You can see. So this is after, again this is another case, 420, flutter rate is 420. So in such cases, this one developed hydros. So all three, we did the fetal medicine. This is the usual. You have to do once the flutter, you have to start with the 2 drugs. One the normal SVT 1:1, you have to start with the 1 drug and then you can escalate. So in flutter we started sotalol, digoxin, and after 2 to 4 days the heart rate improved. Because the flutter will take time to improve, first we have to control the heart rate. Here the heart rate was controlled and then we have to convert into the normal sinus rhythm. So this is the various how to do sinus bradycardia. This has got the most common cause is long QT. So you have to, once the sinus bradycardia, you have to rule out the long QT also. So digoxin, this I want our protocol. On follow-up, this both patient now got the normal. The last, sorry. This what happened, this developed ascites, but we found out there is a IES septum restriction. It was an aneurysm, so there is a restriction of the PFO that causing the, but already the fetus was 34 weeks, so we delivered after that, it's not a problem, we able to manage medically. So multiple rhabdomyoma, now the everolimus is the good drug which has got the restriction. If it causing the LVOT, RVOT, causing the tachycardia, you can start the everolimus so that it will get reduction in that. So this is the one, restrictive ductus, you get the received 3 doses of indomethacin before and then, or the crocin, and it developed that. So this is the one, cardiomegaly developed with the RV dysfunction. When we did the retrospective, mother took the paracetamol for 3 to 4 days in 6 weeks back and developed the severe RVH, and even on the just after the 2 hours of you won't see the PDA. That means the PDA was already prematurely closed. So we manage it medically, developed the pericardial tamponade after that so that it got improved. So once you know the history and once you know that, you can able to manage it very well. So this I already told. So these last two, in utero transfer is important for TG obstructed, duct dependent lesion or the critical AS or severe coax, so that you can plan your thing better. Cardiac condition, that case fetal is restrictive foramen oval, AVVR, high output state or decreased myocardial function, cardiomyopathy or because of the premature ductal or arrhythmia. So right heart dilatation, DD is restricted foramen, ductus, AVVR, LVOTO, HLS, left heart dilatation, PA intact IVS, tricuspid atresia, DILV. So a disproportionate chamber is an important finding, but remember the 3rd trimester mild disproportionate is a normal, but you have to rule out everything, coarctation particularly. So these are the common questions. Why it happened? No one in our family is CHD. Some died, genetic. Tell us whether we to go for abortion. How much chances for another baby? So if you see the first slide, the three, then you can able to answer which has got the good outcome. So counseling is important. So communication, we have to tell everything. What Neha also told, we have to tell everything. What is the risk involved? What is the outcome that you have to do? So this is the last slide that again I'll this you have to remember when you are doing your practice, this is the outcome, because they directly ask you what is the outcome, what is the chance to giving that. So with that, thanks a lot for your kindness. Sorry for explaining.
Thank you, Dr. Sudeep. So I think except for few the cardiac lesions you mentioned in the red box, majority of cardiac lesions are treatable. And with prenatal diagnosis and wherever possible to do an in utero transfer in a center where it can be managed, it has been shown that it improves the outcome and the survival of the baby.
But one thing I want to tell, there are few lesions that are curable. You have to explain the difference between curable, treatable and not treatable, not curable. So blue one is the curable. Once you close the VSD in a proper setup without any complication, ASD, common atrium, PP, they are almost curable condition. Other, depending on so many other factors, TOF, TGA, truncus, they depends on the conduit, they may need 1 or 2 surgeries. So you have to tell that they are curable, but they need to be followed over the long term, lifelong maybe. But these are the curable, and they ask specifically, can child will be normal? So with curable, you can tell child will like a normal with any one of us. Treatable, it will be near normal. He can do the almost all activity, but some you cannot be athlete, but you can do the normal what we are doing day to day life. So we are explaining exactly like that he can't be athlete, but he can live a normal life like all of us. He can do whatever he wants. So you have to categorize your lesion into curable, treatable, not treatable. Then your counseling will be very easy, and you are able to question it very well.
Right. Thank you, sir. So now I request Dr. Amita to give memento to our speaker, Dr. Sudeep Verma. Thank you, ma'am. Thank you, sir. Now I request Dr. Aparna to hand over the mementos to our chairpersons. I request Dr. Madan to come onto the dais and receive token from Dr. Aparna. Yes, sir. I request Dr. Aparna to give memento to Dr. Jayan. Thank you, ma'am. Thank you, Dr. Jain. So moving on to next session. Now we have very interesting session. It's the ethical perspective about fetal rights versus maternal autonomy in the structural birth defects. So we will see the ethical perspective of it. So for that, I request Dr. Yoga Nagendar, who is consultant pediatric surgeon at KIMS Cuddles, and Dr. Amita Anderson, consultant fetal medicine specialist, Yoda Diagnostics. Over to Dr. Yoga Nagendar.
Good morning, everyone. I'm Yovana, the pediatric surgeon of KIMS Cuddles. Today we are going to discuss about actually fetal rights. Let us debate actually with my close friend actually Dr. Amita. And fetal rights is a very important topic actually, which is most often actually neglected in especially peripheries. So in cities, at least actually we have some control. Actually, there are some bodies which will control us. But unfortunately, in peripheries, actually, there is no much control. Actually, mother can decide, anyone can decide, actually, mother-in-law can decide, or anyone can decide, actually, whether this baby can live or die. So, actually, irrespective of the mother's wishes as well. So, that's why we started with, actually, fetal rights campaign. Actually, in Telangana, we started, actually, right till now, actually, we have done in some 7 districts, and we are going to continue in all the districts. And soon, we are going to extend it to the, all over India. So our journey will start anywhere from actually antenatal to neonatal to pediatric age group to adolescent, but really it will start from the mother's womb itself. So fetal rights, and we have so many success stories actually which are most often neglected. And correctable, I divide the malformations in 2 types, correctable and non-correctable. Non-correctable, frankly speaking, actually God is the one who will decide. We need not take much of decisions actually regarding that. The moment birth defects are detected, actually, they're definitely a nightmare for a mother especially. Of course, the family, but for the mother, it is a real nightmare. So in antenatal counseling, literally, we have to prepare the family for how things should go on, and all these things should be decided. So once the baby is born, actually, the family and the mother should be ready to proceed and to handle the baby very well. This is what is expected in antenatal counseling, which we do very well. So I don't know whether this bottom line, actually, I disagree with Dr. I don't know whether I'm agreeing or disagreeing with Dr. Amita, but fetal medicine, I don't know if we should really thank them or we should really curse them, because you people are detecting so many minor changes. We should appreciate your knowledge and skills, but unfortunately, they have become too much. So to such an extent, actually, a small polydactyly will be there. That is the indication for termination of pregnancy, which is not at all acceptable by the public. I'm not talking about the fetal medicine people, unfortunately. So the moment fetal diagnosis is done, so many options are there. Where we'll deliver, how we'll deliver. So all these things are there. All these things we'll be discussing in the antenatal counseling session. And medical term indications, yes, all of you are well aware of it. We are not going to talk about it. But what is important is ethical termination. What are the indications? There can be family issues actually, which unfortunately as doctors we tend to ignore. But this only the family knows. There are many financial reasons. And thanks to our government or our Indian medical system, any surgery can be done from 0 to 10 to 20 lakhs or 50 lakhs as well. So there is an option for them. Actually, it is for them to decide actually what they want. And disfiguration. Unfortunately, in Indian scenario, it is still an important ethical topic to be discussed about, to be thought about, kept in the mind, which every family keeps it. At the moment some cleft lip or something is there, they'll be thinking about disfiguration. Of course, posterior valve, when it is diagnosed, how severe it is, and is there an associated oligohydramnios or not. And meningocele, meningomyelocele, actually till the baby comes out, we really don't know, because meningocele has got a lovely result, lovely outcome. And if at all, if it is associated severe hydrocephalus, 2 majors, yes, actually it's an indication for termination. Bladder exstrophy complex, this I added because actually I know actually how the outcome is going to be. It's up to them. So all these things actually we know, actually 2 main things actually which needs early referral and in utero transfer will be esophageal atresia and diaphragmatic hernia, because in transit itself there can be mishaps. So postnatal, there's a good teamwork in most of the hospitals, especially in our KIMS Cuddles. Actually, we have a lovely coverage of all the subspecialties, as you can see. And there are many conditions actually which need to be operated immediately, but not all conditions need immediate attention. So it is parents can have some time, actually they can decide actually when they want to do it. So there is no hurry for them to proceed. So there are many conditions actually which require a surgery at a later point of date, as and when actually seeing the progression of the disease. Something like event transition also, actually we need not be in a rush. Most of the renal anomalies, actually, we'll just wait. We'll see the progression of the disease. The progression of the disease is the one which decides actually when we should operate. So anrectal malformation, so many types are there. So, but a low anrectal malformation has a near normal life in 15 minutes in a pediatric surgeon's hands. So after that, he's going to have a real normal life. So for that, should we really terminate? That we should explain to the family. Low anrectal malformation, it's a one-time solution, beautiful solution, actually, literally no result, no problems at all. And we really don't know, actually, this fellow has got anrectal malformation also. So, truly speaking, it's a 15 minutes procedure. And nowadays, we are doing single-stage procedures, and with which we are giving a beautiful results. Hirschman's earlier, once upon a time, colostomy, stoma, all these things are there. So nowadays, actually, we are trying to do a primary single transcendental pull-through. I always tell the family, actually, within 10 days, you are going to have a lovely result in your family. And CDH, safe transfer is the most important thing, actually, medical stabilization, yes, all these things are there. Which is this slide I kept because actually it is most often discussed. And the moment it comes, actually, many people, they think, actually, maybe I cannot afford, maybe my baby won't survive. Yes, there are around 75% good success rates. 25% is because it is transferred from somewhere else and it is coming to our center at a very later point of time. So in this patient, actually, if you can see, by seeing this, most of the fetal medicine or someone, definitely it is a poor prognostic factor. In fact, actually, this patient is treated by Dr. Amita and myself when we are in Apollo. So this patient actually is being counseled by many people, not by us, many people that actually, yes, this patient is going to have actually a very bad prognosis, actually better. So I was the only fellow in city actually who told, no, actually let us give a chance. And then actually this patient survived. And frankly speaking, my name is Yog Nagendra. Actually, he named after this Yogi Adityaram wouldn't have been alive today if not for me. So, coming to the diaphragmatic hernias also, actually we have latest technologies. Actually, nowadays, actually, we as much as possible, we are trying to do thoracoscopy. Beautiful results. Actually, you should be seeing. Actually, at least the nipple is looking horrible in that scar. Actually, means it is so beautiful. And even in eventration, actually, we are doing thoracoscopic repairs. And posterior valve is one condition where actually we have to prognosticate and plan. Actually, together, actually, we have to sit together and then we have to decide. And then it is, of course, family's decision, provided if it is pre-TIFA age. Hydronephrosis, so many things are there, but we are giving a beautiful laparoscopic pyeloplasty, and KIMS Cuddles, we have a robotic pyeloplasty as well. Beautiful scars and lifetime, one-time solution. We are doing laparoscopic and we are doing robotic pyeloplasties. Why are we discussing this topic actually about fetal rights? It is in this era of from open to lap to robotic, what we are talking, actually we have advanced so much, but still we are talking about fetal rights killing the baby. Unfortunately, in my 25 years of practice, I have seen many, what I used to see is there is many number of babies who are born, actually many newborns I used to see and 25 years back. But nowadays, actually, literally the numbers have significantly come down, unfortunately. So this is one example I want to tell. Actually, biliary atresia, once upon a time, 25 years back, I worked in prestigious government institutes also. So there, that policy is, okay, liver is bad, actually, just close it. Take a biopsy and close it. So, means baby will die in another 5 months, 6 months with portal hypertension or with bleeding or something like that. Okay, that is the end of the story. But nowadays, actually, things have changed. Actually, in the last 2 decades, many people are doing Kasai operation so that it will be a stopgap, because nowadays, the liver transplant unit, we have a liver transplant KIMS Cuddles, and it is so good and giving a real normal, near normal life to the families. So, future of pediatric surgery, anything is possible. We should think twice before making any decision. This patient, yesterday, they have sent me a picture telling that actually in yoga, she got the first rank, first prize in Kolkata. And she is a survivor of coldoccal cyst. I took their permission as well. So we should be the voice for these unborn patients. Actually, let us defend their lives. They have no right, and it is our responsibility into telling and teaching the antenatal counseling we have to tell them, yes, this baby may do well. Actually, maybe if I show them this picture of some yoga success stories and all, something like that. No, it is our responsibility as the doctors treating with the newborns or unborn children to take care of these unborn children and then defend their lives. So this is what actually I want to discuss, and every fetus has got a right to live. So it is not us who should decide actually whether this baby should die or not. So even the parents. Thank you.
Thank you, sir. So now I request Dr. Amita Inderson to enlighten us about the ethical perspective about maternal autonomy.
So, following Dr. Nagendra's talk, so I don't think all of us would be here today if we did not believe that every fetus requires a chance. So, I'm going to cover very quickly some fundamental concepts of fetal rights and maternal autonomy, a few ethical dilemmas that we face on a day-to-day basis. How are we going to balance this controversial topics, and we'll discuss a few real-world scenarios also. So let me ask all of you here, do you believe the fetus is an individual? Can I see a show of hands? Is the fetus an individual? Half. 50% believe. Then why are the rest of you here? Does it have a right to live? Does the fetus have a right to live? Every fetus. Does every fetus have a right? Less than half. So I assume that the rest of you believe that it is better not to take a chance. Is that so? Well, I am here to say that we need to give every fetus a fair chance. You see this picture here? All of these pictures is about that kid out there doing some funky stunt there. Swimming is in athletics. Plays tennis is the school pupil leader. That is my son. He was born with talipes. And he is here today because there was a person who gave me the confidence to go through that pregnancy. I come from a doctor's family. Both my in-laws and my parents are doctors. They asked me, do you want to continue this pregnancy? There was Dr. Suresh and Indrani Suresh in Mediscan who told me, it is a correctable problem, it is an isolated problem, child will do well. That is that child. He is my first son, his name is Rishi. So do we give the children a chance? I believe we should. So when we are talking about fetal rights, one side we have the legal claims, the legal aspects we are afraid of, and there is a moral dilemma. Inherently we want that life to survive. On the other side, there is dilemmas which are created if it is a very early stage in development. And as Dr. Yoga Nagendra said, with all of us fetal medicine people, we tell you things very early. We give you choices very early. So then parents are like, do we take a chance? Do we take a chance? That is the question. And it also depends on the maternal well-being. If it is something that is going to cause a problem to the mother, then yes, that is a totally different ballgame. So when we are talking about fetal birth defects, it is not the fetus or the mother individually, but we need to consider both aspects. There is, of course, the women's rights to make a decision, but I think the most important word here is informed decision. She needs to know what the condition is, what it involves, and what it is going to become. So that is important, and we do need to respect the choice of individuals. That child with the polydactyly, that was a parent's choice, I believe. So when we talk about respect for autonomy versus protection of potential life, yes, we think of pregnant woman's autonomy because she is going to live with that baby lifelong. We want to protect that life, and it is a very, very taxing and difficult balance between the emotions and tensions that are there. So to put these things in perspective, we have certain laws in our country. Every part of the world, there are different legal variations, and this also reflects our cultural and societal values. I'm sure in our country, in our city, we see different societies, different cultures where they have a different outlook towards pregnancies, different outlooks towards babies with abnormalities. So we need to balance the fetal and maternal interests and our legal framework. Here, I think the most important will be our MTP Act. This shapes how fetal birth defects are handled. It influences the choices of the women who are going through pregnancy, as well as our medical decisions. I think you all understand the ramifications. Just as I said, whether it's an early pregnancy, whether it's a little later in pregnancy, is it legally allowed? That is the question that is often asked. So our MTP Act has been amended recently, and it allows termination up to 20 weeks with one doctor's opinion, and 20 to 24 weeks with two doctors' opinions for specific categories. But most importantly, what has been added is after 24 weeks, termination allowed only for substantial fetal abnormalities decided by a state level medical board. Earlier, this option was not available. It was a hard cutoff. So we have a lot of ethical dilemmas, but we have to remember that we have to make the choices keeping in mind not to cause harm, as well as balancing justice for the fetus and the maternal aspects. So let us look at a few case scenarios. I'm starting with the media favorite, our favorite, Down syndrome. So media, as well as, let's say, the other more affluent countries, Down syndrome has become something where we say the children have a normal lifespan. Many of them, all of these people here are success stories. Yes, they do deserve a right. But let me ask you, a lady in our country, a lower middle class family, will they be able to support a child with Down syndrome? Do they understand the hormonal issues, the growth issues, immunity issues? Do they understand the structural complications that the child can have? Will they be able to handle it? Do we have support systems? I am not campaigning against, but it is important that when we are offering the choices, we give them the full picture. It is not enough to say that there are babies, there are success stories, and this is, something that is acceptable. This is where parents' choice comes in. So this is where we have to give them a complete picture of what it involves after birth, what it involves to after, say, for example, simple question the parent will ask, "Nenu poyina tarvata evaru chuskuntaru?" Isn't that fair? I think we need to give them that information. So a first trimester diagnosis of Down syndrome, yes, I think the screening is validated. And it is still a parent's choice. I have patients who have carried on Down syndrome pregnancies and have delivered. And they are happy with their choice. So let us give them the choice. First trimester diagnosis of diaphragmatic hernia. Sir has said there is almost more than 90% success. First trimester diagnosis. How many parents will be brave enough to continue? Here is where it becomes important for us to complete the evaluation. Is there an associated genetic problem? Is there an associated abnormality? Is it a liver up or a liver down? Will the pulmonary hypoplasia be severe or not? So this, I would prefer to look at it again in the second trimester. By then we have a certain amount of information regarding the genetics, regarding the other structures. We discuss with the patients the options available. How severe is the pulmonary hypoplasia can be evaluated. We can give them prognostic markers. We calculate the O/E lung head ratio. We tell them what are the chances. Now, patients are even asking for interventions and correction. So we discuss fetoscopic, endoscopic laser, endoscopic tracheal occlusion, but all keeping in perspective, what can they afford and what is the success rate? A non-specific etiology, early onset growth restriction. There are scenarios where we have done the entire workup, including genetics, chromosomal, the infection workup, everything. This is a baby, early onset growth restriction. Here, the last chart, you can see the FL also falling off the charts, the growth falling off the charts. She went on to deliver a 36-weeker who was around 1.2 kg. Baby was normal. Dilemma during the pregnancy was FL is falling, all long bones are short. Is it a skeletal dysplasia? In addition, baby had a VSD. Mother said, I believe my child is normal. Now it is a 2-year-old child, absolutely fine. This is early onset growth restriction. We had another child, early onset growth restriction. Everything up to whole exome was done. Baby delivered 38 weeks. It was a low birth weight baby. After 1 year of life, has been diagnosed with West syndrome. That is something we never foresaw. So this is two sides of the picture again. When we look at a structural abnormality, yes, there is talipes, which I showed you. All of us can handle that. Now, tetralogy of fallow. Tetralogy of fallow, not so simple sometimes. So here we have a fallow where you have a good-sized pulmonary artery. These are the so-called pink fallows who do very well. I'm sure Dr. Sudeep will agree with me. Pulmonary atresia, same tetralogy of fallow, but the pulmonary artery is very small. These are children who will require much more cardiac intervention, probably staged surgery. So the parents need to understand what they are getting themselves into emotionally, financially, as well as what are the chances for the baby to survive. When we think of others where we can offer antenatal interventions, for example, the monochorionic twins. Here we had a baby with a selective FGR, and we did a radiofrequency ablation of the smaller twin, because here the problem is if one twin dies, the placental anastomosis can cause thromboembolic damage and of the other twin, of the surviving twin. So this was one scenario like that. And this was where we did a fetoscopy for a case of TTTS. Here, parents need to understand, yes, we are trying to save the babies, but they also need to understand there is a very high chance that they might lose the entire pregnancy, and the pregnancy success rates we quote are only around 60 to 80%. So what I am trying to say here is when we are talking about prenatal diagnosis and implications, the things that impact the parental decisions are when is the diagnosis done, and we need to make our diagnosis as accurate and as complete as possible. We have to help them understand what the severity of the condition is, give them complete understanding about the condition, what is the care available, how it will impact their lives, are there support systems, how much will it cost. That is very important. And of course, we do consider what will be the quality of life for that child, what are the long-term outcomes, and parents need to know if they can handle it emotionally and financially. So I conclude by saying that, yes, ethically there is two sides, but it is very important that we consider the legal and cultural factors, but support the parents with informed choice, offer them multidisciplinary care, send them to the concerned specialist for a counseling, give them information about the state-of-art facility, and give them a plan of action. How is it going to be done? How is the correction going to be done? Who will do it? Where do they have to go? Where do they need to deliver? These are important details which will make handling babies with fetal abnormalities a much more satisfying and a much more complete way of handling things. Thank you so much.
Thank you, Dr. Amita and Dr. Yoga. Now I request Dr. Aparna to hand over mementos to our speakers. First, Dr. Yoga. Thank you, sir. Thank you, ma'am. Next, I request Dr. Amita. Thank you, ma'am. Now moving on to the next session. So we have a panel discussion on perinatal management of fetal structural defects. To moderate the session, I would like to request Dr. Aparna. She is a clinical director at KIMS Cuddles, Kondapur branch. And to chair the session, I would request Dr. Shashikala Kola. Madam is a senior member of ISOPARB. Ma'am, chairperson. I request Dr. Ravi Shankar from Soumya Children's Hospital, sir, is here. And Dr. Jyotsna. The panelist, I request Dr. Manisha Reddy, consultant pediatric surgeon at KIMS Cuddles. Dr. Kirti Somu, fetal medicine specialist, KIMS Cuddles. Dr. Chandrika ma'am, our senior gynecologist. And Dr. Amit, he's our in-house consultant neonatologist. So, over to you, ma'am.
Thank you. So very good morning. So after that very interesting debate, we now move on to a panel discussion on a multidisciplinary team approach for managing neonatal operable surgical defects. I'm Dr. Aparna. I'm a neonatologist. I work at KIMS Cuddles here at Kondapur. And at the outset, I sincerely thank ISOPARB and our state NNF Neonatology Forum and IAPS for being associated with this program. And as we already discussed at the beginning, I would like to reiterate that we are here to kind of discuss about the fate of 3% of fetuses who are kind of delivered with treatable surgical birth defects, where with this kind of team approach, where we have a like-minded fetal medicine expert, we have a geneticist, a neonatologist, obstetrician, and a pediatric surgical team, we strive to offer the best possible outcomes to such children with minimal mortality and minimal morbidity. So it's my pleasure to introduce our panelists. We have Dr. Chandrika Kane with us, Senior Consultant Obstetrician Gynecologist. She has a huge experience in teaching and she has joined us from her post as faculty at Medical College Rajahmundry. Her areas of interest include high-risk pregnancy and gynec endoscopy, laparoscopy and robotic surgery. We have Dr. Kirti Sonu with us. She is consultant fetal medicine. She has been trained in fetal medicine with none other than Dr. Chinmayi, who is also with us, who has joined us today. And her areas of interest include high-risk pregnancy, preconceptional counseling, fetal interventions. We have Dr. Manisha with us, who is our pediatric surgeon. She has been with us at KIMS Cuddles, Kondapur for a long time now. And she has completed her MCH in pediatric surgery from the busy and very well-known Nilofer Children's Hospital. She is a member of the IAPS and she also has a lot of interests to her credit, including pediatric laparoscopy. She has done a lot of minimally invasive surgeries and now she is into robotic surgery. And of course, the team would be incomplete without a neonatologist. And we have Dr. Amit, who is consultant neonatologist and pediatrician from our team here at KIMS Cuddles, Kondapur, along with me, along with Dr. Vishwanath and Dr. Aravinda. And we'll be shortly joined by Dr. Ishita, the 5 of us in our team here. Dr. Amit is DNB Neonatology from Fernandez Hospital. And his areas of interest include POCUS and non-invasive ventilation. So why we have a team here, this is actually symbolic of the perinatal team concept, which is kind of very essential for the proper team dynamics and for achieving better outcomes in these babies. And we have already spoken about the importance of early diagnosis and in utero transfer, which can make tremendous difference in these babies. So let me begin with the first case, and we'll try to discuss around 5 cases today. So this is a 36 weeks male baby born by LSCS with a birth weight of 2,700 grams. This was an unbooked pregnancy, a primary mother, non-consanguineous marriage. Apgars were 4 and 5, which means the baby was depressed, and baby developed severe respiratory distress and cyanosis right at birth, requiring delivery room intubation in view of severe hypoxemic respiratory failure. And on examination, the baby had moderate respiratory distress with a Silverman score of 3/8 with a decreased air entry on the left side and a scaphoid abdomen. Of course, this is a no-brainer X-ray, very simple diagnosis. It's a huge left-sided diaphragmatic hernia. So, Dr. Amit, let me begin by asking you, what are the clinical clues that as pediatricians, as neonatologists, would make us or would alert us to suspect diaphragmatic hernia? In a surprise that comes like this without, regular antenatal visits in our center.
Hello, ma'am. So first of all, what we have to see if we have the diagnosis, because right now we have get a good fetal medicine all over the India and Telangana also. If we have the diagnosis earlier, then we can diagnose, or if it is not diagnosed earlier, then we have to see the clinical symptoms, just like respiratory distress per se with the cyanosis. But moreover, on the auscultation, we will find out that the sound of the breathing will be more deviated towards opposite side of the deviation. Suppose if it is most commonly in the left side, then the breathing sound will be more in the right side, and the gurgling sound, that is the abdominal sound, can be found in the left side. Apart from that, we can also see the shift of the mediastinum, that is the shift of the impulses, the cardiac impulses, more while if there is a more deviation of the abdominal organs, then we can find the scaphoid abdomen. These are the clinical findings. With that, we can diagnose.
A scaphoid abdomen, cyanosis with differential air entry, and if we are lucky enough to actually appreciate bubble sounds in the hemithorax, it actually kind of clinches the diagnosis. Now, the X-ray most of the times would appear like this, where we see the air-filled bubble loops in the left hemithorax with mediastinal shift. But sometimes when we do the X-ray very early in life, when gas has not yet entered the stomach, and this was an X-ray of a baby who had a right-sided CDH, and this was when I was doing my my training. We actually took some time to make the diagnosis of CDH, and because the air had not yet entered the stomach. And if we do an X-ray very early in life, we may actually not be able to see the classical air-filled bubble loops, and you may often mistake this to be a consolidation or a patch of some other reason. But of course, within some time, we started appreciating even bubble sounds within the hemithorax. Of course, 85% of the times, CDH is, of course, Bogdale's hernia in the left side, and only around 10 to 15% of the times in the right side. You may also be able to see a coiling of the feeding tube. So quickly to you, Dr. Kirti. Very often now we are able to pick up CDH in fetal scans, and we are all well aware of the prognostic markers. So can you kind of enlighten us a little bit about the most important prognostic markers that determine the outcome? Is it polyhydramnios? It is the extent of pulmonary hypoplasia, and how do you assess the extent of pulmonary hypoplasia?
So based on, first of all, the diagnosis at the gestational age, if it is an earlier gestational age, they usually have a poorer outcome. And also, if there are associated other defects or any syndromes, they have usually poor outcome. And during scans, we have something called as LHR ratio or O/E LHR ratio. In this, we calculate the normal lung ratio to the head circumference, and there are values for that. If it is more than 45%, they have a very good prognosis, whereas if it is less than 45%, the prognosis is usually moderate to severe. If it is less than 15%, the prognosis is very bad. And based on the contents of the hernia, if it is a liver up condition, it has a poor outcome, whereas usually if it is a stomach or ball, they have very good outcome in the prognosis wise.
So the lung head ratio has kind of become the main pointer for the prognosis, and as Dr. Kirti said, this is calculated based on the circumference or the dimensions from the contralateral lung or the unaffected lung divided by the head circumference of the baby. And since there is a natural evolution in the lung head ratio, people also look at observed by expected lung head ratio, because one LHR cutoff, earlier it used to be LHR below 1, indicative of poor prognosis, more than 1.4, 1.5 good prognosis. But because LHR itself evolves with the gestational age, now we are looking at the percentage of observed to expected LHR. People also look at lung thoracic ratio, which is LTR, but the markers of pulmonary hyperplasia by far are the most reliable ones associated with prognostication, as Dr. Kirti said, and having liver as one of the contents, because it's a solid organ. Even if you see liver in a left-sided CDH, can carry a relatively poor prognosis because it can be associated with poorer lung head ratio. So Dr. Chandrika ma'am, I mean, once we have made a diagnosis of CDH in a baby, let's say the family is actually very keen to continue with the pregnancy. So what would be your role as an obstetrician in planning the delivery? Does the place of delivery make a difference in the outcome?
The studies have told that there is no much difference in the outcome whether we deliver vaginally or cesarean.
The place of delivery, I mean, having
of course, it should be delivered in a tertiary care center where there is where we have availability of NICU and pediatric surgeons, and fetal medicine unit is there. So in utero transfer of the mother should be done, and we should plan the delivery.
Absolutely.
And depending upon the grade and severity of the congenital diaphragmatic hernia, we have to decide the delivery also. If it is mild to moderate, we should counsel them to progress till up to 38 weeks till the complete fetal lung maturity is attained. As I told, the mode of delivery doesn't make much. But the team should be available to immediately resuscitate the baby as
so
soon
the
as
place
baby
of
is
delivery
delivered.
matters, mode of delivery may not be as much. Place of delivery, by which we mean a unit which is doing at least 5 to 6 CDH repairs every year. In most of the Western literature, it is said that these units can probably provide better outcomes in terms of better survival. So it's very important to transfer these babies in utero, as Madam said. And if it's an anticipated preterm delivery below 34 weeks, as per the regular protocols, one might also consider a course of antenatal steroids. Moving on to you again, Dr. Amit, we have discussed about the clinical markers such as scaphoid abdomen, differential air entry, and audible bowel sounds in the hemithorax that prompt us to make the diagnosis. X-ray, of course, clinches the diagnosis. So can you tell us something about the early medical management? Because it is still believed, CDH is predominantly, a medical disease with an important, of course, surgical component. But as a neonatologist, what are your key considerations starting from the delivery room to the NICU?
So for the delivery, as ma'am told, it should be done in a tertiary care center where the team should be available. Meanwhile, we have to just assess the antenatal findings. Right now, they have come with the new findings also, that is in the MRI, they used to see the total lung volume. So if it is less than 35% or severe cases, in the severe cases, first we have to stabilize the respiratory part. So don't go for the bag and mask ventilation for the respiratory part. If any requirement of respiratory support is there, intubate the baby. There is no any emergency for the surgery. So the surgery can be done only after stabilization of the respiratory tract. So do intubation. Now some studies are there in those things, they have seen that whether to do the intubation even in the babies who is mild RDS. So in those cases they have seen that post-surgical, at the time of discharge, they have seen that in the post-op, the requirement of intubation is the same, whether for the mild case, in the mild cases. So in the mild cases also, if you are planning to have surgery, if it is severe in further, then you can intubate electively. Other things, we have to start what mode. So the last study which was done as a VC study, in that they have seen that the conventional ventilation is same effective as HFO ventilation, and there is no any change in the mortality or the BPD. Moreover, the conventional ventilation has good outcome in view of less IVH. So we can go for the conventional ventilation with the gentle ventilation and to keep less PIP and optimal PEEP for that setting. And after stabilization of 24 to 48 hours, we can go for the surgical intervention.
So starting from the delivery room, avoiding bag and mask ventilation because these babies are at high risk of air leaks, early planned elective intubation, preventing pulmonary hypertension. And when it comes to ventilator strategies, as Dr. Amit said, there may not be a huge benefit in elective high-frequency ventilation, but try to use gentle pressures, minimal PIP, optimal PEEP, trying to avoid barotrauma, accepting pre-ductal saturations, that is right upper limb saturations of 80 to 90%, permissive hypercapnia, and keeping the emergency interventions for an air leak ready, like ICD, intercostal drain, all these things to be ready in the NICU, and management of pulmonary hypertension, because this is one of the most important sort of predictors for the postnatal outcome. How gently we manage the baby, how we are able to avoid air leak, manage air leak optimally, optimal ventilation strategy, permissive hypoxia, and permissive hypercapnia. So, Dr. Manisha, when we hand over these babies to you at an optimal time for surgery, can you tell us something about the role of minimally invasive surgery versus the conservative regular surgery, and about, using a graft versus no graft?
Yes, as discussed before, this is more of a medical emergency than a surgical emergency. And as and when the baby is stabilized and the baby is brought to us, coming to what kind of repair is better and how minimal access helps, still there is a controversy between whether minimal access is safe and effective in these babies, because for very large CDH repairs and all, minimal access might be more of a hindrance. It's the carbon dioxide insufflation which was used in minimal access tends to exacerbate the pulmonary hypertension further, and it might be riskier for the baby. But again, if the defect is small and if the contents are not, much of the contents are not in the chest cavity, we can go ahead with minimal access surgery. Coming to very large defects where we use additional patches and all, the different kind of patches are available, like synthetic patches, biografts are available, and even muscle patches are used. But the problem with the patches and these large defects is the recurrence rate is quite high. With synthetic patches, the infection chances are quite high. Using biografts, durability is quite less. So if it is a large-sized hernia, no matter what we do, I mean, if you do a primary repair under tension, that itself can cause recurrence. Or if you use patchwork, though initially it will help, if it's a synthetic patch not causing infection, it might work quite well in these babies.
So to summarize, I think most of the cases of CDH still, because of the pulmonary hyperplasia component involved, probably the surgeons still prefer to do an open repair. But in cases where it's a small hernia,
we can
where
go ahead with minimal
the anesthetist and the intensivist are comfortable, minimally invasive surgery is possible. And Dr. Manisha has discussed about controversies of using graft versus doing a primary repair. So of course, these babies do require intense post-op monitoring. They are at high risk of gastroesophageal reflux, growth failure, etc. But with good kind of post-op care and good surgical care, most of them do pretty well. And in this context, let me also discuss a couple of other lung anomalies that we often...
One second, I just wanted to add up to this, because I think these ADH cases, survival and outcome has changed a lot these days, because these kind of babies are doing extremely well. But it all depends upon whether we are able to give the good care right from the time of birth. I will just enumerate two recent cases, just last month. One case, one of these, obstetrician, she delivered, she told it's an LSCS. So she had asked a pediatrician to come. So, but the pediatrician told, madam, I'll be late by 5 minutes. I'm stuck up in some kind of traffic. But she thought everything's well, fine. So she went ahead full term, and the baby was badly asphyxiated. Badly asphyxiated, they were struggling. Then she made a lot of calls to us, and then we went at that time. And ultimately we brought the child, and we took an X-ray, and we found that it was a CDH, and the child could not be saved because it was deeply asphyxiated. The point is, this obstetrician says we have done a TIFA scan, and we have also done a growth scan also. So why is it that CDH? The parents, they ask us why it was not diagnosed. So all we could say is that this kind of herniation can occur at any age. Herniation is not that it has to be there right from the beginning. The defect is there, but this herniation can. It took a lot of time for us. Lot of time, because there are cases where the CDH can be missed, and missing is PDH in an antenatal period, whether it is in a normal hospital or at a tertiary hospital, can be quite kind of fatal. One more case. Again, ultrasound scans done 5 or 6 times. Born with, this, RD. So the obstetrician felt it is just a TTNB. Then after 6 hours, the RD was again increasing. Totally. Then we, brought the child, took an X-ray. CDH, she is surprised. How is it possible? So, I don't know, whether in the growth scan, do you also look, like, the scan which is done in the last few weeks, whether you look for other things or not, or only the fetal well-being? Because the obstetrician tend to think that if a TIFA scan is done, then everything, all anomalies are ruled out. Maybe.
So I think Chinmay ma'am has a comment, sir.
So,
Can we
maybe I'm not very sure about it. How did this, happen?
No, sir, thank you for raising that issue, and I thank Aparna for allowing me to make a point. You are very right. Every scan that is done on the fetus is a scan where whatever can be detected should be detected. Unfortunately, we have kind of labeled the scans as something or the other, and we feel if we have done that much, it's enough. For example, an NT scan. You measure an NT and you feel that is enough. So people are being sent at 11 weeks when the CRL is just about 45, and some scan is done and everybody is very happy that I finished an NT scan. Whereas the first trimester scan is an enormous opportunity to look at everything. Similarly, the last scan also. When a scan is done, there are specific planes in the fetus that are examined. And if you go in a sequential axial plane, you will at least see the mediastinal shift. Like you very rightly said, the diaphragmatic hernia starts from 10 weeks only, because the diaphragm would have formed by then. But we don't see the effect unless there is a huge mediastinal shift. And what Kirti was saying, that if it is diagnosed early, the prognosis is bad, because when it is diagnosed early, the mediastinal shift has already started. So the lung hypoplasia sets in early. When it is diagnosed late, that means it was very subtle. The pressure on the lungs was not that much.
But that last scan, the respect has to be given by the obstetricians. Somehow they feel that if the growth and Doppler is done, the job is done. But the last scan is your opportunity to pick up subtle problems, like, a diaphragmatic hernia which was not picked up earlier, bowel dilatation which might need an immediate intervention postnatally because every kind of obstruction does not present early, any kind of hydronephrosis, outlet obstructions which are not severe, because these are the ones which will require surgery, and the question what sir faced will be asked, that why was this not picked up earlier? Even in the heart, things like coarctation of aorta, things like TAPVC, which may not have been very apparent earlier, will show at the last stage. So there is no concept of just doing growth and Dopplers. Every fetal scan has to be done to the best of the extent. But of course, we may not be able to see anything which we have to explain to the patient. Now, everyone who does scans will say, if we write a disclaimer, there is no medico-legal sanctity. There is no medico-legal sanctity of anything at all. Because whenever you see the patient, you say, we can't do everything. But you communicating that to the patient and the patient observing that you have tried your best to see whatever was possible is enough. If we do that much, we won't reach that medico-legal hurdle. But no scan can be done only for well-being and not look at anatomy.
Thank you, ma'am. Thank you, sir, for those very important points. I think
one issue. There is, you need to understand that when we are practicing at a tertiary level, the kind of standards we set on ultrasound reporting and the information and the communication between the obstetrician and the fetal medicine is entirely different from practicing at peripheries or practicing in a center where you are dependent on diagnostic centers for scans. Yes. Now, I'm not trying to look down upon a diagnostic center ultrasound report, but there is a certain degree of reliance we have on the training of the fetal medicine consultant and the responsibility they attach to their reports. So you know, the Med Plus or some other diagnostic center, I'm not trying to take names, but they have packages, you know. They'll say they'll give you this much discount and we'll do a whole package of tests, and in that your ultrasound is included. So the growth scans, sometimes they do and come, and we try to explain to them that you need to continue care at certain level, but it doesn't happen. Sometimes the variability in the reporting systems do make it difficult for us to, you know, diagnose certain things. Yeah, and if it's a surprise, it's always the obstetrician's neck on the guillotine.
I think on a good note, a late onset diaphragmatic hernia might actually carry a good prognosis. So in that sense, as neonatologists and pediatric surgeons, we may actually end up giving a better outcome to the baby if, had it been the case that it was genuinely a hernia that came up later because it was so subtle. So with all that interesting discussion adding on CDH, so we'll move on to the next case with 3-4 important carry-home messages. One, antenatal diagnosis of CDH is possible in around 60%, 70% of the cases, and there are excellent prognostic tools, LHR being observed by expected LHR being the best possible thing reported. In utero transfer and delivery in a tertiary center, doing CDH repairs routinely at least 6-7 per year is something that improves the outcomes. The role of obstetrician is very crucial there in kind of counseling and helping the family make this decision. Thirdly, when it comes to the immediate postnatal care, hurrying up for surgery is definitely not the word that is ideal. The focus is on early stabilization, normalizing the pulmonary pressures, gentle ventilation, avoiding bag and mask, and gentle care in the labor room. Delayed cord clamping can be done. Being aware of permissive hypoxia, permissive hypercapnia targets in these babies, trying to avoid lung injury and air leaks, and handing over the baby gently, softly to the pediatric surgeon for a delayed repair at around 48 hours after PAH settles down. And surgical aspects, as Dr. Manisha has said, there is some role of minimally invasive surgery even in this complex subset of CDH. Now moving on to some other lung anomalies that we often encounter, CPAM is one of them. So Dr. Manisha, this is a classical case of a cystic adenomatoid pulmonary malformation. So when do you generally advise surgery in these patients, if they are symptomatic versus asymptomatic?
Yes, CPAMs are conditions, our surgical intervention depends on when the baby presents to us and how bad is the baby respiratory wise compromised. Like if the CPAMs are small in size and the baby is stable on room air, can be sent home, we can delay the surgery for the next few months, but it has to be operated eventually because CPAMs have a chance of malignant transformation. But if a baby comes to us with respiratory compromise, like we had a baby who presented to us with respiratory compromise and whole of the left upper lobe had a CPAM and we were not able to extubate the child, we were not able to send the child home. So we had to go ahead, do an left upper lobectomy in the neonatal period itself, and the baby recovered and we could send the baby home.
Absolutely. So we may have an occasional CPAM requiring excision or surgery in the neonatal period because of persistent respiratory distress, but most of them who are asymptomatic are generally eligible for a delayed surgery at around 6 months, but they do require surgery because when left untreated, they are at high risk of transformation to adenocarcinoma. I'm sorry I've taken out the timer because we had a lot of discussions from the chairpersons. We have another interesting lung anomaly which may often get actually missed on in the early neonatal period. So this was a 3 weeks newborn who presented to us with low-grade fever, breathing difficulty, some occasional cough and cold, and on examination had tachypnea, respiratory distress, and we started treatment in lines of viral bronchiolitis, which is one of the most common things that we encounter at this age group. But surprisingly, the baby actually did not improve, and this was the X-ray that was done on the second day, which showed, as you can see, huge left lung hyperinflation causing mediastinal shift. So initially, it was believed that probably there's a mucus, plug causing hyperinflation. But when this image kind of persisted in the subsequent X-rays, and the baby also did not show significant clinical recovery with the traditional treatment of bronchiolitis, humidified oxygen, antibiotics, nebulizations, we started suspecting that this could be something else, and the CT clinched the diagnosis. So this is, now as it's clear, it's a lobar emphysema, congenital lobar emphysema. So Dr. Manisha, could you share your experience on operating CLE?
CLEs are again ticking time bombs. Depends on the part of the lung and the amount of the lung. Depends on how much of the lung is involved. If a small portion of the lung is involved, we can again wait for the baby to grow a bit and then might take a chance at surgery. But if the major part of the lobe is involved, there are very high chances that somewhere this lobe can rupture and the baby might have sudden tension pneumothorax and it becomes a very severe emergency, and if the child is at home, we might not be there to resuscitate the baby. So if the only segment of the lobe is involved in emphysema, we can still tell the patients that parents that we can wait it over, and if it's growing or increasing in size or there is mediastinal shift or recurrent infections, we might have to operate. But if a large part of the lobe is involved, it's better to go ahead and intervene. And there are some pointers with congenital lobar emphysema, like even during surgery, it is an emergency. We are always ready to intubate the child, always ready to put an ICD in this child, because even while opening the chest, there might be sudden giveaway in the lobe and there might be a tension pneumothorax. So we are always fast enough to go ahead, open and bring out the lobe so that this emergency can be avoided in these
I think
babies.
in fact even preoperatively ICDs are sometimes inserted thinking that the baby has actually developed pneumothorax, because it's a misnomer or a differential diagnosis for pneumothorax, but we can make out lung margins right till the end of the hemithorax. So Dr. Kirti, when you come across CPAM or maybe rarely see ACLEs during the ultrasound, what are the other markers that you look for?
So there are basically 3 different types of CPAMs. One is a cystic structure, solid structure, which is around 2 to 10 centimeters. The second is around 2.5 centimeters, and the third is microcystic CPAM. So first we have to classify like which grade it belongs to. And based on the CPAM, we calculate some ratios, that is CVR ratio, just like how we calculated for CDH. So if the ratio is less than 1.6, they have a good prognosis. And apart from that, we'll check for polyhydramnios and other features of hydrops, whether they're going into that, to see whether it is progressive or not.
Thank you, Dr. Kirti. I think we've already discussed about the clinical presentation. Another anomaly that may also present here
one
is...
thing just want to ask you. Any kind of malformation which comes up after at birth or after a few weeks or so, the parents ask single question. Could this have been diagnosed in the pregnancy? So, that's what is the basic thing, because they don't accept it first. They don't accept it, and they just always think that every malformation should have been diagnosed in the pregnancy. So that's the thing which I think it is very important how we
deal with it,
how we counsel them, how we protect ourselves, how we protect our kind of this colleagues and all, because sometimes this will be visible. So sometimes it's not visible. They'll come in the 3rd week and 4th week and all. So that's how I think it's very important for the pediatricians and this obstetricians to have a very good kind of teamwork. Because what we need to speak, and both of them have to speak the same way. Right. If one tries to contradict others and all, then it's like trying to pass the buck and all. So that's something which we face every day. Any smallest thing, even a polydactyly or anything, is something which happens.
Absolutely, sir. So I think for want of time, I'll skip the case summary of the next case. This was a baby who was recurrently admitted for episodes of aspiration pneumonia involving the right upper lobe. This was an exclusively breastfed baby with poor weight gain as well. And on blood workup, there was no apparent evidence of sepsis. And this was the X-ray which showed a right upper lobe collapse. During both the admissions, the baby had a similar picture. So whenever we have a recurrent readmission for pneumonia and we are seeing involvement of the right upper lobe, one of the things we always suspect is whether there is an anatomical reason for recurrent aspiration pneumonia. And this baby, in fact, had a missed soft palate cleft. So cleft lip, cleft palate is a very common anomaly that we all encounter. So let me start by asking Dr. Kirti. So when would you, actually at which point would you advise genetic evaluation in a baby with, isolated cleft lip, cleft palate? Do you actually advise it at all, or should you not? What is your approach on genetic testing in a baby with isolated cleft lip, cleft palate?
So it depends on the type of the cleft. If it is a median cleft, usually they have very high risk of genetic and chromosomal abnormalities, around 30 to 40%. If it is a cleft lip and associated with palate, even they who do have genetic association, around 15%. If it is isolated cleft lip with no other syndromes, they usually have a lesser association with chromosome and genetic conditions. So if it is isolated cleft lip per se, we do give them an option of testing, but usually the risk of chromosomal aneuploidies is very less in isolated cleft lip. But we have to discuss about the things to the parents regarding there might be chances of any other like aneuploidies like trisomy 18 or 21 can be associated.
Right. So Chandrika ma'am, when you see a baby with an isolated cleft lip, cleft palate, one of the difficulties that we also face when you send them for antenatal counseling is it sometimes is so challenging to give them that reassurance that it is possible for the baby to have a reasonably good outcome if that was an isolated single defect. So how do you deal with this scenario?
2 weeks back I got a patient. That patient's first child had a cleft lip and cleft palate, and they have undergone genetic analysis where it came as a positive. Positive. And now she is worried about her second pregnancy. She is 6 weeks pregnant. She asked me. And they did for the parents also, and they found a carrier status in the mother. Now she asked me, I told that, say, it depends upon the severity. At 6 weeks, I can't give you any assurance, but definitely it depends upon the severity. We have got a wonderful fetal medicine unit. We will check from 10 weeks onwards. We'll go forward. But the question was, she was asking whether do I need to again undergo genetic analysis. It depends. I told, see, it may not be. First we have to come to a conclusion that how severe it is, and most of them they are correctable. Of course you will have a feeding problems, you will have the speech problems, but if it is till up to moderate, I think you can go forward. So this counseling I have already given, so we have to see, ma'am, serially we have to see.
So this was a case of a genetic anomaly that was associated, but in most of the cases where this is an isolated defect and there are no genetic abnormalities, anomalies associated, it still is pretty challenging to reassure and convince families to continue pregnancy, because we all know and we have seen that these babies can have normal outcomes. So Dr. Amit, how do we address feeding in these babies pre-operatively, when a baby with isolated cleft lip, cleft palate comes? So you can tell us about different challenges in feeding and how you deal with it quickly. I request all the panelists to kind of be brief in the answers so that we can discuss the remaining two
for
cases.
the feeding part, first we have to counsel the parents because they are so much anxious for the feeding. So first we have to see what the defect is. If it is defect is only in the cleft lip, then feeding can be done with the upright position. If there is the cleft palate is associated with that cleft lip also, then they have some obturator to just obstruct that the floor and just make the floor in a right way. And some bottles are there that is called Haberman bottles with long nipples and long teeth, and in that the flow can be controlled.
Haberman feeders.
Yeah, Haberman feeders. So with that we can just counsel in the initial days, so we can have some time for the 3 months for the cleft lip or 6 months for the cleft palate to have a good weight gain in the baby, and then we can go for the surgical intervention if required.
Right, so special feeding positions like dancer's hold position, feeding special needs feeders are there, Haberman's feeders, and finally obturators. But I think surgeons generally do not prefer when we use obturators because it kind of widens the palatine ridge. So Dr. Manisha, I mean, when do you prefer to operate a baby with isolated cleft lip and palate? I mean, does the timing base on the postnatal age, or does it also depend on the weight of the baby?
The cleft lip, we prefer to operate once the baby is 3 months and beyond. There's a rule wherein we want the baby to be at least 4 to 5 kgs, cross 10 weeks of gestation of life, so that we can do a cleft lip surgery. Weight. And coming to cleft palate, we prefer the baby to be at least 12 months of age. By then the maxilla development is almost complete, so that we do not alter any facial counters or malar prominences are not altered when we repair little earlier. Before it was being operated much later, like 15 to 18 months, these babies tend to have speech delays and development of speech problems. So now it's operated around by 12 to 14 months of age.
So cleft lip around 3 months and cleft
Beyond
palate
3 months.
Beyond 3 months, and cleft palate is
Around
around
1
1 year of
Yes.
age.
Yeah,
So-
one question to this fetal medicine specialist. So when you diagnose a kind of malformation in the fetus, so when do you think of getting a genetic evaluation? Do you do any kind of genetic
We just
evaluation?
discussed that, sir. I think.
No, but exactly. So will this parents ask? So what is this one in that? Yeah.
So as we just discussed, sir, if it is an isolated only cleft lip, the genetic association is very less.
No, not about cleft alone, because many of these malformations. So do you want to find out the genetic basis to that, or You just leave it alone.
So it depends on the condition what we are seeing, sir. If it is isolated or it is associated with other abnormalities, there are multiple conditions. Obviously, we go for testing to look out any other genetic or chromosomal abnormalities.
Okay. So do you also get, exome also at times?
Yes, sir. It will be a sequential testing, ideally QPSC or FISH, and followed by CMA. And based on the condition, if we are suspecting any other syndromic conditions, then we go for whole exome sequencing.
I think Dr. Jayant also might be kind of talking about this in his session. There is a session on genetics. But if there are multiple organ system involved, generally they would prefer to do a chromosomal microarray versus karyotyping. And if we are suspecting a specific single gene disorder, is that what you would do? You will also opt for a whole exome sequencing. Now, I think because we are running short of time, we'll probably discuss only one of the remaining cases. This is a case of, a classical newborn presenting with choking, profuse oral secretions, frothing, and developed apnea, desaturation requiring positive pressure ventilation, and, the X-ray again showing a classical coiling of the feeding tube. You can see the distended air-filled proximal esophageal pouch, and there is also a dilated stomach bubble, and this is the classical variety of tracheoesophageal fistula type C, where there is a proximal blind pouch and there is a distal fistula. Now, in cases where we do not see the stomach bubble at all, we may be dealing with a pure variant of esophageal atresia without a fistula, but this is pretty uncommon. So, I'll begin with Dr. Kirti. So, what are all the antenatal clues in a classical case of TEF?
So basically, we have to look for stomach bubble. At least we have to scan for continuous 40 minutes to see whether the stomach bubble is filling or not. If there is an absence of stomach bubble associated with polyhydramnios, then we suspect fistula.
So would you also see absent stomach bubble in the commoner type of type C? Or is it something that we only see in the esophageal atresia type?
Atresia. If it is a fistula, usually there is a communication. We might see at least a small filled stomach bubble.
So polyhydramnios would be probably something which is more commoner, and absent stomach bubble in some types of tracheoesophageal fistula. So Chandrika madam, when you have a fetus with an antenatally diagnosed TEF, esophageal atresia, what are the additional precautions you take during pregnancy? Do you give a normal delivery trial, or would you change your mode of delivery based on this diagnosis, or does it not alter the mode of delivery?
It does not change, madam. It does not change. Mode of delivery does not change. But of course, multidisciplinary approach should be there from the antenatal period. The counseling should be there, and she should be motivated to deliver at the higher center, because the chances of undergoing surgery is there. Pediatric surgery, the baby might undergo. So antenatal counseling definitely must be there, and a follow-up scan should be followed to see the severity of the disease.
Thank you, ma'am. Dr. Amit, so now that, let's say the baby has delivered and you are taking care of the baby, what are some important preoperative precautions you want to take? What are the important clinical signs you do not want to miss, because there are some associated anomalies sometimes. We have had a baby with a imperforate anus also with tracheoesophageal fistula, and it took us a while before we actually, picked up that abnormality. And what are the important preoperative precautions that one has to take? And can you also talk about the other screening evaluation that we need to subject this baby to?
For these babies, first, if any one of the things we got, first we have to do the head-to-toe examination, so that we cannot miss either of the other atresia. Suppose we have to see for the anal opening is patent or not. We have to see also for the coronal atresia. Then by that we can just pass out the OG tube by the nose to see the coronal atresia. To see for the TAP babies, we have to know if we got the antenatal report of type C, then it is easy to diagnose after just putting the OG tube and get an X-ray. But if it is the H type of fistula, that cannot be diagnosed immediately after the birth. It can be diagnosed later when the baby presents with either with the failure to thrive or recurrent GER. So these things we have to look after. Then clinically we have to see of the respiratory distress, excessive drooling. That is the main symptoms that we can find out. We cannot go beyond 10 to 12 number or the size of the OG tube, and there is a coiling of the tube. In spite of that, if you go for the diagnostic evaluation, we can go for the water contrast, or in the H-type fistula, we can also go for the bronchoscopy and tracheoscopy to see that where is the communication.
Right. So a cardiac evaluation and an ultrasound kidney will also complete our evaluation because we are looking for vectoral anomalies. And even a simple X-ray will give us a lot of clues. You can see this baby actually has a hemivertebra, which is also part of the vectoral association. And preoperatively, one of the important causes of morbidity while these babies are getting shifted is aspiration pneumonia. So we have had babies where we have got a call for surgery, and sometimes they even succumb on the way because due attention was not paid for the oral toileting, and the baby developed an aspiration episode and collapsed. So it's very important to keep continuous suctioning with a low pressure vacuum continuously through the pouch. And in Western countries, I think they also use Replogel tube, and here also it's possible. It's a low suction that is to be connected 5 to 10 millimeters, continuous suction, so that the baby is at low risk of aspiration. And I'll request now Dr. Manisha to talk about something about the surgical approach. Which approach do you prefer? Is it extra pleural, and do you electively leave ICD in situ? When do you do the post-op dye study, etc.?
Coming to a case of type C TEF, in which there is an upper pouch blind end and lower pouch connecting fistula, which is the most common type, we go ahead and do an open right posterior thoracotomy. There are two schools of thought. Some people prefer to go through a retropleural approach so that even if there is a leak or complication, the lung doesn't get soiled. And some people don't mind going through a transpleural approach because we use a transpleural wrap around the anastomosis, which it adds on to healing. And coming to the anastomosis, once the fistula is identified and upper pouch and lower pouch are dissected sufficiently, we see if primary anastomosis is possible. This is seen by measuring the gap. If it's like less than 2, it's said as less than 2 vertebral bodies defect or 3 vertebral body defects, a primary anastomosis is possible. Even if there is tension in the anastomosis, we prefer a primary anastomosis over a feeding tube and place the baby on elective ventilation, and an ICD is placed to look for any secretions or any leak in that areas, and baby is brought out on elective ventilation only. If till 5th post-op day there are no mild signs of leak, there is no saliva in the ICD tube and all, we can go ahead, do an oral contrast. If there is no leak, we can start feeds from on 6th post-op day. If the gap is very wide, we prefer doing a diversion wherein esophagostomy and gastrostomy is done in the initial period, and feeding is started through gastrostomy, and at a later date, at around 1 year of age, we can do a replacement or pull-through procedures for esophagus.
Thank you, Dr. Manisha, for, we covered all the aspects of TF management. I think for want of time, we will skip this case of antenatal hydronephrosis because we have an entire detailed panel discussion on hydroerythronephrosis. But this is just to kind of brush upon the antenatal classification, the other important ultrasound markers to be looked for in addition to hydronephrosis per se, and some systemic abnormalities that is to be evaluated for. These are the different grading systems, and of course SFU grading system and the recent UTD grading system are extremely popular for identifying the severity of antenatal pelvic ectasis. These are the associated abnormalities that help us in determining the risk associated with hydronephrosis. Postnatally, these are the important aspects of evaluation, and this is an algorithm summarizing the postnatal management. So for us, we do not miss even want to miss a case of lower urinary tract obstruction. This is a case where we want an urgent ultrasound and urgent MCUG so that we can get the pediatric surgeon to intervene and do immediate fulguration. Of course, when there are other markers without lower urinary tract obstruction, but serious markers like the anteroposterior diameter more than 10 mm, urethral involvement, bilateral involvement, then we would still have to electively plan for a MCUG and a renal dynamic scan if there is no evidence of reflux or we have a strong suspicion of PUJ obstruction, which is one of the common DDs. This was the last case of large bowel obstruction. So I'm going to quickly ask maybe Dr. Manisha to talk to us. These are all different cases of proximal intestinal atresia, duodenal atresia, the classical double bubble sign. Lower down we have the distal jejunal-intestinal ileal atresias. So when it comes to a baby with suspected large bowel obstruction, Dr. Manisha, what is the preferred investigation? Of course, we do a lower GA study. How do you interpret a barium enema?
First, when you suspect a large bowel obstruction, the first common thing that we do is go ahead and get an X-ray, confirm that there is a large bowel obstruction, then followed by a water-soluble contrast. Depending on how the contrast appears, that is, if there is any, 3 things can appear in the contrast. Either there can be a complete microcolon, which means a complete large bowel obstruction. This can again be due to a complete TCA, that is total colonic agangliosis, or there can be a proximal atresia, or meconium which can present like this, or it can be a Hirschsprung's disease, which can present with a transition zone more distally, where the distal part is narrow and you have a transition zone, and above this zone there is dilatation of the bubble. So when this is seen, we suspect a Hirschsprung's disease. To confirm, we go ahead and do a biopsy, and once biopsy confirms as a Hirschsprung's disease, either we can go ahead and do a stoma, and later a pull-through, or we can do a primary transanal pull-through. If the baby is stable enough, there is no signs of enterocolitis or there is no perforation prior in these cases.
Right. I think our team has also done a primary repair for a baby with suspected Hirschsprung disease, and this is also something which sometimes families opt for. In anorectal malformation, I think we have a session coming in later where we shall be discussing about different types, low versus high, and how anoplasty can be offered as a single-step repair for a low ARM, which was done recently for a baby by Dr. Manisha and Dr. Ashish. These are all the important steps of medical management. So I'd like to conclude, I know we have crossed time, that birth defects majority of the times are treatable provided there is early appropriate antenatal diagnosis, prompt referral. Sometimes even if it comes as a postnatal surprise, if it is a treatable anomaly, definitely we can try and offer the best to the family provided the baby is referred early to a surgical center. This is a team effort, and it is a very, very satisfying team effort where we are able to give reasonably good outcomes to babies with so-called serious anomalies. This was one giant omphalocele managed by Dr. Manisha and her team, where we were able to discharge this baby, and these were some cases of TEF, preterm baby with CDH, which were also operated. So I thank all the panelists for their active contribution, and if there are any further comments from the chairpersons or from any of the other attendees, we are glad to take them. Thank you.
When we have to, like, it is like interrupted management, like, my job is over. My job is I have diagnosed this. My job is over. Now it is your turn. Now it is your turn. Now it is all, everybody has to come together. It's a teamwork. So it starts from the antenatal dysphagia counseling, because we need to be there at the time. As soon as you find out a small thing, this pediatrician or the neonatologist has to be there to explain them everything. So the pediatrician, the geneticist, then the pediatric surgeon, everyone has to be there whenever a small anomaly, small or a big anomaly is diagnosed. It's important that everybody be in the loop, so that the parents, everybody talks in the same way, and the parents feel comfortable, confident, and they should be, handheld. That's what is the thing. But like, 20, 30 years back, we used to see everything used to be, like it's not my job. Like they used to say like that. Now it's all teamwork. Thank you.
It was a wonderful session. I thank all the panelists and the coordinator, moderator for giving this. What we do basically is whenever a patient comes with a scan report, I think what we need to do is go through the report before you call the patient in, have a talk with the fetal medicine person, then find out if they need any, further investigations like, amniocentesis and what do we talk, and also speak to the neonatologist. And if it is something where a pediatric surgeon is required, then we also bring the pediatric surgeon into the loop. So as you said, it's not continued. All of us, if it is possible, to sit together and talk to the patient and give a plan to the family, what it is going to be and how they have to negotiate. So that will give them a lot of comfort, and they can take an informed decision as they have been talking in the previous sessions. So I think days have changed, and we have to change with the, whatever. We have so many facilities available, and then so much treatment we can give. So, and as obstetricians, I think we are the common link. We have to connect with all the rest of them, and the patients also have most faith with us, because they were coming throughout the 9 months, and they will more weightage to our words, if I may say so.
Thank you so much, doctors, for the most intriguing and enlightening discussions today. And I request Dr. Shashikala Kola ma'am to present the mementos to our panelist, Dr. Manisha Reddy ma'am. I request Dr. Shashikala Kola ma'am to present it to Dr. Kirti Somu ma'am. A little cheers, please. I request Dr. Ravi Shankar sir to present the memento to Dr. Chandrika ma'am. I request Dr. Josna ma'am to present the memento to Dr. Amit Kumar sir. So now we will continue with a more intriguing session by Dr. Chinmay Ratha ma'am, and I request the chairpersons.
Yeah, we request the chairpersons to please stay on for this session. Ravi Shankar sir, Shashikala ma'am to leave, and Jyotsna ma'am. And we are joined by Dr. Sri Sailam sir, President of State NNF. I request everyone to welcome him with a kind applause. We are also joined by Dr. Shilpi Reddy, our Clinical Director of Ops Gynae. So we'll move on with, can we request the chairpersons to maybe please be seated on the stage. So Sri Sailam sir, Dr. Swapna, Shilpi ma'am, Shashikala ma'am. I think Ravi Shankar sir had to leave. Ma'am, will you be able to continue for the next half an hour? Okay, sir. Sure. Meeru kuda help. And you introduce me. Yes, sir. Okay.
I'll finish in like 15 minutes. You want? How much time?
It's indeed my pleasure to welcome Dr. Chinmay Ratha, Director and Lead Consultant Fetal Medicine at Resolution Fetal Medicine Center, KIMS Sunshine Begumpet. She needs no introduction to all of us. One of the most proactive academicians, speakers, researchers in the era of fetal medicine. She has contributed immensely to the improvement and advances of fetal medicine in this part of the country and probably extensively all over South Asia. So over to you, Chinmay ma'am, to discuss limits and limitations.
Thank you very much, Aparna, and thank you for allowing me to butt in this session, because the talk was scheduled after 2 or 3 sessions of pediatric cardiology, but the beautiful discussion that was going on about fetal anomalies, I thought let us just round it off with a reality check of the limits and limitations of the anomaly scan. Because that was the discussion that was going on again and again, that what if we miss that scan, what if we miss the finding, how to explain it to the patients, what can be seen, what cannot be seen on a scan. So the topic that I'm going to address is fetal anomalies, limits and limitations of the scans. So ultrasound has come in as a magic eye where we are able to look at so much detail in the fetal anatomy that when anything is missed postnatally, immediately there is a sense of betrayal, there is a sense of, complete mistrust, what happened, why this was not picked up. So we need to understand that whether it is 12 weeks, whether 20 weeks, whether 40 weeks, 1 dimension, 2 dimension, 3 dimension, whatever dimensions you use, we cannot pick up every fetal abnormality. I am saying this with a lot of humility because as we are understanding fetal anatomy and physiology better, we are also telling ourselves that there is a lot that we do not know. There is a lot that evolves as the baby grows and comes out of the womb. So we cannot detect all abnormalities. Then what are we trying to do? We are trying to see what can be seen. There is a timeline of development of fetal anatomy, and at every gestation there is a particular, limit and limitation of what you can see. So let us do the best for whatever is possible. First trimester scan. Now in a first trimester scan, if you want, you can see the fetal anatomy in that much clarity by just 1 axial sweep and 2 longitudinal sweeps. So it is recommended that you take an axial sweep from the head to the rump and longitudinal sweeps both sides to see both upper and lower limbs at the same time. If you do just that much, you're able to elicit all these images in a matter of like 10 minutes to a trained hand. Why will one not do that? And that is where we get frustrated as scan people when people send us babies for NT scan at just 11 weeks, 10 weeks, 6 days, because she has been told that the moment you are 11 weeks, you have to take the scan. The patient is eating your brains for an appointment, takes the appointment, pays the bill, and then when she comes inside, you see a fetus of 44, 45 CRL, where you're hardly able to tell head from toe, and then, you know, it's an opportunity lost. Because what is the next step that you will do? If you tell, I can't see everything today, come back after 1 week. Who pays for that 15 minutes that you have spent with the patient? You can't ask her to pay again for the scan because that's a big deal. If you give a report on that same thing, it's a very suboptimal report. And then if you miss a stomach bubble, you miss a limb, you miss exomphalos, who takes responsibility for that? So for all obstetricians, please send for the NT scan around 12 weeks. The NT scan can be done any time from 45 millimeter CRL to 84 millimeter CRL. So why not send it when the CRL is 65 to 70, so that not only an NT, but all the rest of it can be seen. In fact, that NT is an overemphasized entity now because there are all other things that we can check on the scan. For Down syndrome, you have got so many good screening tests now, you really don't rely on that NT per se. So that is the first thing I want to say. The reality check is, you do a first trimester scan and then you pick up something. Is a first trimester anomaly scan even justified? Does it generate anxiety? These are the questions we get. Just now I was answering my phone because somebody has had an absent diastolic flow in the ductus venosus, and that's created so much panic. They want an appointment right now on this Sunday when I'm sitting here. That's not possible. So I told them they'll come tomorrow. What will it be? At the most, it will be a cord loop around the neck because of which the ductus is not coming out properly. Or we'll just wait and see that at 16 weeks. Even if I see that absent ductus tomorrow, what am I going to tell the patient? Just wait, come back at 16 weeks, we'll see it again. But that clarity is not there, and that's why there's so much of anxiety on the scans. A lot of things, you know, that should not be the picture after the scan. That's what happens after the first trimester scan, because a lot of things can be seen on the first trimester scan. Now, all of you are trained obstetricians or pediatricians, and you can understand that normal anatomy, as you see the head there, and completely abnormal anatomy where you see unusual protrusions or, you know, very poorly divided brain. These are all very obvious. Similarly, in the fetal face, you can see the face. You look at a nasal bone presence or absence, but you may miss a cleft lip or even a cleft palate in the first trimester. You can pick it up. I'm not saying it's not possible to pick it up, but you may miss it at that time. Just show the patient, this is how the thing is, this is as much as it has evolved now, we will see as the time passes. Spine can be seen very well. Obvious meningomyelocele can be picked up in the first trimester. But very small meningomyelocele may not be picked up in the first trimester. But if you have tried to see the intracranial translucency, you have tried to see as much as possible of the spine, you have a headway towards better diagnosis. The first trimester, you are able to diagnose major cardiac abnormalities because looking at the four-chamber view has now become a routine thing in the first trimester scan. So if it is a hypoplastic left heart, if it is a major AVSD, we may pick it up in the first trimester, but not everything. I cannot say that I can pick up TAPVC in the first trimester. There may be some case report where somebody has picked it up, but I am not going to look for TAPVC also in the first trimester. All the students who have trained with us, they know we are very practical in our first trimester approach. Four-chamber view, maximum outflow tracts. If you can see them, excellent. If you can't see them, don't even spell it in the first trimester because you're going to create more harm than good. I'm not regressing in my work ethics by not doing things, but do what is essential, do what will give you results. Don't do unnecessary things which will lead to a lot of chaos and confusion for the patient. Because if you say one chamber is looking slightly small in first trimester, what will she do? She will go to 3 other people, 2 people will feel it is small, one person will feel it's not. So she's back to square one. Wait till 16 weeks. How does the process of anything change in that much time? What is the genetic testing that you will do? You will do either a microarray or a whole exome. Everything can be done at 16 weeks as efficiently as it can be done at 14 weeks. So please don't panic when you find things on the scan. Abdominal wall insertion problems. Yes, in first trimester we can detect them. Is it important to detect them? Yes, because they have a huge association with chromosome and genetic abnormalities. So look at it at that point, check, do the tests that are necessary, make sure that this is a salvageable condition. That large exomphalos which Dr. Aparna was showing was probably saved because it was not picked up that early. If you pick it up early, most of them are ending up to getting terminated. The pediatric surgeons actually don't like us very much nowadays because many of their problems are getting eliminated in the antenatal period. But that's only because we're not counseling them there very well, and they are not available to counsel. If the pediatric surgeon is available to counsel at the time of detection of an abnormality, that is the single most important determinant of continuation of that pregnancy. Absence of limbs, very well detected in first trimester, and therefore this opportunity should not be missed. The first trimester is the only time where you can see both the hands separately arising from two sides and seeing them till the end of the things. Similarly, the legs. So in the second trimester, one can get confused, and even a missing limb can be missed in an antenatal ultrasound in the second and third trimester, for which it can be explained, but it is very difficult to justify. So if you look at literature, lots of things can be seen in the first trimester, and for certain problems like head and brain, limbs, the literature says 100% detection. I am a little, scared, I don't want to say 100% for anything because there is no 100% anywhere. You get so many things for which you get a guarantee. You buy a television, they give you a guarantee, but at the same time, they give you a warranty. If there is a guarantee, why do you need a warranty? You buy the best BMW car, you still get a warranty. In this period, if there is a problem, we'll give you back everything. So there is a problem, is a possibility. And that is what we don't understand when we do antenatal scans. For some reason, we have become this very media savvy, digital marketing savvy, and exquisite something savvy. We just keep on marketing what all we can do. We should also market what all cannot be done, not because we are lazy and stupid, but because that is how anatomy progresses. This is the mid-trimester anomaly scan patient information leaflet of the United Kingdom, the National Health Service, which we hold as a very, very high, index of respect for the way they provide services. Look at the detection rate predicted for anencephaly. It's not 100%, it's 98% for something like anencephaly. You will cringe why that should be like that, because in India you will have people saying, oh, TAPVC we can detect at 12 weeks. In our center we are doing all echoes at 12 weeks. Well, for the few good pictures that you are generating, how much anxiety are you causing for the rest of the people? And when that person comes for a second opinion for a small, slightly small left atrium in the first trimester, it is a nightmare. It's a nightmare for anybody. So let's be realistic. Let's be, understand the limitations of ultrasound. The ultrasound performance will vary depending on so many factors as have been listed there. So your patient information leaflets are important. All of us who do antenatal ultrasound must take some time in telling the patient what is possible and what is not possible. There is a checklist that we follow. And this is the checklist that we are determining. There will be things in between that checklist that cannot be determined. The anorectal malformation which she showed. It will be very clear after birth. But before birth, whether you see the perianal muscle complex, whether you see anything, imperforate anus cannot be determined by antenatal ultrasound. So there are things where you have these studies. People always say that these are old studies, the ultrasound machines were not that good. But even now there is a set of abnormalities that may not be detected on antenatal ultrasound. So what happens? I mean, when you miss something and you find it after birth, Dr. Ravi Shankar already told us patients ask a lot of questions. But nowadays, in the third trimester also, you might see certain problems which were not seen in the first trimester. Those are called late onset or evolving abnormalities. Now, when something evolves, either it was not there earlier or you did not see it in the beginning. So the person who does the scan thinks, did I miss this early? And when you tell something to the patient, she says, why was I not told this before? After all this, when you tell the obstetrician that, madam, this is what I'm finding, the obstetrician says, oh my God, why did I take obstetrics at all? Because I could have done something else where everything was just my skill. Now I have to explain everything because something was missed by somebody on the scan. And again, it is like, was it missed earlier? So whether 20 or 24 weeks, Can you detect everything? No, you can't. As an obstetrician, you can't take responsibility for what the scan person does, but your responsibility is in at least advising for the scan. Medico-legally, you cannot be held responsible for something that is missed on the scan. That you please understand. So don't worry about it. But if you have advised the right scan at the right time, your responsibility is done. Now, why was it missed earlier? Two things. Either it was not present earlier or it was not seen earlier. There are variable onset abnormalities, there are late onset abnormalities. But if something is missed in the early scan, it's a little difficult to justify. Now this is a major meningomyelocele, and you can see the gestation is quite advanced. So here if the patient asks why it was not seen before, let me tell you, NT scan done at 44 CRL. And then the obstetrician said, no need, another scan you will do, they will call again for echo. You go at 24 weeks only, you can see everything clearly. So at that time, this is what is the picture. So where is the problem? Patients are spending money for ABCD, anything that comes into their mind. Why can't you give us an opportunity to see them at 12 weeks, see them at 18 weeks, and at 22 weeks if necessary? Sometimes views are not great, or even if they are great, what will you be able to detect in 4 weeks? Can you do a gravidogram between 18 to 22 weeks? I'm challenging all the obstetricians here. Because not that you have lost your skills, but the BMI of patients has become so high. Why don't you want to have that opportunity of seeing if there is early onset growth restriction, if there is anything there? So 12 weeks, 18 weeks, 22 weeks. After that, you determine your growth scans, and now there is enough literature to say that 2 growth scans are important. One before 32 weeks to rule out early IUGR, one after around 36 weeks to rule out late IUGR. And if we do that, there is really no harm done, because for that number of scans that you are limiting in many patients, one patient ends up having some 18 to 20 scans because she will have one scan at 8:30 in somewhere, one scan at 9:30 because she decided that she doesn't like the 8:30 report. 12:30 the obstetrician sends somewhere, and 5:30 again she goes for another opinion on her own because she decides that she wants. So that is not really helping. Subtle anomalies may present later. As you can see here, there are things like absent cavum septum pellucidum, not absent corpus callosum. So now when we are looking at things in detail, we are detecting a lot of subtle abnormalities which really do not cause that much problem in the baby later on, but these can be explained. This is a case which was followed by us throughout, but at 3rd trimester you see the pericardial effusion. That is very significant there. So why is that pericardial effusion? When you go on and see, there is a developing pericardial tumor, a tumor in the pericardium of the heart, which is irritating that area and causing that kind of effusion. So this is easy to explain to the patient, and you have your previous pictures where you can show that this was not there. Even if we had not done the scan, somebody else had done the scan, if they have pictures of the 4-chamber view of the heart at that time, we can tell the patient, look, this was not there at that time, it has started now, and therefore this is something that could not have been detected there. Now this is what we can do beyond whatever. But if you have a 3rd trimester detection of a major congenital heart disease, even the 4 chambers are not present properly, large AVSD, then it is very difficult for us to explain why this was not seen earlier. So if the scan does not have a good 4-chamber view picture, it's very difficult to explain that also. So as obstetricians, I have always reiterated, please expect these pictures and just make it a point to look through those 20 planes in your report. Everybody who does that scan should be reporting that many pictures, and you should have them as evidence that they were seen, because there are medico-legal implications of missing these things. A few cases where I will just show you how evolving abnormalities can present, but at the same time, if you do a complete workup, you have an answer for every situation that is there. This is a woman who had a, by a prominent ventricle, 8.99 mm, small Blake pouch cyst, AC just a little bit higher, things where you can't put a finger on everything, but something is not right. So after proper counseling, we said, let's do CMA torch and just rule out everything that is possible, because by definition, these are not abnormal. But it's common sense that today what is 9 can become 10 tomorrow, so you don't want to miss the opportunity of testing for things while it can be tested. By the time we got the report, she already developed ascites. But the good thing is the reports were all normal. So we don't know the pathophysiology of why that ascites happened, but you know that there is no chromosome abnormality, there is no infection. Follow the pregnancy further. Ascites is becoming less. The prominence of the ventricle remains, but things are still okay. But you have no reason to intervene because everything is normal. So we went on continuing this pregnancy, and
by 26 weeks, the ventricles were 11 and 12. So by definition, they have become ventriculomegaly. But what do you know? You know that there are no structural abnormalities. You know that there is no genetic condition. You know there is no infection. So maybe this is a physiological condition where the brain responds to the relaxant effect of the maternal hormones. And then there was an MRI done which said nothing else other than the ventriculomegaly. The cortical pattern is all fine. So there is no problem. And she continued. At 28 weeks also the ventricles were 10.5. And it continued like this. She went on to 38 weeks, delivered a baby, has a normal outcome. So every time there is a problem, don't just panic. Just imagine if she was sent to us at 26 weeks without any workup, with ventriculomegaly, with ascites, she would have lost this baby because we would have given a very, very poor prognosis at that stage. So working up the pregnancy helps, not panicking helps. This is another pregnancy where you have bilateral prominence of the renal pelvis, 16 weeks. Again, 20 weeks, 26 weeks, goes on the same way. And by 32 weeks, massive kidneys, both sides. But counseled, followed, she knows it is a postnatal workup. And she goes on and on, term pregnancy, term delivery, 2.75 kg baby, goes to the pediatric surgeon, has surgery for reflux and continues postnatally. This is a case where in the third trimester, you start noticing slight, chamber asymmetry. There is a whole session on cardiology going to happen. And here, this is what came to be diagnosed as a coactation of aorta. Why was this not seen before? Because it wasn't that apparent. The chamber abnormalities were not that bad. Still, the arch of the aorta is fine, the flow is fine, but there is a mild narrowing in the arch of the aorta. So again, what to do? They were counseled, multidisciplinary team, just like Dr. Aparna showed right now. Everybody spoke to them. Patient was delivered at full term, transferred to a unit where cardiac surgery was done, and this is fine. This is a case of, now in this era of fetal therapy, fetal interventions, one has to be careful. She came to us with hydrops and she was rhesus negative. So she was already given an appointment for transfusion in another hospital. But the problem was she was not convinced about, this is an old case, this is some 2017 or something. So when we did the scan, her heart rate was 260. The fetal heart rate was 260. And the best part was ICT was not done. When we did indirect Coombs test, it was negative. So there was no isoimmunization there. She was rhesus negative, very good. Baby was hydropic, very good. But that will, transfusion is not the solution there. So there, when we looked at it, it was supraventricular tachycardia, which was causing this kind of hydrops. And with the, intervention of the cardiologist, Dr. Nitin Rao advised us, we started sotalol for the mother. And with sotalol, the heart rate for the fetus stabilized. And she went on till almost 36 weeks, 5 days, and delivered a baby with a 90 to 100 heart rate. And the hydrops completely resolved in utero. So there are treatable conditions for which treatment has to be done, but you have to recognize the condition and not offer any blanket treatment to anybody. This is a couple who had unremarkable scans till the second trimester, but in third trimester, you look at the bowels. And these are very bad bowels. I mean, whoever does fetal scans will be extremely scared of these bowels because they are dilated all over and they are known to be associated with bowel inherent bowel abnormalities, which are metabolic in nature, not structural bowel problems. And this is a case of congenital chloride diarrhea. Now, third trimester, you're seeing this happening, consanguineous couple. What do? If you do genetic testing, it needs an amniocentesis. Amniocentesis in such a patient will have a high risk of preterm birth because already there is polyhydramnios happening inside. If you prove it also, what are you going to do? The pregnancy has to continue. So after a lot of counseling, sometimes do nothing is very difficult. So they wanted to do something. I said, let's do parental carrier testing because then we'll know all the common genes that they have. And also if they have a gene for chloride diarrhea, because that will be kind of understood. So they took a decision for couple carrier testing in the pregnancy because we just wanted to buy time. And when we got the reports, both of them were carriers of congenital chloride diarrhea gene. Although it was classified as uncertain significance, we are getting a lot of cases where there is correlation. And then the child was delivered and as expected had chloride diarrhea, was tested, was found to be homozygous, but at least we lost this pregnancy, we lost this baby, but at least we have a plan for the future. And the patients understand that.
Again, in the era of fetal therapy, this is a MCDA. Any MCDA with any fluid abnormality is TTTS unless proved otherwise. So she was referred for TTTS management, and we said this is not TTTS because although there is polyhydramnios on one side, there is no oligohydramnios on the other side. The obstetrician got very upset with us because she sent for TTTS and you decided not TTTS. She sent it to someone else, something. The patient went off without follow-up for a long time. Then after many weeks, the patient came back, and again there was this difference in growth in both the babies. There was difference in Liker, but there was no TTTS. And then you see, this is the case which Dr. Aparna was showing, CPAM. So there is a large mass in the thorax which is causing mediastinal shift, and that is the reason for the polyhydramnios. So there is no TTTS. In the process, the patient went through almost every fetal medicine center in this state because they were being told that this is TTTS, it needs treatment. There is no need for this treatment. So we just waited on this baby, and the baby delivered at full term. Both the babies, postnatally, the surgery was done. And this was operated by Dr. Chandrasekharam. He was kind enough. He sent me all the, videos of the surgery. I'm not going to show you everything there, but he did some kind of dissection, which I'm sure the pediatric surgeon will understand. But this was a thoracoscopic dissection, and they removed that mass from one of the babies, and both the children are doing well. So understand the concept. Just don't get excited that it's an MCDA, there is polyhydramnios, it has to be TTTS. So then you counsel them regarding this. Again, like I told you, anencephaly, the detection rate is 98%. This is one case, monoamniotic twin. One baby having anencephaly, and this is detected at 25 weeks. I don't know why it was missed earlier, but anyway, whatever, here RFA was done, radiofrequency ablation, and one of the baby's cord was coagulated. Luckily, they continued properly and we could take them to full term. The other baby went home. So with the amendment of the MTP Act, we are able to do terminations later, but at the same time, prevent the preventable and detect the detectable. Don't miss things just because there's a possibility of doing it. And while doing ultrasound, don't start it like a PR exercise. That's becoming, I have an ultrasound machine, I'll put up a 3D picture of the face outside and start advertising my center. That is trivializing the whole process of ultrasound. People are coming for a scan just for a 3D picture. And that, I think, is a failure of the way we have explained the scan to them. Because they will see that baby every day, all your life. How many pictures are you taking of your children every day? You wake up with them, you sleep with them. I don't see all of us taking pictures, but that one photo inside the womb has become so important that that is the indication of the scan. So reiterate that scans are medical, interventions and not entertainment sessions. And before I finish, change your attitude towards abnormalities. The sentence that Dr. Aparna has written outside is, born differently but deserve the same love and care. Children with birth defects. So changing our attitude to anomalies changes. Now this is a recent scan, bilateral lack of orbits, anophthalmia. So this patient, I think, decided to discontinue, which I don't judge her, but I would like to show a patient here. Both parents are visually impaired. And I did the first scan of this daughter many years back. And they said if that is the only problem that the child has, we will continue the pregnancy. They continued that pregnancy. I had the chance to scan her in her second pregnancy also. That daughter has at least good eyeballs, but this is their latest photograph few months back she sent me. And that one child definitely does not have a good visual acuity. The second one also is wearing thick specs. But these are the parents who are both blind, visually impaired themselves, and they teach in a blind school. And they would come with assistance from other people. And still they decided that if that is the only problem that the kid has, we'll continue the pregnancy. And they have continued the pregnancy. They continue to take such good care. These girls have a life of dignity. They are looking forward to a future. And how many of us can lose an eyesight in an accident? And once we do that, we are not going to be killed by society because we can't see. We might have an accident which will rupture our lips one day. We will not be killed because we have a cleft there. So just because these kids are not yet born, let's not look at them very differently, and let's not, worry about every abnormality that we see. So the task is not to see what you've never seen before, but to think what you've never thought before on things that you see every day. And for fetal defects, that's what we need. We need a new way of looking at them. And that is exactly why I butted into this session right now, because the discussion that was going on was on fetal anomalies. So I just want all of you to think a little more pragmatically about abnormalities. And medicine is the art of healing or reducing human suffering. So whether it is medicine for the adults or whether it is fetal medicine, our first goal should remain to do no harm. Primum non nocere. Thank you so much for a patient hearing.
Excellent talk, man. And very encouraging also. And I think encouraging not to miss, I think. It's only to not feel guilty for some things when we miss. And when to panic and when to be anxious. I think your vast experience and sound knowledge really helps. And sometimes we should not take it like Pakistan losing the game, but still celebrating. So it should not be taken that way. I think excellent talk, madam.
Thank you.
Stressed upon every aspect and how should handle such situations.
Thank you.
Very good.
And always I say that fetal medicine is the heart of obstetrics because it keeps us pumping and going. And for anybody who does not have a fetal medicine department, we have experts sitting all over, and you should take timely help. Timely help in the sense, crisp and timely help should be mandatory. And when fetal medicine is evolving, you should have all updates and never do half business. I still see a lot of people doing NT scans but not doing markers and not taking the right approach. First trimester is very crucial, and 100% complete combined report is going to make a lot of changes and difference, especially nowadays we are dealing with a pandemic of obesity. And obesity is a deadly combination if the other person lands into preeclampsia and early preeclampsia. Please understand that abnormalities are one level and medical problems are another level, and screening is mandatory, like as madam told. The right time is 12 weeks plus and not at 11 weeks, because that is the better way to judge, and still we will get the final report in 13 weeks and we are good to go if there is any problem. Thank you.
Thank you. Thank you, madam. Very good lecture. It was like we could see your vast experience through your presentation. What we see is we see many of minor anomalies being picked up and it is causing lot of stress for the parents. We see at Nilofer also from so many centers, the mothers come with small anomalies and it is causing so much of stress for the family. Like immediately they come, like for example, renal pelvic dilatation, or as you said, absent cavum septum pellucidum. So this is causing, and the responsibility is that we should guide them what to do then next. Follow all the steps. Otherwise, for such a simple anomalies, they just come and ask us whether we can go for termination of pregnancy. So whenever those anomalies are picked up, we should also make them sit, understand what they should do next and follow them, so that unnecessarily we can avoid those terminations.
So that I think is the responsibility of the person doing the fetal scan. So I'm sure all our young specialists here, Kirti, Priyanka, Neha, they all take that responsibility that when they see something, they report it, but they also put a reference to the context that what does this mean? If it is just mild pelviectasis, is this a problem or is this just an observation? And does this need an immediate attention right now, or is it something that needs follow-up? So I think that you have to close the loop every time you see something on the scan. And unless that is done, meaningful fetal medicine is not there. It's like an adult medicine person. If he sees an ectopic in the heartbeat, he will not just leave you there. He'll do an ECG, he'll do something, and then he'll tell you, okay, this is there, but in your case, it doesn't need any treatment. So that same respect has to be given for the fetal scans, and every finding has to be summarized. Between the obstetrician and the fetal medicine person, you should be sure what you're dealing with. Then the patient will be sure. When both are thinking in two different things, then the patient starts thinking that trident abnormality happens. That is very difficult. Yeah, thank you.
Thank you so much for the amazing talk, Dr. Chinmay ma'am. I request Dr. Shilpi ma'am to present the memento to Dr. Chinmay. I request Dr. Aparna and Dr. Vishwanath sir to join the, to present the memento to Dr. Shilpi ma'am. I request Dr. Sri Salam sir to join to take the memento, please. I request Dr. Sapna ma'am to join on the days with Dr. Aparna ma'am and Dr. Vishwanath sir. Lamp lighting. So we'll just enlighten this program a little more with the lamp lighting. And I request all the chairpersons to join us. I request Dr. Shashikala ma'am, Dr. Josna ma'am, Dr. Yoganagender sir, Dr. Chinmayi ma'am to join on the days. Dr. Manisha ma'am, Dr. Chandrika ma'am, Dr. Anil sir, Dr. Sudeep sir. Please join us for the lamp lighting.
शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तुते दीपज्योतिर्नमोऽस्तुते दीपज्योतिर्परब्रह्म दीपज्योतिर्जनार्दनः दीपज्योतिर्परब्रह्म दीपज्योतिर्जनार्दनः दीपो हरतु मे पापम् सन्ध्यादीपनमोऽस्तुते ओ दीपब्रह्मरूपस्त्वं ज्योतिषां प्रभुरव्ययः ओ दीपब्रह्मरूपस्त्वं ज्योतिषां प्रभुरव्ययः आरोग्यं देहि पुत्रांश्च पतिं स्वच्छामि मे सदा रवेरस्तं समारभ्य यावत् सूर्योदयो भवेत् रवेरस्तं समारभ्य यावत् सूर्योदयो भवेत् यस्य तिष्ठेत् गृहे दीपः तस्य नास्ति दरिद्रता शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तुते दीपज्योतिर्नमोऽस्तुते
Thank you so much, dignitaries. So I request Dr. Sri Salam sir to speak a few words.
Good afternoon, all. First, at the outset, I would like to thank the KIMS Cuddles team, Kondapur branch, and Dr. Aparna for taking up this very important one. I think birth defects contribute a lot to the mortality and morbidity, and we see that over around 1.5 million children are born every year in India. So it's a big number, and a lot of onus lies on us also. And I think any victory in the birth defects I think it is not in the ICUs or in the operation theaters. I think it is in the public health sector where the prevention should be the main focus. I think over years we have been seeing a simple folic acid could do wonders and had done game changers. And even the preconception care, which is one of my favorite subject, the first 1,000 days. I think folic acid supplementation or iodized salt, simple interventions, that can bring a lot of changes in the reducing the mortality. And I think talk on birth defects is really very important one. And I thank the KIMS team taking up this important talk. And I think I see many of them budding pediatricians and neonatologists. I think we should not forget that prevention is better than cure, and lot things can be done very early. So to put a stress on that preconception care, I think the fight for and victory for on birth defects, it will give a great change. So the PCC and the first 1,000 days should also be there in the talks. Thank you for giving.
Thank you so much, sir. The pleasure is really ours to host the session today. And moving on to the pediatric cardiology module, I now call upon Dr. Srisalam sir and Dr. Swapna ma'am to be the chairpersons for this talk. And the talk will be given by Dr. Vishwanath sir and regarding catching the blue baby early, pulse oximetry and CHD screening.
Good afternoon, everyone. I'm Dr. Vishwanath. I'm consultant neonatologist at KIMS Cuddles, Kondapur. So my topic is pulse oximetry screening in newborns. So throughout the discussion of this topic, I will be discussing something about critical congenital heart disease and the screening methods which are available. What exactly is pulse oximetry and the diagnostic accuracy and the clinical impact it has with various organizations, what are they recommending, be it American Academy of Pediatrics or the European guidelines for pulse oximetry screening in newborns. So there is no standard definition for critical congenital heart disease. Any potential life-threatening heart lesions which require any interventions like surgery or be it catheterization, or if the infant dies within the first 28 days of life. So it can be labeled as critical congenital heart disease. It includes various set of heart lesions like hypoplastic left heart, pulmonary atresia with intact ventricular septum, then even simple TGAs and TAPVC, some valve lesions like aortic lesions and pulmonary valve stenosis. These all come under group of critical congenital heart disease. So after understanding the group of heart lesions which are critical, what burden it has. So if you see, the congenital heart defects is the most common birth defect in congenital anomalies, and 8 out of 1,000 live births have congenital heart defects, and among them 2 to 4 per 1,000 live births are critical congenital heart defects, and it contributes a significant amount for the infant mortality rate, that is the mortality in the first 1 year of life. So what the congenital heart disease can be missed. So sometimes it cannot be detected, sometimes it is missed. There are various studies in which roughly around 40 to 50% of critical congenital heart disease have been missed, and then these neonates get discharged from the hospital, and then they come back with potential complications. So what happens when a neonate is discharged without being diagnosed? There is delay in diagnosis, and it has an impact on the mortality and the management of that neonate. So if you see, for example, here this was a study which was conducted, and in that the detection of congenital heart disease, A group of neonates where it was detected prenatally, B was just immediately after the birth, and the C was they were detected after discharge when they had some complications and they came back. So in those set of babies, if you see, they come predominantly with the cardiovascular compromise and organ dysfunction. So once the diagnosis is missed and the neonates get discharged, they come up in a severely compromised state, metabolic acidosis, be it shock, and it worsens the outcome in such babies. So not to miss and to detect what are the modalities available for congenital heart disease. So antenatal detection, prenatal detection, the first point where it can be detected. But if you see, there is a wide variance in the detection of the rate of congenital heart disease. For few heart lesions like hypoplastic left heart, this double inlet or outlet ventricles and this truncus arteriosus, the detection rate is quite high, around 65 to 85. The highest being the HLH is being diagnosed significantly. But there are few simple lesions like simple coarctation, simple TGA. The detection rate is around somewhere between 15 to 25. But overall, if you see, the antenatal detection of congenital heart disease is still around 50-55%. So there are still significant amount of heart lesions which are being missed. Now, once the baby is delivered, postnatally, can the detection be missed? Yes. Just simply based on the clinical examination, more than half of the babies, roughly around 50% of the babies with this congenital heart disease can be missed, and it has been proven. So next set of modality to detect this congenital heart disease is pulse oximetry. So let's get into what exactly is pulse oximetry and how it works. It's a non-invasive bedside, equipment which measures the percentage of saturated hemoglobin. This is based on the differential absorption of oxy and deoxyhemoglobin, which has different absorption spectrum for the red light and the infrared light. And the percentage of this is displayed as, the ratio of these two is displayed as a percentage in pulse oximeter. So you have a light emitting diode and you have a photodetector through which this infrared and the red light, which has a different wavelength, is being detected, and then the ratio is being shown as a percentage. So does pulse oximetry screening really helps? Yes, it has been proven that the states who had a program where pulse oximetry screening was implemented showed a significant decline in the death rate because of critical congenital heart disease. And also there were other conditions which decreased the mortality when the pulse oximetry screening was implemented in those states. Apart from decreasing the mortality, it has been shown that numerous good outcomes of screening, like there is decreased emergency hospitalizations because the neonates get detected early even before discharge. So there were decreased emergency hospitalization, and it is a very cost effective. The recent 2025 AAP recommendations, it is very cost effective in terms, they studied that it took around 9 minutes for a pulse oximetry screening, and which was roughly around $14, around $1,200 to $1,300 for one screen. When they compared it to the mortality cost by neonate who was being missed and coming back with complications, it was way too high. So it is a cost-effective intervention. It saves resources as well, and it decreases the use of neonatal echo. We assumed, it was earlier believed that it increases the use of neonatal echo because of increase in false positive rates of pulse oximeter, but it has now shown that it decreases the use of neonatal echo. And apart from critical congenital heart disease, pulse oximetry screening helps in identifying other hypoxic conditions like your pulmonary hypertension, your sepsis, and pneumonias. So these conditions can also be picked up early. So these are all the benefits of pulse oximetry screening. So let us see in which set of neonates when it is recommended. If you see the American Academy of Pediatrics or the European consensus, it has to be done in a well-appearing neonate who is on room air support, not requiring any oxygen, and postnatal wards, not in ICU. American Academy recommends the screening at around 24 hours or before the discharge. It has to be done in either right hand and either of the foot. There is little bit difference in European consensus because their discharge policies are different compared to American. They tend to discharge little bit early. So the screening pulse oximetry is a bit early in European countries. So they screen around 4 to 8, ideally around 4 to 8 hours of birth. And ideally should be done within 24 hours. Okay. And they attribute the first 2 hours after birth to transitional circulation. So not much of help if screening is done within 2 hours of birth. So this is the latest 2025, the screening protocol. So let us understand, neonate is born not on any oxygen support, on room air, at discharge, at 24 hours or before discharge. The first screening has to be done in right hand and one foot. So it includes both preductal and postductal. If the pulse ox screening shows less than 90% in either right hand or foot, that is pre or postductal, then it is considered a failed pulse oximetry test. The neonate has to be further evaluated in terms of clinical examination and referral for echocardiography. If the pulse ox screen is more than 95% on both sides and the saturation difference is less than 3, it is considered a positive pulse oximetry screen. It means the neonate just requires routine care. There is no need for further evaluation of the baby. And one retest should be done if the criteria is not met, and the criteria of less than 95% or more at both hands and the saturation difference is less than 3, then it is considered pass. And if it fails after one retest, if it is failed, then further evaluation with 2D echo is recommended. There is a little bit change in recent recommendations compared to the 2022 one. It is more simplified version compared to the previous one. They have the lower limit, it has to be checked in both pre and postductal, and it has to be more than 95, and only one retest is recommended. Previously there were 2 retests, and the terminology of either or foot was used, which created a lot of confusion, especially in the healthcare providers and the interpretation of the report. So it streamlined the screening process and the interpretation errors were decreased, and it took really less time compared to the previous guidelines. It decreased the time by almost 2 to 3 hours. There was a slight increase in the false positive rate, but it was overshadowed by the other conditions apart from congenital heart diseases were being picked up, like pneumonia, GBS, or other sepsis. So American Academy, they recommended for term babies. They do not recommend pulse oximetry screening for preterm babies, but European consensus, they recommend pulse oximetry screening for 34 weeks and above. It's more or less same, just a little bit early, around 4 to 8 hours is the ideal time for screening, and the saturations of 95 and the difference of 2 or less is considered positive. And if the saturation is 89% or lower, needs further evaluation. And they also recommend just 1 repeat screening. So 2 repeat screening has been removed from all the consensus. So the common causes of low saturation or the failed pulse oximetry screening is still not the congenital heart disease. There are other conditions, common conditions like pneumonia, meconium aspiration, pulmonary hypertension, and the sepsis, which has to be considered first. Then comes the cardiac lesions. And the core anomalies like hypoplastic left heart and DORV, TOF, TAPVC, TGA, tricuspid atresia, these can be picked up in pulse oximetry screening. There are other special circumstances, like do we need to screen a neonate who is being admitted for other reasons in NICU? No. We should not be screening, especially the neonates who are on some oxygen support. There is no point in doing pulse oximetry screening. There is little bit difference when the screening is done at higher altitude, because the mean arterial pressure is slightly higher compared to the neonates who are being screened on the ground level. And there are no still clear-cut guidelines to screen for the neonates who are born outside because of various reasons, because the neonates who are referred would probably have some oxygen support. So we don't have any consensus regarding that. If you see the diagnostic accuracy of pulse oximetry screening, it is quite sensitive. Around 76% is the sensitivity, and the specificity is around 99.9%. There are some false positive rate around 0.14%, but still it would detect other conditions apart from congenital heart disease. So the take-home points regarding pulse oximetry screening in neonates. It's a non-invasive technique, and it's very easy. It can be done by all the healthcare providers, be it our nurses, other staff, and the early detection has to be done even before the neonates is being discharged, because it improves the survival and decreases the mortality in those neonates. Thank you.
Excellent talk. I think nicely stressed upon the importance of certain simple things like baby steps, big impact. That was our this year's presidential action program also. And I think whenever you document pulse oximetry in the first few days of life, it is very important to document the time of doing the pulse oximetry also, because without that, I think the number, it's just a number. So I think at what hour of life was it done? That's very important. And then added to this, I would like to tell about the TSH also. I think so. When you write TSH, please remember this is not a static number in the first few days of life, just like the pulse oximetry. I think mentioning the time and at what day of life is taken is very important, because without those, even the TSH values, they are just numbers. They don't convey anything. So I think we should start learning the habit of documenting the pulse oximetry and in the first few days, the time of pulse oximetry. Very good. I think nicely stressed that after 24 hours at least, and not before 2 hours. I think that's very important.
Yeah, so now all like sir said, all units should follow a structured protocol of pulse oximetry screening, which should contain the demographic details and the timing of screen, and now the values also has to be mentioned. So it has to be done in all unit.
Yeah. So we all record weight of the babies at birth and see that in the birth card we enter the weight and explain to the parents. So in the same way, it's mandatory that there are certain things which we have to screen for the neonates. One of the thing mandatory is documenting this pulse oximetry and writing the saturations. Otherwise, after discharge, we see these babies coming in very bad shock and non-salvageable. So it's mandatory that we all record pulse oximetry findings and discharge the baby. Thank you.
Thank you so much, Dr. Vishwanath sir, for your beautiful talk. And I request the chairpersons to continue chairing the next session as well. So we have the next session by Dr. Anil Kumar sir to come up with on the topic of clock ticking hearts, when to refer.
Good morning, everybody. I thank Dr. Aparna and the organizing team for giving me this opportunity today to present our experience in cardiac surgery in neonates. It's an honor for me to talk in the Forum of Obstetrics and Gynecology today, to showcase to everybody here that it is possible to correct in our country complex anomalies in children with heart, in neonates, cardiac surgery, with good outcomes. And we have, I want to show my presentation in pictorial form, the follow-up of many complex operations and how the kids are doing well. And that will be a take-home message for everybody that it is possible to perform the difficult cardiac surgery in neonates with good outcomes, and kids, as long as they have 2 ventricles, will have normal life and will go to school as like a normal child and with a normal brain, and they'll have a normal life. So this is a classification of congenital heart diseases, cyanotic and acyanotic. I want to focus on the 3 important lesions today in our country, where you see like coarctation of aorta, transportation of gate arteries at TGA that requires a switch operation, and TAPVC, total anomalous permanent connection, and also intracardiac defects with like a VST associated with arch interruption. So today in our country we are able to perform good repair in an advanced cardiac center like this with good outcome. And I will focus on these 3 the lesions. And and we are able to perform good surgeries in these lesions on par with other parts in the advanced centers in the world. And we have to understand that if you correct them at appropriate age in neonate, we can give normal life, as I said, to the kids, as long as there are 2 good sized ventricles. In other words, a kid with single ventricle, which required multiple staged surgeries, may be having a not normal life, but will have a little doubtful prognostic value in the future. And I want to reinstate the point that these kids with a good surgery will have normal outcomes in the brain. And we need a good infrastructure for these surgeries with a dedicated team, which includes everybody, and that ends with the post-operative nursing care and a very efficient neonatal care. Now, like example of Dr. Aparna and the team here. Now, this is a theater which requires infrastructure. This is a heart-lung machine which shows, it is a heart-lung machine. Open heart surgery is done. It's less we divert the blood of the baby to a heart-lung machine to cool the baby to almost 24 degrees in complex surgeries. So there's a cooling blanket there, and you can see the heart, the cardioplegia. So we stop the heart to perform surgery. So cardioplegia these are all modern technology where we find with modern technology we have minimal damage to the heart-lung machine to the baby. That's what is important. And as I said, I will focus on important lesions like this. Now, this is a case scenario of a 20-day-old neonate. So when do you refer for surgery? A 20-day-old neonate with cyanosis and rapid breathing. And the diagnosis is TGA with intact septum, transportation. So now the issues to be addressed are: what are the emergency measures to be taken? What is the role of prostaglandin? And if the patient if the same baby presents to us at 2 months, what is the option? Now, classically across today in transportation of gate arteries, we have to operate switch operation ideally within 1 week. Because if you don't operate early, the LV will regress and the outcome is not, and the kid cannot undergo switch operation, and we have to do what is called a sending operation. Otherwise, delayed switches with PA banding and stenting doesn't usually work out in our setup. So surgical options: TGA with intact septum, ideally switch operation before the LV regresses. If the VSD is present along with the TGA, then we can plan the operation according to the weight and the presentation heart failure, maybe in 1 week or 2 weeks time, or even sometimes after 1 month. So switch operation. See, this is a picture to show the aorta normal presentation, and then the transpiration where the arteries are switched. So when we do the switch operation, we switch the ventricle, the gate arteries to the ventricle. So it is very important. It is just not a switch operation. When we talk about switch, the important point in the complexity of the operation is because we have to transfer the coronary arteries also along with aorta. That means that the coronary arteries are very tiny, sometimes 1 millimeter. When we do the switch operation, we should transfer them effectively so that the ventricle is not compromised and the coronary artery doesn't kink. Sometimes we have what is called abnormal coronary arteries. Normally, the coronary arteries are circumflex, the circumflex, the LAD, and one on the left, and right coronary on the right. So, if there are abnormal coronary arteries, sometimes if single coronary artery, the repair becomes more complex. That is why switch operation is a very important the surgery. So, this is an example. I'll go through slides of a presentation of babies who have undergone surgery with our unit in the past and in recent times, with due permission for the families. This is a switch operation which was neonate for 70-year-old neonate. I'll show the follow-up of the baby. After extubation, the baby behaves good in the ICU, and then you can see the baby. We have the follow-up of the baby 6 months, how cheerful the baby is. It is so happy for the unit to see a baby come back to you in the next few months, the cheer, feeding well and with cheer, with happy. And the same baby comes to me at a school-going age. This baby was operated in our unit many years ago, about 2014, and now the baby is going to school and comes to me very happy. Similarly, this is another baby of a VSD with a TGA 2.2. So they take time. The babies, these neonates after cardiac surgery, they take time in ICU to recover. That is why I stress the importance of a good, efficient the neonatal cardiac unit where the neonatologist is involved actively in the care, so the nursing care and the neonatology care is very important because they take long time to be in, and the most important thing, they eat up lot of resources because they are so fragile after cardiopulmonary bypass. Immunity is down, so they catch infections. It's a challenge that our Aparna's team manage them so well. It's a challenge to manage them post-op. It's not easy. And after all that, they do well. It's a plus point for the unit. So this baby is a TGA example, 8-day-old neonate, operated. And this baby, after 2-year follow-up, the kid is growing well. And recent follow-up of the kid, and the kid was so impressed. This kid was so impressed. The family was, this was the emergency operation. The kid was so happy. They put my name for the baby. And then this is an example of another baby, 8-day-old unit we operated long time ago, and you can see the baby doing well, 1 month chubby, and then recently she came, they saying she's going to school, and you feel happy as a surgeon and a team that they are doing well with a normal brain and a normal heart, good function heart, no issues. This is a long-term follow-up. This is to a take-home message that transpirations can be treated successfully and the kid have normal life. I'll show an example of a baby. This is operated in Kondapur, KIMS, sometime recently. The TGA with VSD, the Aparna's team transported a baby from a different place on a ventilator, operated on day 6 of life with a very complex anatomy in the transportation, and the kid, recent follow-up, did very well. And Dr. Aparna also wrote up this in the local newspaper. This was a very long 12-hour operation, and the kid had normal heart after that. And this is a rare combination of 3-day-old neonate, operated again in KIMS only recently. So this was a combination of a transpiration with TAPVC. This is a very rare combination, and our detection was done excellent, and we operated that kid, and we made a brief press note also for this because it's a very complex, rare operation, not usually reported across the world. It's a very uncommon combination of TGA and TAPVC. Now, example of a TGA baby operated as neonate, when they come for follow-up, you feel, this is an example of a baby, this was day 2 of life we operated with the coarctation of aorta with TGA. So, this was more complex because in addition to the transpiration, the coarctation also had to be repaired in the same sitting, and the kid did really well, and the family is so happy. Now, this is example of, the next case I will go to TAPVC. Usually TAPS is, we all know, it's same like, it's an emergency. So 3-year-old neonate with a weight of 2.7 kg, saturating less, and then diagnosis is infradiaphragmatic TAPVC. So TAPVC is, as you know, 3 types: supracardiac, infracardiac, and intracardiac. So when the vein goes up to above the heart to superior vena cava, it's supracardiac. When it goes down, it is called infracardiac. You can see this is a supracardiac TAPVC, and when the same thing, when the abnormal vein goes down below the liver to the liver, it is infracardiac. So basically, the veins are not going to the left atrium; they are going to the right side. So we have to divert to the left side. So this is the techniques of surgical anastomosis of the veins to the left atrium have been improvised recently. We have been following what is called sutureless technique to avoid restenosis. So when we suture the veins to the left atrium of the neonate, sometimes they can restenose. So they can, the suturing of that anastomosis will not grow with the heart. So that is why TAPVC repair is a nightmare to many units. So we evolved a strategy as per the world literature and recent advances, where we do sutureless technique, where we don't touch the intima at all. With this outcome, in our unit in KIMS, the restenosis rate has drastically fallen down. And it's not moving, ma. Sorry. Slide. It's not moving down. No. So this TAPVC, so after surgery in TAPVC, you can see it is not to scare everybody, but after the babies take long time to recover. The heart is so sick and the lungs are wet, so we don't close the chest. With the sterile membrane, we keep the chest open. But in recent years, this chest closure is not usual, is not routinely done. We are able to, even in Kondapur, for example, we operate here for the past 3-4 years. We're able to close primarily all the chests with better surgical techniques. And you know, this is we stop the heart, and you can see the anastomosis being done behind the veins, the left atrium. The heart is virtually stopped, and the heart is flipped on this side. And after extubation, they do well. And you see after how nicely the nurses are feeding the baby after such a big wound here. The babies behave so normally, and they start feeding well, and they do well. And then you can see the recent follow-up of TAPVC repair. And this is an example of another baby. This is a preterm. This is a baby we operated within 36 hours. This was in our Vizag unit of KIMS, and you can see, it is so scary to see the baby with so many infusion pumps. The baby is a ventilator. So they are basically to tell you that after surgery, in complex cardiac surgery, they are so sick, and it requires extraordinary management skills to manage them effectively so that they will do well. And look at the follow-up of the baby cheering after 1 year of the same follow-up after surgery, going home and recovering normally. And this is an example of a preterm baby. This was a success story of us with a very small. So just to tell you, even a so small babies, preterm babies also can be operated safely with this lesion, as small as 1.3 kilograms. And you can see the baby did well and then came for a follow-up. We feel very happy as a unit. Another example of a baby, this was a 2-month-old TAPVC. Pre-op, the baby was so sick, we had to put an ECMO to stabilize the baby before surgery. After that, the baby did well, and then we can see the baby. This is another example of a TAPVC. So this baby was operated as a neonate by us, and you can see the follow-up after many years. The child is growing well. So the next batch of lesion is neonatal coarctation of aorta. So coarctation of aorta usually is done from the left side. You can see a thoracotomy wound for this neonate. This is a neonatal coarctation. So what we do in coarctation of aorta, basically, see, there's you can see the arch hypoplasia, and then you can see the narrow of the segment of the aorta there. So we have to mobilize the descending aorta to the arch. You can see the cross clamp placed at the base of the neonatal artery, so the brain is perfused. This is called closed heart surgery for co-oclusion of aorta. And after surgery, the arch is normalized in the echo, and then this case was followed up by CT scan after 1 year because the baby was so small in weight, and the scan was normal, showing a good arch repair. So sorry. So this is an example of a day 2 baby neonatal co-oclusion of repair. So we have in our unit in KIMS, we published the data of co-oclusion of aorta in Annals of Pediatric Cardiology with excellent outcomes and with modification of the technique called this arch advancement to avoid recirrhosis of co-oclusion of aorta. So this is a interruption of aorta. You can see there is no connection between the descending aorta and the arch. This is the aorta arch is interrupted. So we do this repair with what is called regional perfusion of brain. So we cool the baby, so we cool the neonate to low degrees of 18 degrees centigrade, stop the circulation, not stop the circulation, do regional perfusion of brain and operate. And that is to avoid circulatory arrest. And you can see the CT angio of the pre-op case, and you can see the arch, the pulmonary artery is so huge, dilated intra-op. And what we do the innominate artery cannulation. You can see the cross clamp and the innominate artery base. So we cannulate there, and when we do the arch repair, you can see the cross clamp is placed on the closed innominate artery, so the brain is being perfused. So that means the arch repair is done without circulatory arrest, with regional perfusion of brain. And after doing the anastomosis, these babies also do well after such a complex operation of the arch and intracardiac repair of the VAC together. We have good outcomes of this repair, and then is a neonatal VAC operated in the KIMS the hospital here in our unit. The babies are so cheerful when they come back to you for follow-up, and this is an interruption baby with a follow-up picture. Just to share, and we published this long time ago in the Indian Journal of our technique of regional perfusion of brain to protect the brain and operate this with good outcomes. Also, a poster award was done in the international conference. We have a big volume of cases overall in KIMS, and in Kondapur unit we have done a reasonable amount of neonates with TAPVC, co-oclusion, switches, and combined lesions. So, thank you.
Excellent, sir. I think once again you have proven that birth defects is not the end of the road or end of the life. I think very nicely you have presented the case, sir, and very encouraging also. And that majority of us as healthcare providers, we even do not have that much confidence in referring very early and for few defects. I think all the cases you have shown here are truly amazing, sir. And congratulate you and your team also for this.
Yeah, it's a team effort. It's not only surgery. It's starting from the diagnosis of the pediatrician, neonatologist, and then the cardiologist, and then the surgical team, and then post-operative care. So this is a team effort, and it is gratifying to us when we operate on the neonates with such a major operation. They do well post-op, and as long as again stress, as long as they're good size ventricles, the baby will do well in the future if the surgical outcome is good.
So you all proved that teamwork has made the wonders for these babies, and so pre-operative stabilization and post-operative care is at most importance for survival of these babies, and we congratulate the team for the success of all these stories.
Thank you.
Thank you so much, Dr. Anil sir, for the inspiring talk. I request chairpersons to honor with a memento for Dr. Anil. So,
So my sincere apology. I have to go for another meet also. So I congratulate the Kondapur team for their excellent CME program. It seems that the hall is made for the pediatricians and neonatologists because so many CME programs have been here. And I appreciate Dr. Aparna for giving this opportunity. And Team NNF thanks KIMS Kondapur for the collaboration and organizing such event. And I encourage all of you to enjoy the academic feast. Thank you for giving.
So we have the next session coming up by Dr. Jagan Mohan sir. It is ductal dependency, stabilization and prostaglandin therapy. So I request Dr. Anil Kumar and Dr. Chandrasekhar sir to chair the session.
Good afternoon all. I am Dr. Jagan Mohan Varkala, neonatologist. Today my topic is duct-dependent congenital heart disease, its early recognition, stabilization and prostaglandin therapy. This is not a core cardiology topic, rather it's a frontline pediatrician and gynecologist topic. Why this topic matters? So many duct-dependent congenital heart lesions appear normal at birth. These babies doesn't show any immediate signs immediately after birth. So the real danger comes after 24 to 72 hours. Once the duct closes, the babies will collapse. So one misdiagnosis here equivalent to one preventable death. So lack of recognition leads to fatal outcomes that could be avoided. So here, who are the first contact doctors? Gynecologists and pediatricians. So we are the front line in identifying the high-risk babies. So one timely intervention like starting prostaglandin can save the lives. So early recognition saves lives. So coming to the global burden of congenital heart disease, they account for 1% of all newborn births. So out of which 25% are critical or duct-dependent congenital heart disease. And they contribute to 30 to 50% of all birth defect mortality, particularly in first 1 week. And in India alone, there are 2 lakh new cases of congenital heart disease are born every year. So what is duct dependency? Duct dependency is nothing but the baby whose blood supply to the lungs or the body is dependent on the patency of ductus arteriosus. So whenever the duct closes, the baby will land up in shock, hypoxemia, and acidosis. So as we know in fetal circulation, duct is required for the survival of the fetus. So as the baby born, the baby cries, baby takes oxygen. As oxygen tension increases, the duct tend to close. Generally, function closure occurs after 24 hours and structural closure occurs after 72 hours. So coming to the classification of duct-dependent congenital heart disease, we don't need to remember all the anatomy as such. So just remember 3 patterns. One is duct-dependent pulmonary circulation, where the babies who's not able to supply blood to the lungs. So they depend upon the duct for the survival. So the duct-dependent systemic circulation, where the babies who depend on the duct for the supply of the blood to the whole body. And the third one is parallel circulation, where the both circulations runs in parallel, and it duct dependent for both pulmonary and systemic circulation. So coming to duct-dependent pulmonary circulation, which accounts for 17% of the cases, pulmonary atresia is the most common, where there are various other types like critical pulmonary stenosis, tricuspid atresia, tetralogy of Fallot with pulmonary atresia. So generally these babies usually present after 24 hours with profound cyanosis, which is not responding to oxygen, and may or may not with respiratory distress and murmur. So duct-dependent systemic circulation. It accounts to 47% of the critical congenital heart disease, out of which coarctation of aorta is most common. It is around 58%, and hypoplastic left arch or hypoplastic left arch syndrome. And generally they present with shock, profound shock after 2 to 7 days when the duct closes, and followed by cyanosis. And one important thing everyone, the pediatrician here has to remember is, always on day 2, try to palpate the femorals. So feeble femorals or absent femoral pulse. So it's a diagnostic clue for cyanotic heart disease, like particularly coarctation of aorta. So never miss palpating femorals on day 2. So if in doubt, you have to check the BP. So differential BP between upper and lower limb also gives a clue. So if you want to remember one slide from all this topic is this slide. So when to suspect ductal dependency? What are the red flag signs? So any central cyanosis which is not improving with oxygen. So it is until unless proved otherwise, it is congenital heart disease. So any central cyanosis which is not improving after starting oxygen, it is until unless proved otherwise, it is congenital heart disease. So generally babies present with shock after 24 to 72 hours, you have to suspect congenital heart disease. So as we discussed, the absent femoral pulses, differential BP, poor feeding lethargy, metabolic acidosis, uncertain respiratory distress, unexplained respiratory distress. And remember one thing, normal antenatal scan doesn't rule out congenital heart disease, as already been discussed. Only 50% are identified in antenatal scans. So other thing, our friend already discussed about pulse oximetry. Pulse oximetry is one of the cheapest investigation available in neonatology, which is saving many lives. So always my appeal for all the obstetricians and pediatricians over here is, don't discharge a baby without doing a pulse oxy screen. It's a simple, easy test which can be done by our nurses also. So any difference between preductal and postductal, you have to suspect early congenital heart disease. And coming to oxygen, as we know, oxygen is the most commonly used drug in our NICU and also most abused drug. So oxygen is a friend or foe. In critical congenital heart disease, it can kill the babies because high oxygen tension will close the duct. So always don't chase the saturations here. So always saturation between 75 to 85 is acceptable in duct-dependent lesions. So it is 85% is survival for brain survival. Okay. So we'll come to a case scenario. Generally, how we see the cases. The term baby with good cry, with a birth weight of 3 kgs, upwards were perfect. Everyone will be relaxed. On day 1, baby was normal. Baby was feeding well, and mother was happy. And day 2, suddenly baby becomes little dull. Saturations are around 82 with no distress or murmur. And we started nasal prongs with 2 liters. And saturation slightly increased up to 90%. And we have done an X-ray. X-ray doesn't show much except for mild cardiomegaly. Lung fields seem normal. And we plan for echo. Echo, here we can see 4-chamber heart, functional tricuspid valve. We can see here with and you can see intact septum, intraventricular septum here. And apical modified 5-chamber view. You can see here atretic pulmonary valve and no forward antegrade flow through across the pulmonary valve. So here the diagnosis is pulmonary atresia with intact ventricular septum. So it's a duct-dependent pulmonary circulation. So we can see here the pulmonary valve is atretic, and even the pulmonary artery is also hypoplastic. So how do you stabilize these babies? Generally, we follow ABCD approach. So airway is very important. Always secure airway when needed. Intubation, if needed, you have to intubate. And don't chase the saturations. And avoid hyperoxia and secure IV access, umbilical line or PIC line if needed. And don't give, avoid excessive IV fluid boluses. Avoid aggressive bolus resuscitation. And maintain euglycemia, euthermia. And the game changer is prostaglandin or alprostadil. So the golden rule is whenever you suspect a congenital heart disease, baby is unstable with saturation 70% or in shock, start prostaglandin, then confirm. So start prostaglandin early when you are in doubt, when baby is unstable, because it saves lives. You can confirm later. So how do you start prostaglandin? So it has very short half-life. So we need to start in continuous infusion with 0.05 to 0.1 microgram per kg per minute in IV, preferably through central lines. And you can gradually titrate the dose based on the response to saturation and the perfusion. So generally, systemic duct-dependent lesions require more and than the pulmonary duct-dependent lesions. And also, to open the duct, we need more dose. So in a study, it found that if you early you start prostaglandin within the mean period of 2 days, the response is very good because 98% there is a success rate in that study. So saturation increased from 77 to 89% and PO2s are increased from 26 to 49%. So do prostaglandin have side effects? Yes, we need to prepare for that. You should not fear for that because apnea is the most common side effect. Once baby has apnea, don't discontinue the prostaglandin because management of apnea, management of side effects is easy, but we can't able to manage the ductal closure, shock, or even death. So when baby goes into apnea, you can intubate or can start NIV. You need to continuously monitor for respiratory symptoms. And hypotension is another complication. It can be managed with IV fluids or also inotropes. Fever can be managed by antipyretics. Rarely bradycardia, which can be managed by dose reduction and atropine. So whose babies are at risk for side effects, are particularly apnea? When dose is more than 15 nanogram per kg per minute, or when we are giving rapid infusions, avoid rapid infusions. Slowly start with lower dose, particularly babies being premature or sepsis or CNS immaturity. So how to prevent that? So start with lower dose and elective intubation in high-risk cases, and CPAP and continuous monitoring is required. So don't stop prostaglandin whenever you encounter side effects. So consider caffeine or aminophylline. So some babies won't respond to prostaglandin even out of 10 to 15%. So the causes could be wrong diagnosis. Maybe the heart disease may not be duct dependent, maybe blocked infusion, very slow infusion rate, or could be already, it's very late, the PDA is already irreversibly closed. So you need to repeat the echo into consider some parenchymal heart disease or PPHN. And you can titrate the dose and check for infusion pump or milrinone. Or then you need to refer, in this kind of babies, you need to refer to cardiologist for cardiothoracic surgeons for urgent interventions. So as a fellows or residents, we tend to attend more transports, particularly cardiac cases. So how to manage these cases? So secure airway first and establish IV access if it is not there, and start prostaglandin. Don't stop prostaglandin during transport. So maintain euthermia and clear communication with the receiving NICU. And one thing you need to keep in mind is for all duct-dependent congenital heart lesions, we start prostaglandin except obstructive TAPC. I tend to encounter during my residency or neonatology when I was transporting a baby from Vijayawada to Banjara Rainbow. So that baby had TAPC which was obstructed. So as a over-enthusiastic resident, I started prostin. That baby luckily saved, but baby had to get sick during the transport. And I learned this after after hand over the baby. So remember that TAPC which is obstructed, prostaglandin can worsen the PG even can worsen the case because of flooding of the lungs. So how do we manage ventilation? So as how we manage other lung parenchymal diseases, minimal and gentle ventilation is required. Avoid hyperoxia, don't chase saturations, and maintain mild permissive hypercarbia so that pulmonary vessels will relax. So sedation if required for systemic duct-dependent lesions, and avoid sudden changes, avoid suctioning unnecessarily, and wean prostaglandin as baby response. So as we know, the algorithm, baby usually present with cyanosis, shock or murmur, C for saturation response with oxygen and echo, then start prostaglandin, stabilize the baby, then refer baby for surgery or cardiac intervention. So my practical tips for cardiology or gynecology over here is, any antenatal suspicion, early plan for in vitro referral, or try to deliver at a center where level 3 or level 4 NICU with cardiac support is there. And any baby has cyanosis, respiratory distress at birth or immediate postnatal period, don't always think about lung disease. It could be cardiac disease also. And most important thing is, for all, for doctors over here is, always don't discharge a baby without doing a pulse oxy screen. It's a very easy and can be done by our nurses also. And practical tips for pediatricians over is, any cyanosis with poor response to oxygen is equivalent to congenital heart disease unless proved otherwise. So if you want to start, if your baby is sick, unstable, start prostaglandin, then confirm the diagnosis. Because don't wait for a cardiologist, you can act immediately, which can save lives. So stabilize, refer, and transport, even during transport, you can use prostaglandin. So take home messages. So this duct-dependent congenital heart disease requires time-critical interventions. Early suspicion is very important, which can save lives. Prostaglandin is safe, effective, and side effects can be manageable. Start prostaglandin early, then confirm the diagnosis later. And teamwork is required, as we discussed. So duct closes silently, but its consequences scream. With a doctor who keep it open. Thank you.
Thank you for the good talk. So as a pediatric cardiac surgeon, I would just like to share a thought. It's a lifesaver, the prostaglandin, we all agree. But if you give it for a longer time, so the duct dilates and it becomes very friable. So even for a cardiologist to put a stent in that, it will be very difficult. And for a surgeon, it's a nightmare to handle the duct, because when you open, when you want to ligate the duct, it may tear. So we always communicate to the neonatologist that, whenever you start prostin, we should start the corrective treatment as early as possible without delay, and it's not safe to keep it longer to keep it more than 2 or 3 days.
Yes, sir, I agree, sir. This is not a cardiac duct. Prostin is not a cardiac duct. It's a time-buying duct. So you are buying time here. So you are saving life here, or buying a life here. So just is a transient process to stabilize the baby and to refer for the specific treatment. Thank you, sir.
It's a well-delivered talk. So, until unless we have a clear understanding of the hemodynamics, it is very difficult to treat a congenital cardiac problem. Oxygen is toxic at one end, it is useful at the other end. When you see a cyanotic baby, don't pump more oxygen, because if it is a duct-dependent lesion, you're going to land in problems. At the same time, when you're using prostaglandins, like TAPVC obstructed, it does more harm than good. You need to understand the hemodynamics. When you understand the hemodynamics, you can play it in a better way. So, both the things, whether it is oxygen or prostaglandin, they're useful in the right time, in a right dosage. And about the sir, how long we can continue the prostin like? What is the time limit like? When you are buying the time, you are more worried about the duct.
As he said, as Dr. Gopikaran said, it is a lifesaver. We all agree. But how long to continue? It's a judgment call basically. Because for example, in some units, they give prostin for a long time, even for if it's babies to preterm baby, baby has to gain weight, for example, transpiration, weighing only 1 kilogram. So they give the prostatin open for even 2 or 3 months together in some units in America where I train. But in our country, we can't afford to do, because you can't, as a neonatologist, you can't keep a neonate, a small weight baby on prostatin for a longer time, because you'll end up in infections and other problems. So it's a judgment call basically, but usually about 1 week of prostatin sometimes also is not bad for taking up the surgery. It's basically a judgment call.
Thank you, sir. Thank you.
Thank you so much, doctors. I request the chairpersons to honor Dr. Jagan Mohan with a memento. I request Dr. Shilpi Reddy ma'am to honor Dr. Chandrasekhar sir with a memento.
Before we move on, while we are talking so much of preventing fetal defects and neonatal birth defects and treating them appropriately, many thanks to one of our sponsors today, and we are going to talk a little bit on preventing pneumococcal infections. Thanks to Biological E. Is Mr. Rajshekhar here? Yeah. Thanks to him and to Nestle Nutrition India for their support for this today's event. And briefly, we're going to finish on pneumococcal vaccination PCV14. So PCV14, as you all know, is the newer addition to the pneumococcal conjugate vaccine spectrum. We are all well aware of PCV10 and PCV13. But PCV14 comes in India with some market advantages. Particularly, it offers protection to 22F and 33F, two phenotypes that have been accounting for an increasing prevalence of invasive pneumococcal disease in India. And so this is the table that shows the grid of various serotypes covered by different PCV vaccinations now available today in India. You can see that with the last bar, which is PCV14, we have protection offered to 22F and 33F. These are two important strains that have been found to account for a significant proportion of IPDs in various studies conducted in India. And although there is no coverage, especially for 6A, 6B, which is a strain that is present in PCV14, offers valuable cross protection to 6A. And this is something that has been demonstrated in multiple studies. So these are studies showing that even among infants who have been vaccinated with a 6B containing vaccine, there was a significant fall in the incidence of 6A strain of pneumococcal invasive infections. Now coming to the burden of the two additional strains that PCV14 offers protection against, which is 22F and 33F, not only are these two strains common causes of infection, they are found to account for a high prevalence of nasopharyngeal carriage in India, but they also are responsible for increased propensity for antibiotic resistance, can cause invasive meningitis, and are responsible for a high incidence of mortality and morbidity. So when it comes to international recommendations, this is CDC recommendation now. It upfront recommends the 3-dose primary schedule and a single-dose 4th booster dose, which is offered between the months of 12 to 18 months when it comes to the recommendation for pneumococcal conjugate vaccination. And these are the number of trials that have been performed comparing Pneumovax 14, which is 14-valent PCV versus 13-valent PCV. So which show that there is non-inferiority in the seroconversion rates for most of the common strains that are covered with both. And when it comes to 22F and 33F, these are two additional strains which are protected only by PCV14 strain. And obviously with these two strains, the seroconversion is present only with PCV14. So I think with that message, I will end this presentation with the overall message that there is ample data now that is supporting that PCV14 when offered in the primary as well as the booster schedule is found to be clinically non-inferior to PCV13, and it offers cross-reactivity to 6A strain, and it is found to be significantly protective against 22F and 33F, which are very important in terms of antibiotic resistance and invasive meningitis, and hence these should be offered to children whenever it comes to offering the best possible choice in pneumococcal vaccination. So thank you, Biological E, and we will move on with the rest of the presentation. I request Dr. Divya to take us forward with the next talk.
Thank you, ma'am. So we are moving forward with our next talk by Dr. Yoganagenda sir, and the topic is Fixing the Unfixable, New Frontiers, Recent Advances in Surgical Management of Correctable Malformations. I request Dr. Mandakini and Dr. Anil Balraj sir to chair the session.
Coming to the topic of the day, neonatal surgery, pediatric surgery, it is advancing so much, and over years actually we are forced to advance. So from what we were doing earlier, actually open operations, nowadays actually we are doing laparoscopy, from there actually we are doing robotic surgeries, and as much as possible actually, we are trying to do single stage surgeries over actually recent advances. And I'm very happy actually we have our actually esteemed Dr. Mandakini and Dr. Anil Balraj with us. They came all the way from actually, sir came all the way here actually. Thanks a lot, sir. And so, frankly speaking, actually, pediatric surgery, again, actually, coming back to the topic, actually, I am telling, actually, we have advanced over years significantly, and every day we are trying to update, and we are trying to give the best possible solutions for the patients. So, we are all going in a PPT, full screen, slideshow. By the way, I am Yoganagenda, pediatric surgeon, chief of KIMS Cuddles, Kondapur, Gachipoli, and Secunderabad. We have a team of 4 pediatric surgeons, and we are just going up at trend. And fetal rights, as I told actually in the morning, actually that is our main campaign. Actually, we are trying to do in Telangana, and proud to tell that actually ours is the first pediatric robotic surgery program in Telugu states. And this is what I am trying to tell, actually, from lab open to lab, actually robotic surgery. It is not an easy journey, as all of you can understand. It is not very easy to move from open to lab to robotic. It is a very tough journey. And just to start with actually how things are progressing, actually, though it is not related to the congenital correctable malformations. So in high intussusception, it is very much close to the neonatology also, because weaning starts from newborn. Means from the 6 months itself, from your age. So we are doing hydrostatic reduction, and we are successful in almost around actually 95% of the cases. So whether to do laparotomy or laparoscopy, this is a big debate, and we are successfully moving on from laparotomy to laparoscopy whenever it is possible and feasible. Coming to the inguinal hernia, it is one of the common things that we see. Even in newborns, actually, inguinal hernia is very good. Laparoscopy is the better option. The only reason being, actually, we can see on the other side and then correct it at the same time. So you are giving a permanent solution to the family at the same time. This I discussed in the morning, actually Hirschsprungs. Earlier we were doing actually 2 stages operations, but whenever it is possible and feasible, and if the colon is adequate, we are trying to go for actually single stage operations. Actually, this is the beauty of the neonatal surgery advancement, because in 10th day, actually the patient is going home without any problem throughout his life. And we are successfully launching this pediatrics colostomy support group actually tomorrow being our National Pediatric Surgery Day. Actually, we want to highlight on this inaugural that we are planning to do as this is first of its kind in actually India, because for parents actually there are no much support groups available in India. So whether we are doing a primary repair or thoracoscopic repair, the answer for TF is yes, actually a primary repair is the answer as much as possible. And whenever actually when it is possible and feasible, we are going for the thoracoscopic repair successfully. Duodenal atresia is one condition, actually it is the only intestinal obstruction where a pediatric surgeon can comfortably do a laparoscopy, because the rest of all the bowel is actually shrunken and very small, so we can access that area very easily, and laparoscopy will be the answer. Colorectal cyst, earlier we were giving such a big cut actually on the body. Actually nowadays actually we are coming up down to very small negligible scars which are much tolerable and acceptable than that big scar on the body. And we have successfully done 2 robotic colorectal cysts in our KIMS Cuddles hospital. So ovarian cyst, another condition. Actually, that patient actually it's operated in our KIMS Kondapur. Actually, it is a 10 centimeters ovarian cyst. Actually, we did laparoscopic ovarian cystectomy by Dr. Manisha and team. So this one successfully we have done, because more than 5 centimeters, all of us know that there is a possibility of torsion. Yes, these things actually we have to proceed. Earlier we were doing actually oophorectomy for most of the conditions, but nowadays we are doing actually, it is a video, but I am not running it right now because of shortage of time. But we are doing actually oophoropexy. Even prophylactic oophoropexy on the opposite side is something that as pediatric surgeons we do, because we have to see about the coming 60 or 70 years of the patient's life. Pyloromyotomy also, actually earlier we were doing actually big incisions. Actually nowadays actually we are able to do actually successfully laparoscopic, and very comfortable, very easy, and overall actually procedure time is going to be more or less same. Thoracoscopic surgeries actually are the real upcoming actually recent advances, where most of the thoracic operations are done by even actually Dr. Chinmay has shown one of the video. This is a diaphragmatic eventration that we have done, actually thoracoscopic repair. Actually you can see there on the X-ray actually how beautifully it has gone down. And this is another actually diaphragmatic eventration and hernia. Actually thoracoscopy is becoming the gold standard nowadays, because it avoids a major thoracotomy scar throughout the life for the patient. Hernia, again I told actually this this is one Morgagni hernia. What I am trying to show is, if at all, if the same patient had to go for a laparotomy, it would have been actually very big cut, and actually it's very difficult to see that area. So this is a beauty actually. If at all, if we see in laparoscopy, we can know what is the real finding. Actually, if you can see, it is on the other side also, other side of the falciparum ligament also, you are seeing a small defect. If I miss that defect, actually, maybe I'll be having a tough time, because actually it looked like a recurrence for the patient, which is not acceptable nowadays. And I just want to take you through this scenario, though it is 8 months old, but it is a surgical problem. That's a neonatal surgical problem. They recently traveled to India, had persistent vomitings and non-bilious vomitings where they're admitted somewhere else, and it is treated as a gastroenteritis. Yes, everyone will treat like that only. Later they got an X-ray done. X-rays were really very interesting. First X-ray was showing like that one small single loop, and we are not able to see a typical X-ray of stomach bowels. And within time only, actually it is at 2 a.m. in the night, and at 5 a.m. actually we got it done. Means if you can see the difference between these two X-rays itself, you can make out that actually the things got settled. So basically now with the clinical conclusion that it might be a gastric volvulus, we went in, we gave the option of 8 months old, actually we gave an option of open laparoscopy and robotic, but patient from US actually insisted on robotic surgery. And robotic, this is the beauty of robotic surgery. Actually this is you can see that there is some ecchymotic patches over that area and some free fluid. This is the only evidence that I had that it is a gastric volvulus. Other than that, nothing else was there. And later when we saw, actually we could see that, so in the CT scan also, if you see, actually the kidney is thoracic kidney, and it is a diaphragmatic eventration also. So we did thoracoscopic repair, actually thorax, robotic surgical repair, and this is the beauty that is given. Actually, the maneuverability of the robotic instruments is too good to believe. Actually, you should come inside the OT to believe what it is. So with this, actually, a successful surgery was done for this patient. Actually, with minimal cuts, their parents are very, very, very happy. And that's why we wanted to tell that robotic precision is significant, and we have adopted this new technology. And this is the transition from all these heavy instruments, and we are slowly, as you can see, actually slowly we are going away and away from the patient, but at the same time the vision is increasing significantly, and we are doing a very good job for the babies. And robotic applications are so many in children, actually in pediatric urology, gastroenterology, thoracic surgeries, and in outside countries, actually many are doing even newborn robotic surgeries, but actually still we did not venture on newborn robotic surgeries. So this is one SSI mantra, actually robotic pyeloplasty, 8 months old. This is the first time in SSI history that actually robotic pyeloplasty is done on an infant, because actually I had to cheat them and take this opportunity. So laparoscopy versus robotic pyeloplasty, robotic ureterectomy implantation. This is one ureterectomy implantation video. I did not want to waste time. So biliary atresia, actually liver transplant is just next door. So earlier we were literally discarding biliary atresia babies, but nowadays because of the recent advances, liver transplant availability, feasibility, we are doing. Anything is possible in pediatric surgery. We are achieving that targets. Thank you very much.
Excellent talk, and then hoping for the robotic in future. As we have seen from the conventional open surgeries during my surgery days, that days I had a thesis, my cholecystectomy. So the future was laparoscopic cholecystectomy is going to be the standard. Similarly, I hope the robotic pyeloplasty is going to be the standard operations in the future. And it gives excellent vision. That's the main difference between laparoscopy or even robot will be going to be more. It's a 360 degrees maneuvering, and then you can do, as you said, that Morgagnis anterior. That repair is very, very tough. Even laparoscopically is also very tough. I think in the robotic can change the whole scene. And you have shown that eventration and then diagnosing the stomach volvulus is very difficult, right? So I hope this is going to be you are going to the pioneering and doing the robotic surgeries in the future. Congrats. Congrats.
Can we check that?
And I think he's laid the path for the rest of us in terms of being futuristic and getting into innovative technologies.
Thank you very much.
Thank you so much, doctors. I request Dr. Yoganagender and Dr. Chandrika ma'am to honor the chairpersons with a memento. I request Dr. Mandakini to come forward. Ma'am. Ma'am. Sir. Okay. So I request Dr. Yoganagender sir and Chandrika ma'am to honor Dr. Anil Balraj sir. Thank you, doctors. So we'll disperse for lunch and meet back after half an hour. We have more amazing sessions planned ahead. 2:15. We'll meet by 2:15 again back here. Thank you, doctors. The lunch is organized in the ground floor in the gynec OPD block.
Is in the abdominal region. If still in contrast, if still there is a doubt, we can inject little amount of contrast, water soluble contrast into the upper pouch, and an X-ray can be taken. The first is an X-ray of pure atresia. The tube was not entering into the stomach. When X-ray taken, the stomach was completely gasless. So most likely, this is a case of pure atresia where the upper and lower pouch are atretic without any fistula connecting into the trachea. The second is a case where there is coiling of the tube in the upper part of the esophagus, along with presence of double bubble sign in the abdominal region, which indicates presence of duodenal atresia. This is a case where we did a contrast to confirm the diagnosis. A small amount of oral contrast or
NG contrast can be given into the pouch and an X-ray can be taken, but we should be sure to aspirate this contrast because aspiration, chemical pneumonitis is very common in these babies and we don't want this contrast to pull or spill back into the chest cavity. The other investigations which we go about in these cases is 2D echo to rule the most common anomalies that are cardiac anomalies, and then ultrasound of the abdomen to rule out any renal anomalies, and if necessary chromosomal analysis as well. Coming to preoperative management, to prevent preoperative management is one of the very important aspects in tracheoesophageal fistula because from the time the baby is born, diagnosed to taken up for surgery, there's a lot of spillage of the oral contents and gastric contents into the lungs, further spoiling the lungs, further soiling the lungs, causing pneumonitis and delaying the recovery of this child. So it's very important that once the tracheoesophageal fistula is identified, some sort of suction is done into the oral cavity. The baby should ideally be placed in a prone position so that the oral secretions can fall out instead of being spilling into the lung, or we can use a continuous double lumen suction wherein a slow low pressure suction is applied into the upper pouch where the secretions are sucked out. Then we can start on IV antibiotics as well as put the baby in a prone or a head up position to prevent any spillage of the secretions. Coming to surgical management of tracheoesophageal fistula can be done in an open as well as a minimal access way. In an open surgery, typically a posterior lateral thoracotomy is done. The fistula is identified entering into the trachea and it is divided. The upper and lower parts of the esophagus are identified and a primary esophageal anastomosis is done if there is a possibility. It was always our choice and our preference to do a primary esophageal anastomosis even if there is some tension because you can avoid a very major surgery at a later date if you are able to achieve a primary anastomosis. It might not be possible in every case because the gap might be very wide in which we might have to divert, but wherever the possibility is there, we'll have to go ahead with the primary anastomosis. These are a few intraoperative pictures, images. As you can see in the first image, the part of the trachea, the part of the fistula is being held by the NG tube. That is the fistula entering into the trachea, and you can see just above that is a small dilatation, that is the upper pouch. Once the upper pouch once the lower fistula is identified entering into the trachea, the fistula is dissected up to the trachea and flush ligated on the trachea, and the lower pouch is dissected. Upper pouch is identified by sending a small sized catheter into from the oral cavity, and by to and fro movement you can identify the upper pouch. The upper pouch is dissected well, and you have to assess if anastomosis is possible. If anastomosis is possible, a primary esophageal anastomosis is done on a feeding tube. This approach can be done either retropleurally or transpleurally. Retropleurally, you can avoid spillage into the chest cavity if there is any leak, and you can prevent an empyema. And transpleurally, normally what we do is once the anastomosis is done, we make a pleural wrap around this anastomosis, which helps in further healing of and preventing leak of this fistula. This is an intraoperative image where you can see the yellow cursor pointing towards the done anastomosis and the blue one pointing towards the ligated fistula. Once the baby is operated, ideally most of the anastomosis are under tension itself. These babies are nursed post-operatively in a flex position. Head extension is typically avoided. Elective ventilation with muscle relaxation is continued for 3 to 5 days. To prevent anastomotic disruption and further facilitate healing. On post-op day 5, that is, if there are no subtle signs of leak, if the child is stable, once extubated, we can give a little amount of contrast to the oral cavity, get an X-ray, and if the contrast on the X-ray shows no leak, we can go ahead and start feeds. This is one of the babies, picture of one of the babies which was operated in KIMS Kondapur. In post-op day 5, we have given contrast, and you can see there is no leak on contrast, and we went ahead and started feeds with the help of a nursing staff. Coming to complications in TEF, early complications, and one of the most common complications that we see is anastomotic leak. Now this leak is every leak to be attended to. Leaks are of different types. It can be a minor leak, major leak, or minor or major leak, depending on if the leak is causing a lot of disruption to the child, causing clinical features, the child is not stable, only then we go and address the leak. Otherwise, we are not going to address the leak. The other complications which you see later on are strictures, recurrent TEF, GRD, and tracheomalacia. Coming to one of the other common fistulas that we see are H type of fistula. These babies are typically don't present in the newborn period because there is no atresia of the esophagus. This fistula connects the esophagus to the trachea in an N sort of fashion. It is called a H fistula, but more like an N sort of fashion. These babies typically present after establishing feed after a few days with recurrent choking, cough, cyanotic spells, as well as pneumonia. But not seen when NG feeds are given in these babies. When the infant cries and sudden abdominal distension is there with a cry, even then you can suspect this. When this condition is suspected, a bronchoscopy or esophagoscopy can help in identifying this fistula, as well as we can cannulate the fistula, and an approach is taken which is transcervical, and we can identify the fistula between the trachea and the esophagus. This fistula is repaired, trachea is closed, and a muzzle flap is placed to prevent any recurrence. In cases where there is pure atresia or the gap is very wide, what we do is called a diversion, wherein esophagostomy and a gastrostomy is done immediately so that the baby can be started on feeds. And once the baby grows up, then we can go ahead with something called a pull-through procedures, wherein we do esophageal replacement procedures. For gastrostomy, we use something called as a Mickey's gastrostomy tube, which is very easy with feeding. For esophageal replacements, it's very important to select a replacement which is an efficient conduit, which satisfies the nutritional status, should grow along with the child, simple and adaptable, prevent reflux, should not impair cardiac and respiratory functions. Various routes are available for doing the surgery: posterior mediastinal or transhiatal, substernal route, as well as transpleural route, and various parts of the intestine can be used for these replacements. The most commonly that we have done are colonic conduits, and other common conduits that are used are stomach conduits, jejunal, gastric tube and reverse gastric tube, and free jejunal grafts. I wanted to present this picture. This is a baby which was operated exactly 5 years ago in this week when I joined KIMS, and the baby is 5 years now. She is a case of tracheoesophageal fistula who had minor leak. This was the only case which had minor leak among all the cases that we operated here at KIMS Cuddles. The baby is 5 years old now, and she's doing well. She excels academically. And all this is possible with an excellent fetal medicine, obstetrics, neonatal care team, as well as neonatal anesthesia team. And again, our teamwork is what keeps us going and helps us in excelling in all the things that we do. So thank you for this opportunity, and I'm happy sharing all this in Pediatric Surgery Week with a lot of pediatric surgeons among us. So good day, thank you.
Just a word about tracheoesophageal fistula. The most important thing is try to send the patient to the neonatal ICU or the pediatric surgeon as early as possible. So all of us know actually there will be upper pouch saliva which is drooling into the lungs. So the more soiling, the more is your mortality risk. That's why whenever we are talking about 75% success rate, that means 25% is mainly because patient is coming somewhere from actually some other say remote center and it is coming to us. So that should not happen. Actually, as pediatric surgeons, we should try to promote this in the public and within the kind of obstetric faculty also, telling that try to refer the case as early as possible, and on table don't waste much of time, and without 2D echo don't touch the baby. So 2D echo is very important because we don't know actually which baby is having which problem, and all the brunt is going to come on to the pediatric surgeon. So we should be very careful. And fistula, yes, leaks, definitely tell the patients, families before only, telling that actually there is a possibility of fistula which is there. So the more and more times actually we talk to the attenders, that is when actually we win the confidence of the patient. That is more important in our practice.
So we have a next session by Dr. Avinash Reddy on the topic of managing diaphragmatic defects at birth.
Good afternoon, everyone. I'm Dr. Avinash, consultant pediatric surgeon in KIMS Cuddles, Secunderabad. So I'll be talking about managing diaphragmatic defects in newborns. So basically, diagnosis is not a surprise anymore now. See, most of the times when a parent comes to us or a mother comes to us antenatally, diagnosis, we already have the diagnosis. So gone are those days where with distress we diagnose CDH and then we operate. So those days are gone most of the times because of beautiful fetal medicine experts. So diagnosis is already given to us in hand, and along with the diagnosis, the parents are very well informed, as well as they know the outcomes, the prognosis, everything. They are very well. We have a multidisciplinary team who talks regarding all of this, and then we go ahead with the management. So surgery is nothing but anatomy. So I just want to tell you, basically brush up your anatomy. We have two types of hernias which are very common. That is Bogdalek hernia, which is posterolateral defects. So you can see on either sides, but most of the times the left side is very common. And Morgagni is in the right anterior and medial aspect. So this is little rare in occurrence, but it is more commonly the right side. So one more defect is diaphragmatic eventration, which most of the times will be present, and it will not cause any symptoms probably. And sometimes we may also have diaphragmatic eventations in some of the surgical conditions, in cardiac surgical conditions also. So most of the important ones are the Bogdalek and the Morgagni hernias. So how do we identify these? Yes, definitely after the delivery. Most commonly just an X-ray is more than enough. If you see on the left side, typical Bogdalek hernia on the left side, where you can see all the bubble loops into the chest. Whereas Morgagni hernia, little difficult to diagnose. We need to have a good index of suspicion. And if you take a lateral X-ray, you can see the herniated bubble. That is most commonly seen in the retrosternal aspect. So eventation of diaphragm, most of them may not go wrong with it, and there will be less spaces seen on the side of eventation. So basically, how do we diagnose CDH is by the prenatal diagnosis. As we already told, most of the times 40 to 90% of cases are diagnosed, and mean gestational age at discovery is generally 24 weeks. So we can identify as early as 12 weeks also. And polyhydramnios gives us a glimpse towards the diagnosis, though it can be seen in many conditions as well. And one important aspect where most of the times we can miss is a right-sided defect, where the liver can tamponate the hernia site and obscure the diagnosis. So if you see in a typical ultrasound picture in a CDH, 28-week gestation in a cross-sectional image of the fetal heart and stomach are in the same plane. So this is the way we diagnose a CDH. So nowadays we are doing a lot of fetal MRIs also in a Has sequence. And if you can see, typically in a 28-week gestation, both the stomach as well as the heart chambers are at the same plane. So why do we do all these? Mainly to prognosticate. So prognostication is very much important, both antenatally as well as postnatally. So antenatally we have lot of indicators for prognostication, but most commonly I think our fetal medicine experts will agree is basically the lung to head ratio, LHR ratio, which is a cross-sectional area of the contralateral lung, not the affected lung, at the contralateral lung at the level of cardiac atria, which is divided by the head circumference. So what we have to memorize is greater than 1.35, definitely there is 100% survival. 0.6 to 1.35, probably 60% survival, as well as less than 0.6, generally it is no survival. So this helps us in probably giving the options to the parents. So definitely if it is above 1, we generally go ahead with prospective management. And if you can see just typical punched prognostic factors is anatomical. Left side generally have good prognosis, whereas right side have little dismal prognosis. And if you see the stomach, liver and spleen into the thorax, generally they have a poor prognosis. So these are just a few things which we should keep in mind. And parental counseling, it is very important because all the prognostic factors have to be told to the parents, and we have to involve them in taking a proper decision. And yes, definitely after we tell the prognostic factors, everything, they might ask you whether they can have any fetal interventions. So generally fetal interventions are there, but in India right now they're not doing much of fetal interventions, but there are some promising fetal interventions. And there are few certain selection criteria where the diagnosis should be less than 25 weeks, and you should exclude all the fetal cardiac disproportionate, that is any cardiac defects. Kindly avoid doing fetal interventions. And definitely the LHR ratio is very important. Favorable LHR ratio, please go ahead with a fetal intervention. Liver herniation, generally we try to avoid any fetal interventions. So what are the options available for in utero interventions? We have typical exit procedures or complete in utero repairs. We have exit procedure, but it has to be done at around 28 weeks to get the complete benefits. So we have plug techniques. We plug the endotracheal, that is with foams or glues, basically, and endo plugs also. These can be done with endoscopic procedures as well. So less risk of all the complications like any other fetal interventions has. So these plugs and endo plugs, plug techniques, they help in expansion of the lung. So that is, the future lung will be expanded and available for gaseous exchange. So perinatal treatment, yes, definitely. Once we have identified the problem, we have to make sure that the mother is delivered in a properly available center, where preferably ECMO centers, or at least they have proper ventilation techniques or ventilation equipment. So timing of delivery, exactly, it is just close to the term. So no need to do any preterm or post-term. Cesarean section, if you ask me, definitely it's not a indication, but most of the times what happens is we are already informed in the diagnosis, and we have a proper controlled environment. So better to go ahead with an LSCS in a proper controlled environment and do it as well. And major concerns, yes, if the patient is delivering in any other place, preferably we want to deliver in our own center, but any other place, please keep in mind the pulmonary hyperplasia, so that you have all the adequate ventilations and pulmonary hypertension. So after this, if once the baby is delivered, neonates without a respiratory distress requires just a nasogastric insertion. Most of the times this doesn't happen. There might be some or the other distress associated, so requiring intubation, ventilation, and so what I want to emphasize is, it is CDH or diaphragmatic defects is a physiological emergency, not a surgical emergency. So this is a very good example of how a physician as well as a surgeon can manage a condition beautifully. Like the physician takes care of the initial part and the surgeon does a finishing job. So preoperative stabilization, which is a common word, you all are aware, and this is the primary goal. And in preoperative stabilization, it involves the mechanical ventilation, taking care of pulmonary hypertension, and it is a topic by itself, which most of the neonatologists do present. And surgical aspect, if it comes towards surgical aspect, it is straight forward and no controversy at all. Just what we do is close the defect. So what next? So definitely hand over it to the neonatologist for stabilization, and please assure the obstetrician also that we are all towards in the care of the baby. So obstetrician is very important, because all of us have come to a confirmed concluded decision. So what are the things which are worrisome to the neonatologist is the persistent hypertension and adequate gas exchange, as well as parental pressures. So these are the things which they take care and present to us. So operative approach, as I said, just we have open lap, so many things we can do. Just open the abdomen, close the defect, It doesn't look like that. It's presented very simple, but we do face a lot of challenges in doing that. So if you can see, it's a simple, straightforward, where we close the defect, and sometimes when the defect is too large, we can place a mesh for a closure of the large defects. So if you see minimal invasive surgery nowadays, I think Dr. Yoganagender has already shown us his beautiful work he has done, and we have different positions for different hernias like Morgagni and Bogdalek, but most of the times we can achieve thorough and adequate surgery with minimal invasive. To emphasize you, if you can see the baby, the instruments what we use for a laparoscopy are much bigger than the baby. So these are the instruments which we use for laparoscopy, and robotics, as of now, we don't have the technology available for neonates as well. And maybe in future we may get the technology, but as of now we are doing a lot of procedures in infants. So this was one of the case of a CDH. We did a thoracoscopic repair. You can see the scars, hardly any scars, with a very fast recovery, and definitely fast recovery will have a cost-effective treatment. So like any other procedure, we have complications early and late. So most of the times early post-op are taken very very easily, like air leaks and PPHN with lot of medications. And GERD is one complication which you can expect initially and may also prolong for a long term. And sometimes skeleton abnormalities and chronic lung issues if the lung hypoplasia is severe. And one more important one is the neurodevelopmental problems, which nowadays have a lot of emphasis on, and that also has to be taken care during the stay as well as post discharge. So outcomes, definitely survival rates of isolated CDH have improved dramatically. We can say more than 90%. Major predictor of survival is resolution of the pulmonary hypertension, and in survivors, please do monitor the chronic lung diseases, developmental delays, nutrition and growth problems. So to conclude, actually we are conducting a National Pediatric Surgery Day tomorrow in KIMS Cuddles, Secunderabad. I would like to invite all of you, and this time the theme for the National Pediatric Surgery Day is safe surgery for every child. So that means like every child should undergo a safe surgery. So how do they undergo a safe surgery? Is having first the safe environment, that is a proper hospital, then safe anesthesia. Yes, definitely it can not be more emphasized than that. And not last but not the least, the safe surgeon. So improvised your surgical skills and experience, a safe surgeon can provide all of these together and give a good outcome. Thank you.
Thank you so much, Doctor. Yeah. I request Dr. Yoganagender sir to honor Dr. Avinash Reddy sir with a memento.
Rhinitis. This can cause thrombosis, which can cross the placenta and cause thrombosis of the blood vessel in the fetus, resulting in segmental disappearance of blood supply, leading to atresia. And the classification is almost similar to dural atresia, but the only thing is there is type 3B, where there are two blind ends, and the distal end is usually coiled around a single mesenteric vessel. The ileum is coiled around a single mesenteric, like an apple peel, ending at cecum. And type 4 is multiple atresias. And the latest recent addition to this classification is type 3B JIA, which is nothing but, as said, in apple peel atresia, the distal loop usually coils around the single vessel and opens into the cecum. Whereas in this, the distal loop coils around the single vessel. Thereafter that, we'll have some amount of normal ileum which joins the cecum. This is the recent addition to this classification. And only one case has been reported worldwide. And clinical presentation is almost similar. In both these atresia, sometimes babies pass meconium. So that's the reason why if a baby passes meconium after birth, it doesn't mean that baby doesn't have any obstruction. Most of the times prior to this vascular accident, the meconium might be formed in the distal bowl, which gets emptied. And this is a triple bubble sign, which is compared to double bubble sign, it is a proximal jejunum, that's a third bubble, and sometimes distal atresia even are found with like dilated bubbles with multiple levels. And usually when there is ambiguity or X-ray like multiple air fluid levels, dilated bubbles, where diagnosis is not accurate, we usually do a contrast enema which shows unused colon, microcolon. And the treatment is we usually resect the dilated part and we do anastomosis. And ARM is nothing but anal atresia. So anorectal anal atresia can be divided into 3. Immediately after birth, we do a invertogram or CTPL where we determine the level. For low anorectal malformations, which has been recently done in Kondapur, so usually the meconium pearls that we see are indicative of the low ARM. There we can directly do a single stage anoplasty, whereas for intermediate and high ARMs, we usually do staged procedures. And coming to us, the Hirschsprungs, it is one kind of obstruction which is not mechanical, it's functional. It is mainly due to failure of the neural crest cells to migrate through the entire colon, which is, these neural crest cells do not migrate because of the early maturation differentiation. The other theory is they reach the distal segment, but they fail to survive in the in-hospital environment. And there are many congenital anomalies that are usually associated with Hirschsprung's disease, like Down syndrome, neurocristopathies, Smith-Lemli-Opitz. And coming to classification, therefore, the most common what we see is classical segment, where it extends up to the aganglionic zone is the main thing that is responsible for the obstruction in this aganglionic zone prevents propagation of peristaltic waves that results in obstruction. The aganglionic zone in classical segment is still sigmoid, whereas in long segment, it can go up to splenic fracture, sometimes even hepatic fracture. In total colonic aganglionis, the entire colon doesn't have ganglion cells that helps in peristaltic movement, and it extends up to terminal 50 centimeters of ileum. And TIA, also called as Juiceless disease, the entire duodenum till anus, there are no ganglion cells. And so okay, I'll cover the last important points. So the main important thing in Hirschsprung disease is the plain X-ray. In plain X-ray, we usually show dilated bowel loops and absent rectal gas shadow. This absent rectal gas shadow is the one that gives us a clue it might be HD, along with the clinical finding of failure to pass meconium in the first 48 hours of life. Thereafter, we do a contrast enema to confirm the diagnosis. In a contrast enema, the classical coning as seen in the first picture, narrow aganglionic zone, cone-shaped transition zone, and proximal dilated zone. This classical picture is sized to HD. Once this classical picture is identified, there is no need for further rectal biopsy. And the common finding after rectal biopsy in Hirschsprung's is absence of ganglion cells in the submucous and myenteric plexus and presence of hypernerved bundles. And the stoma that we do in Hirschsprung's is called leveling colostomy because we decide the level because we do stoma at the level of ganglionosis. Means in the dilated part where ganglion cells are present. That's why it's called leveling colostomy. And there are two types of procedures, staged and single staged. Both we are doing both recently. We do single stage laparoscopic assisted transanal pull through where we do a laparoscopic biopsy first. We'll send it for frozen section. Thereafter we start transanal method and we wait for the biopsy come. In the meanwhile, once biopsy is confirmative of the ganglion cells, we do a colo-anal anastomosis. But still staged procedures are gold standard, like in Duhamel's where we do a leveling stoma at newborn period followed by Duhamel procedure in the after 9 months. So this is a case of Duhamel pull through which it's a long segment where we did a stoma in the splenic fracture region. Thereafter we did a pull through at 10 months. This child now has a normal bowel movement. He passes stool only twice a day. There is no incontinence or there is no constipation. Thank you.
Thank you so much, Dr. Ashish. I request Dr. Yoganagender sir to honor Dr. Ashish sir. So, thank you so much. We're taking a small detour to the neurosurgery module right now. So, I now call upon Dr. Jayant Krishna sir to give a talk on microarray, exome sequencing and counseling families in fetal structure defects. I request Dr. Venkat Priyanka and Dr. Neha Reddy to chair the session.
CV slide ఇది కాదు. Done. Good afternoon, everybody. I think I'm audible enough. So I have 20 minutes, okay. So I think today we had a very nice discussion in the morning with Dr. Neha about the fetal malformations, when to suspect and what tests to be done, and the very quick overview. We'll be dealing this in detail today. So today I'll be covering about the current updates of all the prenatal genomic tests available, and what are the exact tests, what are the each test and basic concepts of them, when do you do that, and what are the exact indications of invasive prenatal testing, and the current evidence and guidelines for fetal whole exome sequencing. Now, I think everybody knows that we are using whole exome sequencing left, right, and center, but do we have enough evidence to order it in every patient? And a special emphasis on when not to do fetal whole exome sequencing, and that is more important. And ACMG actionable genes, I'll just talk about this as well. And last little bit about expanded carrier screening. I'll be covering these in this talk. So these are my references. I'll just quickly overview. All the clinical guidelines come from International Society of Prenatal Diagnosis and an International Fetal Genomics Consortium. All the molecular genetics and molecular pathological diagnosis come from ACMG and ACOG, along with AMP. Most of them US based. So I think with fetal medicine, it's not just one person. It needs to be a multidisciplinary team for sure. Even a geneticist, an experienced geneticist, would lack extreme details about pediatric neurology or any antenatal finding which a radiologist could pick up or a pediatric neurologist could pick up. It's a teamwork. You need fetal medicine consultant, fetal medicine radiologist, neuroradiologist. Now we have pediatric neuroradiologist also as a specialty, clinical geneticist, obviously obstetrics, the primary physician, a genetic counselor, and a pediatric neurologist. So all of them will be involved in counseling or dealing with a structural anomaly in a fetus and counseling them. So quickly, I'll just quickly rush through the basics. We know that the DNA, the genetic material, is compactly packed inside the cell in the nucleus. So whenever we're talking about chromosomal disorders, just imagine the chromosomes as a book or a novel in a rack, in a book rack. And if you open the book, inside that each page would be a gene, and in that each line would be a variant or a spelling of that nucleotide. So you need to understand these basically, because based on that you'll be ordering a test. For example, if you're suspecting a chromosomal disorder, and if you send whole exome sequencing, it would be normal and the test would be waste. Or if you're suspecting cystic fibrosis or sickle cell anemia or any single gene disorder and you send chromosomal microarray, and if it's negative, it doesn't make any sense. Obviously, you need to order the right test, so that you need to understand the basics first. So we all have a very special emphasis on chromosomal disorders in fetal anomalies, but single gene disorders are also very undermined. They are also very common. According to WHO, it's like 1 in 100. So that's the main problem. So we'll have to look for single gene disorders also. So as Dr. Neha discussed, congenital anomalies, like if you have high risk NIPT or ultrasonographic abnormalities, the yield of karyotype is only 30%, with an additional 6% with CMA, chromosomal microarray. But nearly 50 to 60% of these anomalies go undiagnosed. So that is a real problem. So 2015 to 16, there was an extensive research which happened, and then came the horizon of extensive sequencing era. That is next generation sequencing. So since then, it has changed, the diagnostic yield has increased, but it also came with a lot of problems, ethical concerns as well. So let's quickly look at what are the tests do we have available they're easily available in all the cities. Starting with karyotyping, it will look at chromosomal structural disorders like aneuploidies, rearrangements, isochromosomes, ring chromosomes. Chromosomal microarray is going to look for microdeletions and duplications. FISH, if you know exactly at which chromosome to look at, you can order for FISH. And now this is the new one which is coming, which is called low pass whole genome sequencing. it is a whole genome sequencing at a very low depth. So recent studies, there is enough evidence that low-pass whole genome sequencing is much superior to chromosomal microarray in detecting deletions, microdeletions. But we don't have enough guidelines and evidence. So still the guidelines, all the ISPD, ACMG guidelines still say we go for chromosomal microarray. But most of us have actually started using low-pass whole genome sequencing, which is pretty cheap. These are the chromosomal tests. When single gene tests, we have Sanger sequencing. This is targeted testing. But this need to be clear here. Though you know the first sibling diagnosis, you have the exact gene, then only you do amniocentesis and look for that particular gene. This is called targeted sequencing or Sanger sequencing. Whole exome sequencing, you look at all the significant clinical exome which are clinically relevant. Panels and clinical exomes have now we have stopped using it. Whole genome sequencing has come up in the last couple of years and it's available in Hyderabad as well. It's expensive, but when whole exome sequencing is negative, you can go for whole genome sequencing. But with fetal sequencing, its whole genome is not yet, it's only experimental. We have other tests like MLPA for spinal muscular atrophy and DMD, and very rarely methylation studies. So this was a one study which actually compared, and if you see this low-pass whole genome sequencing, the copy number variation detection is pretty high. It's as good as chromosomal microarray, and which few studies say that it's superior to it. But I think this is going to be the future of medicine, I mean genetics at least. I think CMA will go away and we have whole genome sequencing at a low resolution. So quickly about NIPT, we have the traditional NIPT. NIPT is only going to look at known chromosomal disorders like chromosome 18, 13 and 21, mainly focusing on that. It is non-invasive, you take a maternal sample, so you don't have to do an amniocentesis. But we have something called advanced NIPT. It's not available in all the centers. Now this is aiming to look at all the chromosomal disorders. I mean, not the microdeletions, at least aneuploidies and other chromosomes. Coming to invasive prenatal testing, as Dr. Neha already discussed, like we have specific structural abnormalities, like not soft markers. If you have 2 or 3 soft markers, then you suspect that there's some underlying chromosomal disorder. You start doing karyotyping and CME. So what are the indications is high-risk NIPT? So these guidelines are again by ACMG and ISPD. And significant fetal anomalies, like for example, it's not just a soft marker, you have a significant anomaly, like 2 or 3 systems involved, you definitely have to rule out an underlying chromosomal disorder. And a strong family history, even in the absence of any fetal anomalies, you have recurrent abortions, something like that. A strong family history, you have to go for chromosomal microarray and karyotyping. This is pretty clear, we all know that. Coming to fetal whole exome sequencing, this is something new and very controversial. There are clear-cut guidelines given by ACMG and ISPD to avoid controversies. The first indication is fetal anomalies with normal karyotype and CMA. That means you have a clear-cut anomaly in the fetus, and you have done karyotyping and CME and nothing has come up. Then you go for whole exome sequencing. It has its own downsides because you have to wait again, you have to preserve the sample, but you don't send whole exome sequencing right away because you have a lot of confusions. Once you do karyotype, CMA, it's normal, then go for whole exome sequence. That's what the guidelines say. Second indication is recurrent similar unexplained anomalies. For example, last time also there was a term, there was a miscarriage and the fetus had anomalies and CMA and karyotype came out to be normal. And this time we have the similar anomaly coming up. So that means that there's some genetic disorder or autosomal recessive disorder that was missed last time. So you can directly do for whole exome sequencing in the fetus. Third, specific genetic suspicions. Like for example, there are clear-cut features of skeletal dysplasia, or if you see the long bones are very short, or if you have any specific disorder like craniosynostosis, if you have fetal anomalies which are very suggestive of some specific single gene disorder, then directly go for whole exome sequencing. For this is very gray zone again. Some might feel I have a specific phenotype, some might feel the phenotype is not yet there. So then came the concept of deep phenotyping. Deep phenotyping is a concept where we use in postnatal kids, pediatric age group, wherein it's just not clinical features, it's unifying all the investigations, like use the clinical features along with investigations, genetic testing, X-rays, MRI all together, put up a diagnosis. That's called the phenotype. And we can do that in fetus as well. That's called the deep fetal phenotyping. So this is a new term. So we don't have a standard phenotype. For example, Meckel-Gruber syndrome has this type of phenotype. We know there are few features, but we don't have a standard, this is the exact phenotype of this syndrome. So to increase awareness of this, Human Phenotype Ontology has agreed with the International Fetal Genomic Consortium. We have now developing data on fetal phenotyping. So one more thing, the fetal phenotype evolves with age. You might have to repeat the scans and see for more changes. And one more thing, fetal MRI brain. I think if you don't have enough information on what anomaly you are dealing with, then go for fetal MRI. You'll get high resolution imaging of the brain. So these are some of the single gene disorders which have a clear fetal phenotype. So in this, if you have a clear phenotype, you can directly go for whole exome sequencing in the fetus. These are some of the examples like achondroplasia, camptomelik dysplasia. Most of these are skeletal dysplasia. If you have clear evidence in the bones, you have deformity of the bones, the length of the bones will be shorter. Even Noonan syndrome also has a typical phenotype, like you can have nuchal translucency, which is high. I mean, along with that, you can have pulmonary stenosis, osteogenesis imperfecta, again, other single gene disorder. All these disorders, if you do chromosomal microarray, everything will be normal. You have to go for whole exome sequencing. So this is again a very important slide. I'll just slow down here. When do you not do prenatal whole exome sequencing? Why am I focusing more on this? Because unnecessarily, if you do whole exome sequencing without a clear fetal phenotype, there are two results of it. Either you find an answer, you reverse phenotype. For example, you did whole exome sequencing and you found a gene which is causing skeletal dysplasia. And you open that in the OMM, you see all the features of that skeletal dysplasia. You match with the fetus. If there's something matching, then that reverse phenotyping has worked. That means you can go for termination. The second one is a danger one. You find a variant of uncertain significance, and you don't really know whether this gene is matching the fetal phenotype or not. Again, you'll be stuck. I mean, you refer to specialists and you won't find an answer. So before that, you have to decide whether to send whole exome sequencing or not. So you have legal, ethical, social, and all clinical dilemmas if you send whole exome sequencing in the fetus without a clear phenotype. So clear phenotype is very important. So one, I think a common question, a family comes and the first child has autism spectrum disorder. They have never done genetic evaluation in the first child. Now the mother is conceived. They want to look for genetic causes. We right away say no to them. Because you need to find the genetic disorder in the first baby. Without that, it's like the needle in the haystack. You'll never find an answer. Second one, another problem is that some relative of them has some genetic disorder, like cousin has a genetic disorder. So my baby can also have, why don't you do fetal like whole exome sequencing? And rightly say no to that. So never go with a vague phenotype. For example, you need to have an exact genetic answer for the previous sibling or an affected family member, then only you specifically go and look for it for targeted testing. Without a clear phenotype of the current concept, I mean, for example, the phenotype of the fetus currently you have is very non-specific. You have only few findings which are not fitting into any syndrome. That could be very non-specific. Even in that case, don't go for whole exome sequencing. You do more phenotyping. I mean, you test for more. I mean, you get a fetal MRI, try to understand what is going on. For example, you have asymmetric ventriculomegaly. Left side it's 11, right side it's 13. Very borderline. You don't have any other anomaly. I mean, one of the radiologists said that there's thin corpus callosum. Again, these two are very non-specific. I mean, in this situation, I think you should go and get an MRI. Fetal MRI would actually make you understand, is it partial agenesis? Is it complete agenesis? Do you have associated vermis hyperplasia, pontocerebellar hyperplasia? All that needs to be coming. And you have a clear phenotype of the fetus and then only go for whole exome sequencing. And again, even if you do all this, if you don't explain the couple about what is the outcome of this test, the parents will think that you get a positive or a negative test. Positive means then, there's some disorder. Negative means they're 100% sure that there won't be any genetic disorder. So you have to explain them exactly what is this test going to look and what is the sensitivity, what are the downsides. You have to take a pre-test counseling, you have to do the genetic testing and do a post-test counseling also. The pre-test counseling should include all of the outcomes of that test. Sometimes, fetal exome sequencing should be followed by trio-exome sequencing. For example, you have variant of uncertain significance in fetus, then you have to test both the parents. I have done that once for one of the variant. And incidentally, I have found a gene in the father which causes young onset Parkinson's. He is around 40 years and he also already has tremor, which was diagnosed as essential tremor. And the father was devastated because he was looking for answers in the fetus and he got a diagnosis. He never came back to me. He was very upset with the diagnosis. So again, you should be talking about what are the outcomes of this. For example, if you're looking at some fetal anomaly, you find a gene which causes cancer. The ACMG says that you have to report that because it's an actionable gene. So you have to explain that, you're looking for something, you may find something which is not related to this also. You have to be ready for that. You have to take consent for that. And the biggest dilemma, again, you all know, variant of uncertain significance is a nightmare for anybody, for a geneticist, for an obstetrician, for everybody. So to avoid that, I think you need to think before you send prenatal exome sequencing. So these are the challenges. If you see sample size is a problem, you have already sent for karyotyping, already sent CMA, you have to store another sample for exome sequencing. And the timing, sometimes a fetal phenotype takes some time, 30 weeks, 28 weeks, late diagnosis. Again, you said a whole exome sequencing, it's going to take at least 2 to 4 weeks. Rapid sequencing 2 weeks, normal sequencing 4 weeks. Advanced maternal age is again a problem. So all these are the technical challenges. I won't go into the details. So this is a very important slide. Any test, any genetic test, even a simple karyotype, you have to do a pre-test counseling. You have to make the couple sign the paper. You have to do the genetic test and then do a post-test counseling also. So how do you handle VUS? I'll just skip this because of the time. So these are the actionable genes. ACMJ clearly says that even if you're looking for something else, but you find this secondary finding, you have to report them, despite the parents want it or not, because these are actionable genes. If you identify them early, you can screen them. So there are 3 categories of these genes. One category is cancer predisposition genes. Second is cardiovascular risk factor, and third is metabolic. So these don't primarily say that you will definitely have the disease. They are predisposition genes. So you have to report them. So as of now in 2025, the latest update, there are 84 actionable genes. So you have to mention the parents that you might find something you're not looking for. So one more example, prenatal exome sequencing report has, we had a gene recently, which causes susceptibility for autism spectrum disorder. So there are some genes which causes susceptibility. So you have to understand, just because the gene is positive, you can't go for termination. You have to involve a pediatric neurologist. You have to understand the gene. There are a lot of genes. On the left-hand side, if you see, these are all the genes which cause, they mention that they are susceptible to autism. They don't necessarily cause autism, because autism is a multifactorial disease. You need to have environmental factors, prenatal factors, pregnancy factors, and also genetic factors play a very small role in it. So just because the susceptibility gene has come, you can't terminate. So you need to understand this. So for that, you need to obviously consult a pediatric neurologist, preferably. On the right side, these are the genes which definitely cause autism spectrum disorder and a syndromic association. Like, for example, Fragile X, tuberous sclerosis. Definitely you're going to have the disease, and autism is one of the feature of that. Finally, expanded carrier screening. I think you should cut down more of whole exome sequencing in the fetus. You have to offer expanded carrier screening. I think in the US and in other developing countries, they are making universal. It's called universal expanded carrier screening. All the couples, in India, we have specific indications. For example, if you have history of consanguinity, history of any one of the parent being affected or a family member having genetic disorder, you offer them carrier screening. So carrier screening, there's no confusion. Carrier screening, you're only going to look for autosomal recessive disorders of both husband and wife. If both husband and wife are carrying for the same disease, then go ahead with prenatal testing, with amniocentesis, with Sanger sequencing, targeted. For example, one of the couple has they have 3 genes identified. One is sickle cell, one is thalassemia, third is cystic fibrosis. Both of them are carriers. So you have to look for all 3 genes in the amniocentesis. That's one of the example. So why is it so important in India? Again, the consanguinity rate in South Asia and especially India is very extremely high when compared to other countries. So that even makes it more important for us to do carrier screening. And we check for approximately around 2,500 disorders, which are autosomal recessive, along with Duchenne muscular dystrophy and spinal muscular atrophy. Okay, just quickly to overview, antenatal malformations identified on the scan, see if they're isolated or associated. Look for other organ system involvement, look for associations. Prefer advanced imaging techniques like fetal MRI. Use them and try to understand the phenotype. Narrow down the phenotype. Deep fetal phenotyping is a must before you order any test. Second, detailed family history is obviously very important. Consanguinity, think of autosomal recessive disorders. Miscarriages, think of chromosomal disorders. Previously affected siblings, again think of autosomal recessive. Sibling deaths. Symptomatic parents, think of autosomal dominant disorders. Extremely important to delineate and what you are dealing with. Based on that, you can send the tests. Choose appropriate tests accordingly. Sanger sequencing, if the previous child has a very specific diagnosis. Chromosomal microarray for suspected fetal anomalies, the CMA and karyotyping as first line. And if both of them are negative, you can go for whole exome sequencing in the fetus. don't forget pre-test counseling and post-test counseling. And consider preconception carrier screening in consanguineous couples. If a couple in India comes to you actively saying that no, there's no history of consanguinity, we still want to get expanded carrier screening, you have to say yes for it. If they opt for it, you give it. Because we are not going to have variants of uncertain significance. Yeah, thank you. I can take up any questions. Dr. Yoga sir has a question.
After all these results,
fetal rights,
yes. Next baby also might be having the same problem. Actually, how will you tell them to stop procuring kids, or
No.
you will tell them to adopt, or how are you going to?
Sir, we try to do, so for the first demise is there, we advise fetal autopsy also. Fetal autopsy plus all genetic workup. If everything is still negative, there's still a chance that there could be a genetic etiology to it. And there are subsequent multiple pregnancy losses like that, and the final option would be donor egg or donor sperm or go for IVF. That's the last option.
Excellent.
Or
Very good.
adoption.
Very nice talk.
Yeah.
Thank you very much.
Thank you, sir.
Thank you so much, Dr. Jain, sir. I request you to please honor our chairperson, Dr. Venkat Priyanka.
Next, we move on to our neurosurgery module. So we have Dr. Sheena Ali. She is joining us through Zoom. She is a consultant pediatric and fetal neurosurgeon. She is currently attached to Bhai Jerabai Wadia Hospital, Mumbai, and Lilavati Hospital in Mumbai. She is doing some really good work in fetal interventions. Including spinal dystrophism and complex hydrocephalus and this craniofacial surgeries. And she is trained in this fetal neurosurgery. And she's a family friend of mine. So I request Dr. Sheena Ali to take on the topic of fetal MMC repair, boon or bane.
Hi, good afternoon, everybody. I'm Dr. Sheena Ali. I'm a practicing pediatric and fetal neurosurgeon at Wadia Children's Hospital in Mumbai. I would like to thank my dear friends and colleagues, Dr. Ishita Singh, Dr. Vishwanath, and Dr. Savitra Shastri for this, and of course the entire organizing team at KIMS Cuddles for this wonderful opportunity in spreading awareness for something that is so close to my heart. So the therapeutic aspect of a fetus as a patient can be best tackled from a neurosurgeon's perspective with regards to open spina bifida. So it remains one of the most common congenital CNS anomalies in the world. It is a global disease and is rampant here in India with around 13 to 17 cases per 10,000 pregnancies. So not only is the knowledge of this anomaly at its respective gestational age essential for timely diagnosis, it can be tackled ethically with timely intervention, even postnatally and even better antenatally. So medical termination of pregnancy might not always be the solution. So here is a world map marking the prevalence of open spina bifida in red and orange, as you can see, with a greater occurrence in parts of the Indian subcontinent, Southeast Asia, Africa, Central America, and of course, the Indian subcontinent lights up as well. So this is why the Global Alliance for the Prevention of Spina Bifida was actively involved in the prevention of this disease with folic acid fortification. However, it only prevents around 23% of all folic acid preventable neural tube defects. So implying that only 58 countries have mandatory folic acid fortification worldwide. In India, this project has been taken up around 30 to 33 years ago. It's still ongoing. There has been no particular consensus till now. Yes. So in postnatal repair, we commonly encounter myelomeningocele as pediatric neurosurgeons, whom we ideally surgically repair within 72 hours. So the disease, as we know, has a variable course and an awful morbidity. So the surgical repair of such a small defect, as you can see in the picture here, this child would still be subjected to crutches and AFOs and probably a 40% chance of shunting. A slightly larger one would have around a 40 to 60% chance of shunting. And finally, a large myeloschisis like this one here would have a 100% shunt rate with an expected mortality by around 15 to 20 years of age. So, in fact, these lesions are also predictors for the severity of hydrocephalus, with an almost 100% chance of hydrocephalus noted in those with larger lesions, especially in the thoracic area, which is higher. And of course, this reduces the lower we go. This brought about the rationale for fetal surgery and the very famous MOMS trial, as we all already know about. What does it explain basically? So while the two-hit hypothesis explains that there is a defect in primary neurulation at the 4th week of gestation, which is usually within 21 days, that might be the primary culprit. It is ultimately the exposure of this abnormal extruded neural tissue to the neurocytotoxic amniotic fluid, causing the dreaded sequelae of this very common CNS birth defect, which is of course compatible with life. So the MOMS trial rationale states that a protective scaffolding can help to provide a protective plane between this exposed and extruded neural tissue and the amniotic fluid. So not only did it show a reduction by about 40% in shunting rate, but also a reversal in KRE2 and improved ambulation by 30 months of age by at least 2 motor levels. So again, here I'll just briefly go through the primary outcomes again. You can see that the placement of the shunt in the prenatal surgery group has been reduced by around half. You can also see that there is a reversal in the brainstem kinking. Again, when we come to the secondary outcomes, there is an improved ambulation by 30 months, and there's an improvement in the motor levels by at least 2 motor levels. So So in fact, the MOMS 2 and MOMS 3 further reiterate these benefits with respect to other aspects like a 6 times improvement in neurological continence, thus making this venture very wholesome and valid. So this is why the American College of Obstetricians in America, they insist on offering fetal surgery to a mother who has been diagnosed with open spina bifida. So I've had the pleasure to be the mentee of Dr. Samir El-Baba at Orlando and also privy to research his cases which he had operated earlier in St. Louis Hospital, which is in Missouri. So it made it a fact total of over 100 patients, which I had researched and seen firsthand as well. So our patient selection was based on the inclusion criteria of the MOMS trial. In short, it was a myelomeningocele or a myeloschisis between the levels of T1 to S1 with anal Chiari malformation type 2 with a documented normal karyotype. So following the ANC ultrasound diagnosis, a confirmatory fetal MRI is usually done between 19 to 23 weeks. Localization and confirmatory diagnosis is of utmost importance because unlike our routine patients, we have never really met this patient before. So we also employed the use of other aids like the use of 3D printed fetal models. It helped to better our surgical planning. As you can see here, it also helped us in identifying the ideal patient, because many times a bunch of patients will go into exclusion criteria. When you actually see them, when it's in your hand and when it's a 3D model, you get a clearer perspective and an idea before jumping into your case. Of course, this was then followed by an amniocentesis wherein a karyotyping and a microarray analysis is done. I always say teamwork is dream work. So fetal surgery requires a well-trained group of anesthesiologists, OBGYNs, neurosurgeons, neonatologists, besides, of course, good, capable ground staff and technicians. So there is a sonologist or one of the members of the maternal fetal medicine specialist team who monitors the baby by checking the heart rate every 3 minutes. So we give in a mixture of bringolactate and vancomycin as the amniotic fluid substitute. This was used by the American group. A couple of groups in the UK, they like to take out the amniotic fluid in a separate jar and then they infiltrate the same and recycle the same amniotic fluid of the mother. Between the time period of 19 to 26 weeks of gestational age, we take a typical fan and steel incision or a vertical midline incision and we deliver the uterus. Very important, the lesion is confirmed once again on intra-ultrasound. A bloodless hysterotomy is done using uterine staplers or box stitches. So an important point is that unlike a normal cesarean, the placenta must be preserved. So the incision is usually posterior when the placenta is anterior and vice versa. So here is, as you can see, the back of the baby being exposed with a cystic type of myelomeningocele. Here are some with the flatter placode. We then proceed to one of the most important steps which we also do in our postnatal repair, which is the placode dissection. So we do a sharp circumferential dissection around the placode. As you can see, we're also employing the aid of hydrodissection, water dissection, helps to define the planes even better. This brings us to one of the most crucial steps. Very little has been spoken about this in literature. This is known as placode neurulation or tubularization, wherein we do pile-to-pile sutures with around 8O or 9O proline. It is important to recanalize the spinal cord and make it as anatomical as possible. Sorry, the video is in, yes. Yes, this is then followed by a dural closure, a watertight dural closure, and subsequently a skin closure. So the uterus and placenta are then sutured back in a watertight fashion and then they are reverted back into the abdomen. The baby is ideally delivered by a C-section by around an average age of 34 weeks of gestational age. All this seems very doable. So let me elaborate a bit more on the smaller defects. The smaller defects are the ones we consider which are less than 3 centimeters. They were, of course, closed primarily, as you can see here, in a typical 2-layer watertight closure. Those with medium-sized defects, we employed the use of acellular human dermal matrix alloderm as an inlay graft. So you place the graft within and you suture the skin over. And those with the large defects or the myeloschisis, we would use an onlay graft wherein the same alloderm graft would be sutured on top of the skin. You would be surprised that even these ones with the large defects would show wonderful wound healing even after delivery. Just show you a couple of clinical pictures as well. So, yes. So here is an MRI of the baby, so of the fetus after repair at around 25 weeks of gestational age. And here you can see at 32 weeks, you can appreciate the wonderful Chiari reversal. I don't know if it's visible on the screen. And you can also see the wonderful CSF cleft around the site of the surgical repair. So once the baby is born, we do a very basic and early functional assessment. You can see the nice with toe, ankle, knee and hip movements in these babies. This is a functional assessment at around 12 months of age. And this is at around 36 months of age. Whereas at Orlando, we only had 3 cases of tethering and 1 asymptomatic case of inclusion cyst. An important technical note is that placode neurulation was done for all the patients at Orlando, unlike Missouri, wherein only around 48% of the patients were tubularized in Missouri. So it is important to improve yourself and your skills with time. So introspection is very important. Yes. So, of course, those in whom we identified the tethering, those who were symptomatic and showed a decline in rehabilitation, screening MRIs were done. As you can see here, you could see the typical low-lying cords with adherent nerve roots. And of course, what did we do? We went ahead and detethered them, and we excised the inclusion dermoids. So there is enough literature emphasizing on the prevalence of secondary tethering and inclusion cysts after fetal surgery, but none of them really discuss neurulation or tubularization. So this also leaves us with the question that what is the best dural substitute, what is the best skin substitute then to prevent all of this? I'll leave some suspense. Do read my article. It has been published in Child's Nervous System. Hopefully you'll get some more clarity after reading that. Another separate extension of this procedure is the use of ETV or endoscopic third ventriculostomy in such babies. So as we know that no shunt is the best shunt, something which I would probably like to discuss in another talk. It's a very large ongoing study in North America and is showing wonderful outcomes and results. I would like to finally discuss and come up, finally this would bring us to the burning question of why this procedure hasn't in all these years worked in India. So has the new 2021 MPP amendment been too lenient? Has it probably made it easier for us to terminate such fetuses? So the MPP has now been extended to 24 weeks from the earlier 28 weeks. However, MPP of birth defects is not just an Indian practice. It is done in several parts of the world. Also, is it because that there are no skilled professionals? I think I spent the last few minutes deliberately discussing how doable this procedure is. And also, while maternal risk is of utmost importance, isn't it also very contradictory that we have no value for life in India? In a country with a bursting population of around 1.45 billion, terminating a child with an impending morbidity seems to be the most humanitarian and financially feasible option. So when there are so many whys, there's always going to be why nots. I strongly believe that this procedure will pick up in India, and here's why. So with an increased trend in late pregnancies and older mothers getting pregnant, this has resulted in an alarming rise of infertility in India amongst both men and women, making it a total of around 27.5 million. So we all know that fetuses start off as female, and it is much later that the testes descend. In males, the space left where the uterus could have developed is the space where many men stored the audacity. So in a country like India, it is extremely common to blame the mother for infertility or in fact any baby with a congenital defect. However, the GBD reports an alarming drop in fertility rate, making India account for around 25% of the world's infertility burden. So trimester 0 isn't just preparing the mother for a healthy pregnancy, but also the father. Yes. In fact, the National Family Health Survey reports that there has been an increase in infertility in men from 20 to 30% in 2016 to more than 50% in 2024. So experts put it down to the increasing trends in obesity, stress, and other lifestyle factors, which are of course going to keep getting worse in the coming years. I'm sorry, am I audible?
Yes, you are audible, Dr. Sheena.
Yes, I think I kept getting a call from the, yes. Okay, so however, the whole problem is also apparently solvable with the dawn of IVF and the advent of the precious pregnancies. And while the techniques have definitely advanced, there is enough evidence tying down IVF to several birth defects and congenital malformations. In fact, there is a five-fold increase in neural tube defects that has been reported in several articles all over literature. Yes. In most centers performing fetal surgery, there are very low numbers of maternal mortality. In fact, it was 0 in both the institutions that I have researched in as well. Yes. So this procedure is not expensive. It does not require any extraordinary medical equipment. In fact, it works out cost effective for the family with a healthier child rather than a morbid one. Morbid in the sense one requiring several shunt surgeries, revision surgeries, or being confined to wheelchairs with repeated hospital admissions in their whole lifetime. This itself goes against the concept of quality of life. So while I regularly face skepticism and criticism in promoting the need for fetal surgery in India, the bitter truth is that fetal surgery for spina bifida is the standard of care all over the world and also the need of the hour in India too. We have the ability to change the lives of such unborn babies and their families as well by reversing a disease. So here is our Wadia family. Yes. So it's not moving ahead. We have made this service official last year in the month of June 2024. I'm told it takes an average of 2 years to set up a fetal surgery department. I'm glad to share that we have over 40 ANC diagnosed fetal spinal dysraphisms in the span of 1 year. Yet unfortunately, we are still waiting for our first ideal fetal surgery candidate. I would like to conclude leaving you with more questions and thoughts to ruminate about. Here are my contact details. Do feel free to contact me if you need any assistance in setting up the program in your hospital as well. Thank you.
And I would like to call upon Dr. Savitri Shastri sir to give a talk on postnatal evaluation and treatment of spinal dystrophism.
Free Zoom as opposed to paid Zoom. Hi, good afternoon. I think Sheena's logged off, but this is in direct continuation of her talk. What do we do with the children who either for whatever reason do not get terminated and are diagnosed when they're diagnosed with a meningomyelocele, or what do we do with postnatally diagnosed children that we pick up on a screening? So my name is Dr. Savit Shastri. I'm a senior consultant neurosurgeon with interest in pediatric neurosurgery and minimal access spine surgery here at KIMS Kondapur. Now, fairly simply, we can classify neural tube defects into open defects and closed defects. Open defects are primarily meningomyelocele or myeloschisis, and these are failures of primary neurulation, which means that the neural placode itself is open. These are commonly associated with hydrocephalus and the Chiari malformations and profound neurological defects. Most children with meningomyelocele are paraplegic with bowel and bladder involvement, and they continue to worsen over time due to tethering, syringomyelia, or hydrocephalus. The evaluation for any child with a spina bifida, from a clinical aspect, we look at their sensory level, we look at the motor evaluation, look at the distal most voluntary movement that the child is capable of. We also look at anal tone and anal reflex. Radiology, of course, involves an MRI of the brain and the whole spine, a neurosonogram, and an ultrasound abdomen, and possible catheterization to look for bladder and renal involvement. For an open meningomyelocele, the treatment is fairly simple. Repair has to be done within 72 hours. Delay can cause meningitis or ventriculitis. More often when these children are born with open defects, and to be fair, I have not seen one in about 10 years now. But when these children come to us with an open meningomyelocele, we usually advise them to stop any amount of enteral feeding to avoid fecal contamination of the site. Saline dressing still we can plan for surgery, and perioperatively the surgery is very similar to what is done. Actually, it's the other way. the intrauterine surgery or fetal surgery is very similar to what is done once the child is out, where you basically excise the placode, you close it up, and you do a multi-level layered closure to prevent CSF leak. In addition, if the children do have hydrocephalus, we will also plan for a VP shunt. The goals are fairly simple. We want to protect all functioning neural tissue. We want to prevent CSF egress and bacterial ingress. And surgery usually involves excising the dysplastic skin and closure of the pile defect and the dura with meticulous, and skin closure which is imperative to prevent CSF leak. We also often use Limburg flaps or rotational flaps to be able to close large defects. And these are basically the steps of surgery, where we have the placode here that we dissect out completely. We make sure that all the neural tissue is completely separate from the surrounding tissue. And then we close it up and close the dura over it and the fascia and finally the skin. But what about spina bifida occulta? When we're looking at a fatty filum terminale, a lipomeningocele, split cord malformations, inclusion lesions such as a dermoid or a dermal sinus tract, neurenteric cysts and myelocystoceles, these are a completely different set of animals and which require a little more clinical judgment in terms of what to do and when to do it. At birth, the clinical signs that we would need to look for would be an asymmetric gluteal cleft, a capillary hemangioma, hypertrichosis of the spine in the spinal area, subcutaneous lipomas, a dermal sinus tract, or cutis hyperplasia. Now, some of these look like this. This is an asymmetric gluteal cleft. You have a capillary hemangioma, you have a tuft of hair, you have a subcutaneous lipoma, you have a dermal sinus, and I couldn't find a cutis hyperplasia, but this is a hemangioma of the skin. Spinal examination, in addition, is also carried out to rule out other associated anomalies such as a sacral agenesis or a caudal regression. Scoliosis, of course, is extremely hard to diagnose in neonates, and foot or leg deformities are also known to be associated with spina bifida. A urological examination, again, may not be at birth, but we often see children with recurrent UTIs, and we have found them to have had tethered cord, and these kids have improved substantially after detethering. Incontinence, again, is very hard to diagnose in neonates, but there are situations where these children may have overflow incontinence or retention. And as children get older, if parents identify that there's a delay in toilet training, then this could be a reason. Of course, these are the symptoms that we look for in infants, toddlers, and older children. There was an interesting study from Japan that looked at what was the percentage of document or MRI positive spina bifida occulta based on what was seen clinically. So when we looked at a hemangioma or a subcutaneous mass or a skin tag or a burn mark and a gluteal cleft and so on and so forth, the least was the sacral dimple. And that's very important to note that while we all identify sacral dimples fairly early on, they are the least likely to have any association. Now, routinely in our hospital, we do get ultrasounds done for all patients who have even a suspected sacral dimple, and we found most of those ultrasounds show that the cord is in the normal position. So, sacral dimples are the least. The more significant ones are stuff like a tuft of hair, a subcutaneous lipoma, an obvious dermal sinus, which is far higher than the intergluteal cleft, and so on and so forth. Radiological evaluation most commonly is done with an ultrasound because it's cheap, it's easily available, but unfortunately it's not easy to interpret. The things we look for are a low-lying cord, the presence of a lipomeningocele within the vertebral foramen. We look at split cord malformations, and of course we can also do a neurosonogram to look for hydrocephalus. Now, if we remember all of these abnormalities that we saw, this is what all of them look like on ultrasound, right? So, most of them show a lipomeningocele where you can see a bright, a bright hyperechoic fat cleft over there with the presence of a sinus. This again it shows a low-lying cord with a lipomeningocele. This is a split cord malformation where you can kind of see two hemicords over here. This is a tethered cord, and very interestingly, some studies have shown that you can do an M-mode ultrasound and you see loss of pulsations of the nerve roots. And this indicates that these roots are tethered and they're not free-floating in the spine. Again, this is a dermal sinus tract where you can clearly see a hypoechoic tract extending from the vertebral foramen right up to the skin. And finally, another case of a split cord malformation. Plain radiographs are largely for, a theoretical purpose. We would still use them as spine surgeons to look at hemivertebrae or block vertebrae in children with scoliosis, but more often than not, we don't often do them. MRI, of course, is the investigation of choice to plan intervention. The points we look for, this is an MRI of both the brain and the spine. The points to look for would be hydrocephalus, a Chiari malformation, at what level of the conus, at what level is the conus, specific abnormalities such as a lipomeningocele or a myelocystocele and so on and so forth. And in some situations, we would ask for a prone MRI if there is a significant clinical suspicion of tethering. However, a supine MRI looks normal to us. In a prone MRI, again, a normal spinal cord, a normal phylum terminal and a normal chorda equina would fall down with gravity. If it's tethered, it stays stuck to the dorsal surface. The commonest lesions we would see are a lipomeningocele, which is basically some amount of fat that is tethering the cord to the subcutaneous tissue. This may be the defect runs from the through the spatial layer, through the spinous processes and the dura. The lipoma cord interface is often pulled out of the spinal canal, and this is due to traction, which again causes tethering. Now, these are the simplest types of the dorsal or transitional, where there's a clear line of demarcation between the neural tissue and the dorsal and terminal, where there's a clear line of tissue. Transitional lipomeningoceles are often also called chaotic lipomeningoceles because the nerves, the fat, everything is one big mess, and it's very hard to distinguish the two. This is what a typical MRI would look like. Fat is bright on both T1 and T2 images, and you can see that it's stuck to the cord and coming out of the spinal canal. A very easy thing to deal with is the lipoma of the phylum terminal, which again is diagnosed if the phylum terminal is more than 2 millimeters in size. And on T1 sequences, it's bright white. It's associated with a sacral dimple, also associated with the Vater deformities and sacral agenesis. A split cord malformation is again something we see commonly, is where the cord itself is divided into two. It's of two types. Type 1, where there is a bony spur separating the two hemicords, and type 2, where there may be a fibrous attachment between the two cords. Dermal sinus tracts are also common. We've seen everything from the occiput down to the sacrum, where we see a dermal sinus tract, and these sinus tracts extend from the skin right up to the neural tissue. They may be associated with dermoids or epidermoids or teratomas at their termination. These children commonly present with recurrent meningitis, either chemical, because there may be a dermoid or an epidermoid within the neural elements, or bacterial infections. Meningoceles are some things that get missed on prenatal diagnosis fairly commonly because they tend to be small and they also do not tend to have any neural tissue. They're simply collections of CSF which will occur through a dural defect, and these are fairly easy to treat. A rare thing that sometimes go to our colleagues in pediatric surgery as an abdominal mass is an anterior sacral meningocele, which presents as a large pelvic mass. And it's important to look for a communication between the spinal canal and these lesions, because if you go in ventrally and remove the lesion, you create an iatrogenic CSF leak, and then CSF starts pooling in the pelvis. These have to be repaired from the posterior aspect by going through the L5-S1 space or even the sacral lamina to be able to identify the defect and repair it from within rather than excising the pelvic mass. Now, what do we do with these children who we've diagnosed with a spina bifida occulta? Do we wait and watch, or do we perform surgery? What would be the indications for surgery? And most importantly, what is the timing for surgery? And that is something that we often have to kind of decide what's the best thing to do for these children. The goals of surgery are to address hydrocephalus if present, is to detether the cord, which means to free the cord from wherever it's stuck, to decompress the cord by excising any cysts or lipomas which may be compressing on neural tissue, to preserve all the functional neural tissue available, and in all of these situations, we would always push for being slightly more conservative than radical. It's better to consider doing a second surgery for retethering than having to deal with a child where we've caused a neurological deficit by chopping through a lipoma and cutting the cord instead. Symptomatic infants with either orthopedic or urological syndromes need intervention. There is no second this thing about that. We would also advise detethering prior to any kind of scoliosis or deformity repair, because that deformity repair in itself causes traction on the neural tissue. But what about asymptomatic neonates or infants who are diagnosed with tethering on screening or have cutaneous stigmata and then have undergone evaluation and we found that they have a spina bifida? Option one was what is traditionally followed, that we delay in any kind of interventions and symptoms developed. The rationale was that some children who are asymptomatic may never really develop any symptoms, so why should we actually subject them to any kind of surgery? The risk of surgery, of course, in infants is extremely high because they tolerate very little amount of blood loss, and there is a high risk of intraoperative nerve damage given that we are working in and around nerves. Option two is to consider intervention at the safest early surgery window, which is about 4 to 6 months or when the child has had adequate weight gain. The rationale for this is to do the surgery before there is any kind of growth spurt. And the reason to do that is all tethered cords will become symptomatic when the child grows. That is when there is traction on the nerves and the spinal cord, and as a result, that's when the deficits develop. The other rationale is all of the deficits that develop in children with a tethered cord are lower motor neuron type deficits. You're looking at foot drop, you're looking at sensory loss, you're looking at Charcot joints, you're looking at bladder and bowel involvement. These do not reverse after surgery. Surgery at that point of time is a damage control option to prevent any kind of further deterioration. So, which is why we advocate that surgery be done in these children at the earliest point where it's safe. Now, the reason to go ahead and promote surgery is the fact that with modern techniques, we are able to control blood loss fairly effectively. We do all of these surgeries under neuromonitoring, which means the risk of neurological deficit is extremely low. Of course, if the child already has a neurological deficit, that may or may not reverse, but we almost never add on a secondary deficit. And the only downside of a very early surgery, as Dr. Sheena said, is that there is a risk of retethering as the child grows. There are some special considerations for operating on these children. They're all done under general anesthesia. We aggressively avoid hypothermia at all costs. Intraoperatively, we look at meticulous hemostasis to literally chase down RBCs because we have a very little window of allowable blood loss. We try and preserve as much normal skin as possible because closure is often difficult in these children and their skin is so thin that the wounds often break down, so we have to be really careful. We do sometimes have our colleagues in plastic surgery come in and raise, rotation flaps for these children sometimes. We try and preserve and identify as much normal neural tissue as possible. This is done both visually and electrophysiologically, and we're able to stimulate individual nerves or suspicious tissue, and we look at recorded electromyographic signals from all of the lower limb muscles, including the anal sphincter, to make sure that whatever we want to cut is not active functioning neural tissue. The repair of dura is extremely important. This sometimes can be done primarily, which is ideal. Otherwise, we would use any kind of local graft that's available. This is a challenge in neonates and children, but there's a lot of subcutaneous fat that we can use for the repair. And finally, we have artificial tissue grafts or even bovine pericardium that we can use to augment the dural closure. A watertight facial closure and skin closure again is imperative because CSF leak can lead to postoperative meningitis, and postoperative meningitis in these children has a mortality of about 30%. Finally, this is one of our cases of a tethered cord where we have opened the lumbosacral junction and we're able to do this without actually taking out too much bone. The dura, we've seen that you can see the dura is opened, and this is a suture pulling on the dura, and these are the nerve roots, and this is the phylum, and you can kind of make out that it's almost filled with fat, and that is a fatty phylum that was causing tethering, and literally just disconnecting this is enough, and the surgery is done. Most of these surgeries are done in about 45 minutes to an hour, and the kids are discharged within 24 to 48 hours after surgery, and absolutely no restrictions on their growth. We do, however, tell all of the parents that if the child is born with one defect that we identify, there is a good chance that something else will crop up as the child grows. and retethering may occur. The child may develop new neurological deficits, and these have to be identified early and then treated. There's no point waiting till the child ends up coming back to us with a completely burnt out spinal cord. So when we intervene on these children, we make sure that the child stays with us on follow-up as long as the child grows. And then we've had children that we've operated on about 15, 20 years ago when I was a resident who have come back with adult retethering, where we've had to detether these patients as adults even. So it's important to have these children follow up, have these children be on follow-up forever. Of course, it's also impossible to do this without the support of a tremendous pediatric neonatology and anesthesia team, because it's really, really easy to do surgery, and these children will die if they're not taken care of after surgery. Finally, I'd also like to thank Dr. Sheena for giving that fantastic talk and for helping me in the last minute to do this presentation, because I just moved house 2 days ago. It's also why I'm in scrubs, because I can't find any of my clothes. So any questions I'd be happy to take right now.
Dr. Savit,
yeah.
Will you ever tell any patient or family, I'm not going to operate on your child?
Yeah.
Not for non-financial reasons.
I don't bother about finances. Yeah. If it's not going to help, I'm not going to operate.
Yeah.
Or if a child is sick and if surgery is potentially life-threatening, it may not make sense to operate on the child.
I'm talking about only neurological aspect.
Only neurological aspects. See, the thing is that
bowel, bladder,
the question is you have to be able to equate the expectations of the parents with the reality of the child's situation. We see this in adults as well, right? So if I have a patient that comes to me with a cauda equina syndrome, I'm going to tell them that there's very little chance that you can improve even with surgery. But however, if we don't do surgery, there is no chance that you'll improve. Now you have to decide whether that risk is willing to take or not. Now, with pediatrics, it's much, much harder, because parents often expect that any intervention will bring their child back to his peers, his classmates, their other siblings. They were fine. Why is this child going to be paralyzed for life? So it's important to have that conversation. And yes, parents may not be happy to hear that their children will not get better. Parents may not be happy to hear that all we're doing is damage control and preventing any further damage. But oftentimes they will find that, at least in the pediatric neurosurgery circles, nobody's going to tell them anything different. So they can go to multiple doctors and have the same conversation. There are about 10 of us who do pediatric work in Hyderabad. We all know each other, and we all tell them the same thing, that sure, we'll do this. However, I don't know if this is going to get better, right? So there have been instances where we have said, not for tethered cord, but I have refused to operate on a 6-month-old child with what looked like an atypical teratoid rhabdoid tumor. Because every time we've operated on these children, they live for another 6 months and die, right? The ATRTs are pretty much the worst tumor you can get in pediatric brain. So I've told them that there may not be any point doing it. And nobody likes to hear it, but I think our job as doctors is to tell them the truth. So yes, I have refused, not necessarily for this. I have had parents refuse to get operated, have their children operated by me, because I've told them this, that they won't get better. But I sleep well, so I'm happy.
But you still feel we should tell the full life story of that patient?
Yes, I think it's very important to, because they'll come back. All of them will come back. Right? They'll come back with retethering, they'll come back. The patient you were talking about, right? You'd had that sacral agensis patient who now has a cauda equina, a tethered cord. They're going to need detethering. They're going to need multiple urological reconstructive procedures. We see the same thing with craniosynostosis. We'll fix something when the child is 6 months old or a year old, right? And then 5 years or 10 years down the line, their face is finally growing, and the parents are like, we don't like what this child looks like. And then craniofacial has to come in and do an orbital advancement or a midfacial repair. So it's really cruel, but I call these children factory defects. And I tell them that it's like a car that has had a factory defect. We'll fix what we see. But as your car keeps running, there are new problems which are going to come up because the factory screwed up. So I think it's very, very important to tell them that they have to expect that as the child grows, we will see different issues. We see this in cranial a lot because say you have a child with congenital hydrocephalus, the first question is the child going to grow up to be normal? Right? I don't know. Right? Nobody knows at a 3-month-old if the child is going to be you or me or Sachin Tendulkar or A.R. Rahman, right? You can't predict those things. So you tell them very clearly, I don't know if this child is going to have a learning disability, but I know that if I don't operate, he's going to end up with a head this big. So take a call.
As Dr. Savit told clearly, the bottom line in all these correctable malformations is we have to tell them the full life story of that patient, something like be it for 70 years or 80 years. So you tell what are all the complications which are expected in his lifetime, so that actually they'll be coming back to us. Actually, that's why we play a significant role in doing a proper antenatal counseling, because we tell them everything. Actually, if at all, if you don't get it operated, if you get it operated, what are the sequelae, long-term sequelae, all these things we should be discussing in detail. Only then the patient will have confidence in you. So that is our bottom line. Actually, we should be very clear.
Yes, ma'am.
Would you offer detethering if the neurogenic bladder component has already set in?
Yes.
You would.
It might turn around. Bladder is a horrible thing, right? You don't know if it's UMN or LMN. You don't know if it's going to get better. You don't know if it's going to get worse. You don't know if they're going to be catheter dependent. You don't know if CICs. Nobody knows. But I've had a child, Dr. Durga's not here, but he was seeing a child who had recurrent UTIs for whom we did a prone MRI. The child had an absolutely normal MRI, but Dr. Durga was convinced that there was something off. And we got a prone MRI, and the phylum did not move. And we went ahead and did a detethering, and he's like, our urodynamic numbers are getting better. So it's definitely worth it. I would operate on a child if he had a club foot and foot drop as well, because you don't know if the other side is going to get affected down the line, right? It makes sense to give them a chance.
Neurogenic bowel bladder we've seen have worsened. Like not because of the tethering or detethering. So it's an eventuality.
Bowel usually regulates itself down the line.
We do manage it.
Yeah, bowel manages to regulate. There is an internal neurological system in the bowel. Ultimately, with diet and a regular habit, the bowel sorts itself out. The bladder requires significant urological rehab, and more often than not, the only thing that really ends up working is CIC.
The bladder is an issue because all these kids are born with normal kidneys.
Yeah, no, the only thing that works is CIC. The problem is not the detethering. The problem is nobody does CIC. Nobody teaches CIC.
We do.
You teach it, right? I tell everybody to wear a seatbelt and wear a helmet. Nobody does, right?
Yeah.
So
the idea of getting the pediatric surgeon into it.
Yeah, so they'll have to tell us what they can do. But at the end of the day, you can, if it's a small bladder, you can make it a big bladder. If it's a big bladder, you can make it a small bladder. Ultimately, you have to drain the bladder regularly, right? So whatever surgical procedure is done, and I used to be a general surgeon at one point, so this is stuff that I've actually studied. But whatever surgical procedure is done, you still have to do CIC. You still have to teach CIC, because at any point of time, if that gets missed, you're going to have backflow, renal damage, and then they're going to come back with an elevated creatinine, which may not reverse.
Sure.
Right, so detethering is not the cure for neurogenic bladder. It's just one additional thing that you will have to do. Because if it is a UMN bladder, it might change. If it's an LMN bladder, it probably won't. And in neonates, it's very hard to distinguish a UMN versus an LMN bladder because you cannot do a useful urodynamics on them. So, or in infants even. So at this point, I would say detether and see what happens.
Thank you. Thank you, Dr. Savit.
I think there's another question.
I actually wanted to just see if we can connect back to Dr. Sheena as well. Are you there, Dr. Sheena?
Yes, I'm right here.
Hi, excellent talk. This is Aparna, neonatologist. I'm part of Vishwanath's team. So, okay, hi.
Hi.
Excellent talk. So, Dr. Sheena, with so much of experience that you have had on fetal interventions, and it was really exciting to see that the work that you do. I'm sure with the kind of mindset and the limitations that we have in a country like ours, where these things are still yet to kick off the way they should. What is the one sort of message you would like to give to an obstetrician or to a family
with a neural tube defect diagnosed antenatally, where you genuinely feel a fetal intervention can make a lot of difference, what would be that one thing? And also, are there, I'm sorry, I mean, I think I missed the first half of your talk, but are there those definite indications, definite sections, categories of neural tube defects which you feel would definitely benefit from fetal interventions versus the ones that otherwise would generally go in for termination? That's the question I had for you. And Dr. Savitri, if you recall, we had a child with bilateral VUR and tethered cord. So the question that mother kept asking is, would you recommend both detethering and ureteric reimplant at the same time? The child was being posted for ureteric reimplant in other hospital, had come around for an opinion specifically from the tethered cord point of view. So would you recommend both at the same setting versus one?
Same sitting, maybe no, but within a couple of weeks of each other, sure. I mean, it depends on how old the child is, because one surgery has to be done prone, the other has to be done supine, right? So I would probably say, do the ureteric reimplantation, save the kidney, and then detether. Because whatever neural tissue is damaged that's causing the kidney problem is likely already gone. The kidneys at this point of time will require to be saved. So every case is going to be different. You will have to decide what is feasible and what's not. So I would say in this particular child, fix the kidneys, then but because at the end of the day, you can reimplant the ureters, and if you can get them out of the bladder, great, it'll make sense. But then you still kind of want to prevent the possibility of a foot drop. The nerves to the bladder and the hypogastric plexus aren't the only nerves out there, right? So you would still detether to make sure that no fresh problems happen. But that would be secondary to saving the kidneys.
Yes, thank you for your question, ma'am. One thing I would like to emphasize and would like to make the obstetricians aware is
Ma'am, please continue. Ma'am, you're on mute. Dr. Sheena, ma'am, you're...
Hello. Oh, I'm so sorry. Am I audible now?
Yes, ma'am. Yes.
Yes. Fetuses with any sort of spinal dysraphism can be diagnosed as early as around 15 to 16 weeks of gestational age. So unfortunately in India, because there is no standardization, the sort of ANC ultrasounds which are being done in villages and in smaller centers, I mean, a lot of these findings are missed. And most of the time, the challenges which I have faced in the first year of starting this program is that the diagnosis has been late. It has been after 26 weeks when you can't even offer any sort of fetal surgery for them. And then it's also too late for MTP. So then they just proceed with the pregnancy and then we offer them postnatal surgery. So I think vigilance is very important, and I think now there's so many better imaging modalities like fetal MRI. We usually advise a fetal MRI as soon as we diagnose there is a query, there is a doubt of maybe just probably ventriculomegaly. I think the obstetrician should be a bit, they should skip, even though there is just ventriculomegaly on the ANC ultrasound. We have seen children being born with a spinal dysraphism, and it has got missed on the ANC ultrasound. It has got missed on the fetal MRI, which was done in a center outside. So I think there are a lot of things which are still like a work in progress in India. But yes, vigilance, I think, is something which I would like to emphasize upon. I think we need to be more vigilant. As for the patient population, it's very hard to convince the Indian population. What you asked was a very good question, that how are you going to convince such parents for fetal surgery? It is a very tough proposition, telling them that the mother requires a surgery, 2 lives are going to be at risk. Yes, that has been a pretty tough adventure so far. We have had, like I had mentioned, around 40 patients. Out of that, around 20 were even willing to proceed with fetal surgery. You need a very good team of counselors. We have a palliative team on board as well. Our obstetricians are on the same page as us. because we have had obstetricians from other hospitals who have counseled them directly for MTP, or just like your child will be on a wheelchair for the rest of their life. That your child is not going to be able to go to school or study, or his cognition is going to be poor. So that's not necessarily true. There is no literature yet. I mean, we're still figuring things out. So yes, and what was your second question? I'm sorry,
Any specific indications where fetal interventions definitely work among the big basket of neural tube defects?
So myelomeningocele and myeloschisis, whether it's small or large, anything between the level of T1 to S1, and also if there is an evidence of KRE2 malformation, there are a lot of centers which are also operating on encephaloceles, whether they're occipital or frontal encephaloceles. Hydrocephalus at one point was also tackled with antenatally, but of course that was abandoned because the procedures didn't really have very good outcomes. They were doing these ventricular amniotic shunts, putting pigtail catheters that did not work out. In fact, a lot of centers actually, when there is a child with a head circumference more than 40 centimeters, and say the family is insisting on a normal delivery of the child, they do ventricular, they aspirate the excessive ventricular fluid percutaneously. So yes, these are the procedures which can be done, but of course they are not being done in India as of now.
Thank you. Thank you so much, Dr. Sheena, and thank you, Dr. Savit.
Dr. Sheena, I am Yovnagin, the pediatric surgeon. I am very much interested in fetal surgery. Actually, at one point of time, actually before I die, I want to do one successful fetal surgery. That's my lifetime wish. I will. In the floor, actually, we have one doubt. Means in a meningomyelocele case, actually, if you have not operated just few weeks before and operated on the day 1 or day 2, how is it going to make any difference? Means, for example,
you mean to say we operate them postnatally?
Yes, postnatally. Because anyhow, we are going to operate almost in the newborn period itself. First 4 or 5 days only, most of the meningoceles are being operated, or meningomyelocele. And if it is ruptured, definitely on day 1 itself we'll operate. And no, so for example, actually, like what actually we are asking, suppose if it is a diaphragmatic hernia, yes, by doing that, you are allowing the lung to grow. In the coming few weeks, lung will grow in a fetal surgery. In meningomyelocele, actually, how is it going to make a difference? Because after closing MMC, we have a fear that actually there can be increasing hydrocephalus.
Dr. Sheena, may I?
Yes.
Yes,
no.
Yeah. So there was a study that was done. The entire management of meningocele trial, which was the MOM study where fetal neurosurgery started, was the basis of that trial was a bunch of animal studies that showed that the longer neural tissue was exposed to amniotic fluid, the more it started getting damaged. And the reason to do fetal neurosurgery that early is to prevent that damage. These children that Dr. Sheena had showed that were walking are open neural tube defects that were repaired intrauterine. Open neural tube, if they come till term, they do not have any functioning neural tissue. So most of these children are paraplegic. Most of these children have bowel and bladder at birth. So the reason to intervene on these children as early as the US groups are doing is to actually have these children walk. Because the first MOMS trial that came out, they intervened much later because they were worried for these children to be, they wanted the fetuses to be an adequate size and so on and so forth. And they found that while there was no change in neurological development, the only difference was in the need for a VP shunt. So children who underwent fetal surgery in the first arm of the MOMS trial only showed reduced requirement for a VP shunt and reduced incidence of hydrocephalus, whereas had the same neurological outcome. Then they started intervening earlier, and they found that these children have good neurological outcome. And that is the reason to consider, like I said, if we are intervening after birth, we're doing damage control. Everything is done. The nerves are dead. The placode is non-functional. We're just closing it up, make sure that whatever CSF the brain produces stays inside the body and doesn't flow out. That's it. Unruptured sac, it doesn't have to be done fetally. You can do it whenever you want, right? But unruptured sacs, if unruptured sacs are a bit of a fallacy, it basically means some epithelialization has happened at some point of time intrauterine. they are still meningomyelocele. The difference there is in imaging where you see an open neural placode. So if there is an open neural placode, it has to be closed. Right. A meningocele, which is intact neural elements and just a dural bulge, is not a problem at all. Right. But an open meningomyelocele, we actually don't call them open and closed as much as we would say ruptured and unruptured. Right. Those have to be fixed ideally intrauterine.
And also, sir, it helps to reduce the rates of shunt placement because there is the hindbrain and the brainstem kinking, which you see due to the Chiari-2 in such babies, that gets reversed. There's a good rate. There's a good reversal rate, and that itself helps to reduce the rates of hydrocephalus as well. So that's another morbidity we're trying to reduce antenatally itself.
Yeah, sorry. Yeah, that's one of the reasons for hydrocephalus. Again, there's aqueductal stenosis is also known to occur with these children. Again, if you have a problem somewhere along the neuraxis, there will be a new one somewhere else. So yes, the Chiari malformation reduces because there's no traction on the hindbrain. So that reduces the incidence of Chiari-related hydrocephalus, but doesn't change the rates of aqueductal stenosis.
Sir, can you please explain, how do we prognosticate the cases with fetal diastomatomalia? Like what a parent must know about the postnatal implications?
Fetal diastomatomalia, I mean, most kids with diastomatomalia will be born normal, right? They will grow up to end up having deficits unless, now the funny thing about diastomatomalia is it's a part of a bigger problem that there have been instances of each hemichord having its own abnormalities. So you can have a lipomeningocele on one hemichord and a neuroenteric cyst on the other. It's extremely rare. But diastematomalias are often not isolated instances. If there is no associated open neural tube defect and it's just diastomatomalia, more often than not these kids are born normal and then they need early intervention. So we will have to consider doing the detethering. It's if it's a type 1, it's a difficult surgery, because you have to remove this piece of bone between two spinal cords, which is not fun, but it is possible. We've done it, and the big problem with diastomatomalia is if left untreated, a lot of these children come to us with scoliosis. Right? They come to us with tethered cord, the problems with tethered cord, they come with neuromuscular scoliosis, and that becomes harder and harder to treat as the kids get older. So I think from a prognostication perspective, anything outside of an open neural tube defect is dealable postpartum. Okay. Anything that is a neural tube defect has to be referred to Wadia Hospital.
Okay, thank you, sir.
So thank you so much.
Thank you so much, Dr. Savitha sir. Please, just one second. I request Dr. Aparna ma'am to honor Dr. Savitha sir with a memento.
What is this honor?
Thank you, Dr. Sheena, for joining us. Panel discussion, I request to join with us Dr. K. Venkatapriyanka, Dr. Ankita Chauhan, Dr. Mandakini, Dr. Vishwanath, and Dr. Deepthi with us.
As already we are at the back end of the day and all of us are so tired, and after a detailed session with the fetal surgery and all, we are all geared up. But I'll try to make it as brief as possible. Frankly speaking, actually sometime back I removed most of my slides. So that actually things should be very soft, crisp and sweet. And we'll try to take some take-home messages more than actually discussing all these things. So maybe I won't be doing a very good panel discussion type, but I will try to see that all of us get some take-home messages. Actually, frankly speaking, these panel discussions are not meant for us. It's meant for youngsters. Actually, I'm seeing so many young people actually along with us. So genitourinary malformations, they make around, actually truly speaking from pediatric surgery point of view, actually it make around 50% of our work. But coming to the malformations wise, it will be around 20 to 30% of the malformations, correctable malformations that we see. So whether it is correctable or not, whether we have to take these cases or not, actually we will decide. So coming to the genitourinary, actually I have jotted down some, starting from the kidney to the prepuce. So so I will try to take you through some, he's going to take some more time. Actually in the meanwhile, I'll ask some random things actually which is useful for others. Dr. Vishwanath and Dr. Mandakini, both of you. So if at all, if phimosis is there, when do you call it physiological, up to what time? Of course, we are talking only about neonatal period here, but truly speaking, actually, so many pediatricians are also there.
So phimosis, if we see it in initial newborn period, we don't intervene much. We have some conservative management. We try to apply some topical steroids for it to improve. And unless it is causing any severe issues with the urinary flow, then we ask them to come back on a follow-up, and then we grade it as phimosis. I mean, I'm not very sure about a particular time where we confirm it as phimosis.
Yeah, Dr. Mandakini.
So, the relevance of phimosis with respect to genitourinary obstruction, I would like to speak about that. So, like say there's a child with posterior urethral valve, then I would be worried if he has phimosis or not. So it is important to understand whether the skin is, because less than 1 year all these boys are high pressure voiders, so they would exert pressure and things, so the chances of UTI is a little high. So I would address the preputial skin by probably asking the mother to put a bit of coconut oil or probably giving some low dose steroid cream so that they don't exert much pressure. Second thing is solitary kidneys, with reflux. So you would like to address the phimosis issue or advise circumcision in them at an early stage. Physiological phimosis, well, if there's no complaint, we can wait up to 3 years, sir.
So what take-home message is actually, usually it is physiological, no need to do anything. No need to only if it is leading to some obstruction or something, actually maybe we may have to intervene. So before he opens, actually again about the circumcision only. So for example, actually Muslim, he wants to get it circumcised. Actually, what is your advice and what are your contraindications, Dr. Vishwanath?
I mean, if it is really indicated and causing contraindications, I mean, we do. If there is any underlying bleeding diathesis, then it is a contraindication for circumcision.
Yeah, hypospadias is the contraindication for circumcision. Yes, correct. So, so coming to the actually what you said is correct. Actually, if at all, to prevent urinary tract infections also, there are indication for circumcision, and still he's taking some more time to open. So urinary tract infections in children is one other common problem that we all of us see. So urinary tract infections are also actually we have to evaluate, and then we'll be seeing other conditions as well. And coming to the fetal medicine, what are the conditions actually? We are going to talk about the kidney to start with. He's taking some time, sorry. So kidney, what are all the things that you expect and what do you want to give to us as pediatric surgeons or pediatric urologists? What are the things, what are the parameters?
Yes. Previously, there is a dilemma in both in the grading the system and also regarding the management part. Why? Because previously the grading is as mild, moderate and severe. Nowadays, after the consensus which has come by the American Society, it's a group of almost like 9 societies which came together and have given a CACUT consensus, which is, they gave a single entity called as urinary tract dilatation, the CACUT. So after that, it has become very easy, both in a ways of for the fetal medicine specialist and also the neonatologist, as there is a combined classification which has come together and they have easily classified. they have classified as UTD A1, A2 or 3. So UTD A1 is the best thing and which is the commonest thing which we come across every day during our routine scans or the target scans which we do every day. Why? Because almost all 70% of the times or 80% of the times during the, particularly during the second trimester, what we see is a transient urinary tract dilatation which we call it as pelviectasis. So this is the most commonest scenario which we come across. Also to counsel them particularly it is very easy. Why? Because there is a rule of 80, 10 and 10. 80% of the mild pelviectasis, that is the UTD A1, these people have a very good prognosis because most of them resolve antenatally itself. And the most commonest cause of this UTD A1 among these people is 80% of the times it is due to just the maternal relaxation effect. That is the progesterone hormone effect. The other part, which is UTD A2 to 3, those are the cases which we put in a follow-up. UTD A1, we just put a follow-up at 32 weeks and we are done. But whereas in a case of UTD A2 to 3, what we do is we have to call them back every 4 weeks or maximum by 6 weeks, and we continuously look into the following checklist. In the fetal medicine, in our unit, we follow a proper checklist for KUB, which we do antenatally, sir. In that particularly whenever we see some case of UTD, what we look into is first of all the size, renal AP diameter size. Also along with that, what we look into is the dilatation of the pelvis, calyceal system, we also look into the renal parenchyma, whether there is any thickening or any thinning of the renal parenchyma. Also we see into this echogenicity. Also we particularly see the ureter. Ureter is not at all visible in the antenatal scans. If at all the ureter is visible in antenatal scan, it is pathogenic. So we look into the ureter. Also the main thing is the bladder. Bladder particularly, we look only 2 things in the bladder antenatally, that is the dilatation, that is the size of the bladder and the wall thickness. And the most important is the amniotic fluid, which we look into. Any case of renal abnormality or any case of UTD, we follow up with this checklist as a whole. Then only our examination is completed.
As our fetal medicine specialist told, looking at the KUB completely is the key. Sometimes actually they'll be looking the ureteric jet into the bladder also. And sometimes they'll be seeing if the baby is passing urine also. But unfortunately in this era actually we cannot tell whether it is a boy or a girl. But all these things are very important, and then only we'll be able, she'll be able to give a necessary knowledge which is required for us. So I'll just take you through a few of the case scenarios, and this is a case of antenatally detected at, it is on follow-up, but yesterday he came to us actually telling the 32 weeks, at 32 weeks it is a 23 mm pelvis, and at 1 month it is a 29 mm pelvis, AP diameter of pelvis. At 6 months it is a 6 months postnatal, it is a 35 mm pelvis, and so actually they will see them. So actually you want to see that, actually comment about it in 1 minute.
Yes, what I can see there is a unilateral kidney which is dilated. Also we can see a central dilatation with peripheral thinning. So in the antenatal scan we give this only as UTD A3.
So actually along with that, actually we have put the report on the left side, it is 23 mm pelvis, and this is what is the finding. So this is the sequence, actually 23, 26, 29.6 and 35 and 43. Dr. Vishwanath, actually you want to comment about this one?
It is progressively increasing. So if antenatally there was feature suggestive of lower urinary tract obstruction, we would right away go ahead with MCU scan in the initial neonatal period before discharge. And if there was no LUTO and the presence of hydronephrosis and associated oligohydramnios antenatally, then based on this APD diameter, we can manage when to do MCU around 4 to 6 weeks, and then based on the reflex, we can decide on antibiotic prophylaxis and the renal scan to assess for the renal functions. So probably here the APD diameters are quite, it is progressively increasing. So would require renal scan and then, surgical management for the dilatation?
The bottom line from this slide is, as you can see, so much of delay has happened in this patient, which is very unfortunate, and literally we must have lost so many nephrons. So, Dr. Deeti madam, you might be seeing, ureters, not much of current is there, and the previous scan actually it is a bilateral hydronephrosis, and the opposite side kidney has resolved, as we can see. Unfortunately, I'm sorry, actually you are not able to see. That's what actually basically he did not comment about the ureters, and he did not comment about the opposite side kidney also. Maybe it must have resolved as.
Seeing this scenario, we can see the APD diameter is progressively increasing, sir. So we have to see what the function of the kidney, whether it is functioning or not. So whether the functioning obstructive or non-obstructive pattern we have to do immediately. In this, we have to go for renal renography, sir. Diuretic renography is the modality of choice, which can differentiate whether it is obstructive pattern or a non-obstructive pattern.
Sorry, you are not able to see. I'm so sorry for that.
No issues.
Or if you can just come this side. Dr. Mandakini, actually, as you can see, actually in the top one, actually he has written MCUG, there is no reflux. It is unfortunately seen by pediatric doctor only. He has written actually MCUG, there is no reflux. You saw the next test which was done. There are no ureters which are dilated. MCUG is not there. But unfortunately, he ordered for a DMSA. You think that's the right move?
Like considering the antenatal scan showed bilateral hydronephrosis, though unilateral was progressing and one side resolved, I would still go ahead and do MCUG first, sir. I wouldn't do a DMSA scan. My next choice of test would be a DTP.
Actually, that's true. Here, DMSA is unnecessary wastage of money on some poor patient.
Yes.
Some 6,000, 7,000 rupees wastage. And just because it is available, we need not order that. So now, can you just comment about this DTPA, EC scan? Just we'll talk about the graph only directly.
Yeah.
Yes.
So it's a upslope only, sir. It looks like a left pelviureteric junction obstruction. Even the delayed film, you can see the tracer that is like there's traces of tracer in the left pelvic calyceal system, and then there's no downslope of the graph at all. It's definitely obstructive.
As we can see in the this kidney is empty, this kidney is filling. That kidney is filling. There is a block. It is clear cut, and like Dr. Vishwanath told, there is progressively increasing block. There is no point in waiting. Let us save the nephrons, and the next right choice is
Laparoscopic or maybe
whatever it
robotic
is. Actually, remove the
Yoganathan.
obstruction and then relieve the problem, and then go ahead with the pyeloplasty, and whichever you want to do, minimal invasive or robotic or whatever it is, just go ahead with the pyeloplasty. So key in all these PUJ obstructions or anything is, even if the ureter is not dilated, then also you have to go and get one MCUG, because we want to be safe throughout. So hydronephrosis, it has got its own treatment protocol to go. So what do you advise, doctor? Shall I go for termination?
See, I will definitely ask them to take a second opinion, to take the opinion from the pediatric urologist, because postnatally, even if they plan to continue the pregnancy, the treatment has to be given by the urologist. So the prognosis of the baby after delivery will help making us a decision whether to continue the pregnancy or not to continue the pregnancy. If the cause is treatable and the prognosis will be good, then definitely they have to continue the pregnancy. And one more thing which I believe in India is very important, the financial burden which these kind of diseases brings, and along with that the emotional trauma it brings to the patients or the parents. If the parents are ready to bear the financial and emotional burden, yes, they are all set to go. I have had patients, and this is I'm telling from my personal experience, I have had patients, they were told that the prognosis of the child is very bad, even if we operate, and it will be like financially very draining, but the parents had a mindset, no, whatever the case be, we will continue the pregnancy. So it is again, it is their call whether they want to continue the pregnancy or they don't want to continue the pregnancy.
Yeah, you said actually after the antenatal counseling, let them take the call.
Yes, definitely.
Yes. Now Dr. Deepthi will give a diagnosis that it is bilateral obstructive mega-ureter. Bladder is okay. Actually, ureters are grossly dilated. You will be giving a dilatation at upper level, mid-ureter, lower level, just near the VUJ junction. Dr. Vishwanath, actually, how will you evaluate this patient in the newborn period, and when will you hand over to us?
So after initial clinical examination, we would like to see if this hydronephrosis is associated with other systemic issues like cardiac anomalies or other anomalies. And then if there is any genetic association, we would go ahead with genetic testing, and obviously will involve pediatric surgeon at that point to get further evaluation. We'll get an ultrasound done, and then MCUG to see where is the level of obstruction and all, and then plan further.
Dr. Mandakini, how will you evaluate bilateral? First, we should confirm if it is bilateral obstructive mega-ureters.
So bilateral, I would definitely do a micturating cystourethral.
When?
Immediately. Like first, I would get an early scan. I wouldn't wait for 5 days. Postnatal immediate ultrasound to look for whether it's bilateral or unilateral. How is the bladder, whether it's a boy or a girl, how is the bladder, and then look at if it's a preterm, if it's a boy child, I would still go ahead and get a scan done and look at the creatinine levels. First, my diagnosis would be a bladder outlet obstruction, secondary to posterior urethral valve.
You will plan a EC scan?
No. So first, my thing would be an ultrasound. And then it would be like checking the creatinine. If the creats are high, catheterize, get a MCUG done at the earliest, arrive at a diagnosis, and then go ahead.
MCUG is negative, no reflux, obstructive mega-ureter. EC scan confirmed, obstructive mega-ureters. Then what will you do?
I would just, obstructed mega-ureters, I'll look at the creatinine. I'll look at the creatinine and then decide what to do. If the creats are normal, I just wait and watch and see how the child is doing.
That is one school of thought, but actually both the kidneys are at toss. Actually, we don't want to wait. So doing a bilateral sobers or ureterostomy so that the bladder cycling will keep happening is also one school of thought, so that actually kidneys will be saved. That is one school of thought. Actually, we have done actually myself and Davanesh, we have done few.
What is the idea of doing a sober when it is an obstruction?
Basically, we don't want to allow more nephron loss. That's the only reason, so that just to save the kidneys, because it is a bilateral problem. Whenever bilateral is there, actually, I personally feel that actually we have to handle them in a different situation. If it is a unilateral, yes, actually you can as well wait because you have one more standby. But here, maybe because we don't have, we can go for that. Actually, basically what I want to tell is actually we should have to do a sober so that the bladder should keep on cycling, or else actually ureteric implantation is going to be a big mess actually later at 1 year of age. In the meanwhile, actually kidneys and ureter's size also will decrease. Then we can do a dielectric ureteric implantation at some point of time. Just coming, just 1 or 2 slides actually we'll finish. Actually, renal agenesis. What will you do, Vishwanath?
Yeah, unilateral renal agenesis, it's babies usually have near normal, right? But with bilateral renal agenesis, then the prognosis is
bilateral God decides, so unilateral let us decide.
Yeah, they'll have a near normal lifestyle. Yes,
you're going to tell
we'll
them.
Get an evaluated with ultrasound and see if the other kidney functions, and routine follow up for the other kidney. And most of them they have good. Not major of issues they have.
So basically that's what we are telling. Actually, we are going to tell the family that actually it is a single kidney status. So take care of the kidney. Actually, whatever kidney protective things we are going to tell, we are going to tell the same thing. Same thing we are going to do with actually multicystic dysplastic kidney also. Literally we have it is like a single kidney status. And if it is increasing in size, actually then we will be going and proceeding with and what are the indications for nephrectomy in a multicystic dysplastic kidney, Dr. Mandakini?
History of UTI, sir, urinary tract infection, hypertension, and if the ultrasound shows increasing in size of the multicystic dysplastic kidney.
So every multicystic kidney disease need not be operated. That is the bottom line. Actually, spontaneous regression is a possibility in a multicystic dysplastic kidney.
And horseshoe kidney, Dr. Deepthi madam, actually, how will you evaluate this? How will you follow up this patient with horseshoe kidney?
Horseshoe kidney, the lower poles of both the kidneys will be fused, sir, which are anterior to the aorta. So in these cases, usually they will be asymptomatic also sometimes. But recently, we have seen few cases where they can come with congenital anomalies like PUJ obstructions and dilatation, ureteric dilatations. So anomalous course of ureters can also be there with the ectopic insertion into the bladder. So ultrasound is the first modality of choice, sir, for evaluating.
So
also one thing in horseshoe kidney particularly, sir, without doing a amniocentesis and doing till CME and whole exome sequencing, it's better not to continue. Why? Because there is a 30% risk of aneuploidies in these cases, particularly in case of horseshoe kidney, which is diagnosed
amniocentesis for all these
Yes,
cases.
sir.
Very good. Actually, what Dr. Deepthi madam is telling is actually, if at all, it's just a normal variant. If at all, if no aneuploidy is there, you just continue with the lifetime follow-ups. If no urinary tract infections are there, we can as well comfortably take care of these babies.
So, ureterocele is another condition. Actually, as we are running short of time, ureterocele is one condition. Actually, sometimes we'll be seeing, especially if it is a duplex moiety, and if at all, if it is seen, actually, what we'll do, this is ultrasound finding, and we'll be doing multiple punctures to start with, and if it is refluxing, then we'll be doing a ureteric implantation at some point of time. Posterior urethral valve, you want to comment, Dr. Priyanka?
So posterior urethral wall is one of the easiest finding, easiest diagnosis which can be made prenatally, which is by the keyhole bladder appearance itself on the ultrasound. But in the posterior urethral wall, these can be either complete or incomplete. So in case of a complete posterior urethral valve, these can present as early in the first trimester itself. Usually during the RNT scan, we'll be trying to look at the bladder. To look at the bladder, it is very difficult during our NT scan. We usually search for the bladder. But in case of these posterior urethral valve, which are very much of complete posterior urethral valve, they present with the megacystis in the first trimester itself. Also, we categorize them as the normal bladder diameter longitudinal diameter will be less than 7, which is normally during our NT scan. That is the first trimester scan, sir. Afterwards, if we see a bladder dilatation anywhere between 7 to 15, we follow up these cases not only for the progression, but also in a way that there are more chances of chromosomal abnormalities. If the more the bladder dilatation, the more the chances of being obstructive pathology than the chromosomal pathology in our antenatal diagnosis.
If a well-read family member is their mother or father, they'll ask, Madam, you are telling it's posterior, is it a boy?
So that is the reason, sir, we will not disclose. We'll only put the DDs in our report, but we'll never disclose this as a posterior urethral valve. We put as a DD as ureteric stricture, where you put all the whatever the possibilities are there in our chapters. We'll put all the DDs, but we never comment it directly as a posterior urethral valve.
So in antenatal counseling, actually, how are you going to tell it is a posterior urethral valve?
That's it, sir. We put all the DDs like strictures and all, but we never comment it as a posterior.
Sir, if the bladder is thickened, there's bladder outlet obstruction, so I'll tell him if it's a boy, these are the causes. If it's a girl, these are the causes. So we'll have to just wait and see what the sex of the baby is after the baby is born, and then we'll take it from there on.
Very rarely we have what are called as the anti-urethral valves also. Actually, they may be having a similar presentation, which we mean in the ultrasound, because in the urethra, it's still more difficult for you to tell about anti-urethral valves. So, Dr. Ankita, actually, the same patient, let us take it as 24 weeks old. Okay, she's crossing and she's coming to some 30 weeks or something like that. And bilateral hydronephrosis is there. It's a posterior urethral valve. Oligohydramnios is also there. So, what are your indications, and when will you plan the delivery for this patient?
In any of the anomalies, the mode of delivery is not going to change. Whenever we are quoting any of these problems, the mode of delivery is not going to change for me. It will depend entirely on the maternal condition, whether I want to go for cesarean or normal delivery. Only in cases of, I would say, severe oligohydramnios, if the mother is severe preterm, like very early preterm, and she has severe oligohydramnios, in those cases, I might consider a preterm cesarean section. Otherwise, I would just continue the pregnancy as long as possible, and the mode of delivery will depend on the maternal condition.
And below what level of AFI do you consider?
Like maybe 2 or 3. Nothing like anything more than 8 or 5, I would be 5, 6 is all good for me.
MRI can confirm this. And coming to the evaluation and actually Vishnu and Dr. Mandakini. So catheterization, what is your take on catheterization of this posturethral valve case?
Yeah, we usually don't catheterize in an ICU for if you are suspecting posterior urethral valve. We'll go ahead with renal function test. We'll assess the
When do you want to get the renal function test?
Because if the baby is not passing urine within 24 to 48 hours, we do it in first 48 hours, the creatinine levels and see.
So basically first we will ask the mother to see how is the urine flow. We'll ask for a documentation, actually show me the one urine flow. Then we'll plan for a MCOG, ultrasound and MCOG, and then actually we'll be coming up with a diagnosis of this one. And what about your take on catheterization?
I'll look at the serum creatinine first. If it is high, then I'll catheterize.
When do you get the serum creatinine done?
Immediately. The first day. The
day
day the baby comes.
Day one is maternal creatinine.
No, but if it's posterior urethral valve, I'll still get it done on the first day.
And you'll repeat on the second day also. And
then I'll decide on catheterization and I'll see if the creats come down or not.
So frankly speaking, as a pediatric surgeon or pediatric urologist, what we tend to do is actually we'll document a fall in creatinine. If there is a fall in creatinine, that means the block is at the posterior wall level only, and it is not at the VUJ junction. So if it is at the VUJ junction also, doing a primary fulguration is not going to give any result at all. So we will have to tackle the ureterus also in some way. So how we are going to tackle and all, actually because of shortage of time, actually we'll try to do that. We'll skip that. What we tend to do is actually do a MCOG. Before, this is the only condition where we won't wait for the urine culture report also. Directly we'll go for MCOG with little bit of antibiotics. And then we'll be doing the primary fulguration. And if, frankly speaking, the role of vasocostomy has become obsolete, and we are good. This is one last one, actually I'll try to focus, last one. One tricky case scenario. Frankly speaking, I saw this case, that's why I'm putting it here only in this hospital. So it was a 3-month-old child, non-palpable testis. Someone else counseled, okay, it will descend over 6 months. And now the child came up with right side scrotal swelling, and what should be our approach? Usually we wait for 6 months for the orchidopexy to do. So, but you are stuck the only other functioning testis is at stake.
As in the testis which is down is swollen, sir?
No, now Dr. Deepthi madam's role will come. Madam will tell, first thing we'll send for ultrasound, we'll ask madam, madam, what is it?
So it's non-palpable left testis and right scrotal swelling.
Right scrotal swelling.
So we have to, is there any redness or erythema changes are there, we have to see, sir. Whether it is a torsion testis or epididyma orchitis, infective focus.
So madam is going to throw light on whether it is torsion testis or not. If it is torsion testis, so we have to go sometimes against our own rules that you need not wait for 6 months and evaluate that patient. We have to document, means that's Dr. Vishna's role. You have to document on the paper, if at all, if any redness or swelling or anything is there, please come ASAP. As soon as possible, preferably come with a radiologist ultrasound report, and then we'll plan. And this is the case scenario you may have at one point of your time, which is not acceptable at all. And it is a non-palpable intra-abdominal testis. So that means that is also not working. This is also not working. So this baby is going to have a tough time in his lifetime. So it is better to evaluate and then keep a close eye on these patients with undescended testis cases, even in the first 6 months of life. So because of shortage of time, I will try to skip all these circumcision. So this is one point I wanted to emphasize. Labial synechiae is something that we often see, Miss, actually, I was, many people have referred to me, gynecologists as well, telling that actually there is absent vagina, absent this thing, actually get a MRI done, that get this thing done. So we discussed, in fact, actually that's why I'm not discussing here. So it is a simple office procedure. We just do it in our actually OP basis itself. Actually, we'll be doing the labial synechial release, and that is the permanent solution for this patient. Thank you very much. Actually, we'll skip it.
Thank you so much, Doctor.
Thank you very much.
Thank you so much, dignitaries, for joining us today. I request Dr. Aparna ma'am to honor Dr. Vishwanath sir. Next idanతా రెడీ ఉందండి. అక్కడ ఉంచండి. I request Dr. Aparna ma'am to honor Dr. Deepthi. I request Dr. Yoga sir also to join. Please. I request Dr. Aparna ma'am to honor Dr. Ankita ma'am and Dr. Yoganagender also please join. The delegate certificates is available in the reception area when the registration happened. Please collect them there. And thank you so much all the doctors and delegates for joining us and making this possible today.
Yeah, thank you all for joining and staying till the end. We also thank ISOPARB, IAPS, NNF for associating with us for this program, and hope that this program motivates and inspires us for more optimal management of fetuses with preventable, treatable birth defects. Thank you. Now I'll request all the KIMS faculty, Cuddles faculty to join us for a group photograph. We can switch off the LED screen. We'll have one photo with all the faculty and then one with all the